Introducing the casket, the crystal approach sinus kit that safely lifts the sinus membrane with a hydraulic lift system. The casket reduces the chance of membrane perforation. The patented cast drill creates a conial bone lid that keeps the drill edge from direct contact with the membrane. Casket ensures safer drilling by preventing sinus membrane perforation. Using the drill stopper makes it easier to adjust the drill depth. The casket features drill stoppers in 1 mm increments. It is possible to control the drilling depth precisely by using the stopper, which ensures safer drilling without the risk of perforating the sinus membrane. The hydraulic lifting technique of the maxillary sinus can facilitate the blood supply of the surgical site. The casket's membrane lifter is using hydraulic pressure to elevate the maxillary sinus membrane higher and wider. Consequently, it facilitates blood supply, which encourages the formation of new bone and the healing process. Try the casket that reduces the risk of membrane perforation to ensure safer surgery. Introducing the Asset Kit for narrow alveolar ridge split. The Asset Kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The Asset Kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out. Introducing the E-Z series. E-Z is a zirconia block made by Osstem implant. The E-Z was developed by our R&D specialist at Osstem implant. Our in-house specialist at Osstem implant developed the manufacturing process. Each product is inspected and completed through a systematic quality inspection. E-Z is a CAD/CAM compatible material that simplifies the process of creating zirconia prosthetics at the clinic. It can be fabricated in various dental restorations, including inlays, veneers, crowns, and bridges. Multiple prosthetics can be milled simultaneously with E-Z. The disc is in 98 mm diameter and has 7 different types of thickness, which means you can select the right disc according to the length of each prosthesis, so that the material can be used more efficiently. Meanwhile, the shape of the block that comes with solid metal mandrel is diversified depending on cases. In particular, if you want to fabricate a long implant or bridges, you can choose block type with the 25 mm height. With the E-Z HT, you'll experience natural-looking colors. With 3 different shades, A1, A2, A3. You can replicate the patient's natural teeth color. E-Star ZT has an excellent strength. Thanks to high flexural strength of at least 800 megapascal, you can fabricate stronger prosthetics for the posterior region that is susceptible to high masticatory pressure. Zirconia prosthesis material with natural-looking colors and outstanding strength. Try the E-Star Z series made by Osstem implant. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5. It's both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing Osstem Implants Hycil Plus. Hycil Light Plus is excellent at reproducing fine areas. Hycil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a Hycil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. Hycil Plus is highly hydrophilic. Hycil Plus has a short intraoral setting time of 2 minutes and 30 seconds. Hycil Plus offers a sufficient working time of 3 minutes and 50 seconds. Hycil Plus has a high elastic recovery ratio of 96.5% or more. Experience Hycil Plus for accurate and precise impression taking. Most patients need a solution that can help maintain their dental health effectively every day. And Vusen C Toothpaste is here to help. To prevent the demineralization of teeth, you need to suppress the growth of oral bacteria. Vusen C contains 1,450 ppm of fluoride. It removes 99.9% of bacteria, causing demineralization that leads to cavities. To prevent demineralization and suppresses bacteria, you need healthy teeth which are resistant to acids. The high fluorine content of Vusen C increases your teeth resistance to acid and prevents demineralization. Anti-cavity toothpaste, which also helps with the recovery of demineralized teeth. The high fluoride and hydroxyapatite content of Vusen C prevents cavities, effectively remineralizes teeth, and it even helps the tooth recovery from the early stages of demineralization. Vusen C is the most effective way to keep your teeth healthy every day.
학술 행사 오스템 미팅. 오스템 미팅 2022 서울이 더욱 새로워졌습니다. 임상이, 치과 위생사, 치과 기공사 등 치과계 종사자 모두를 위해 대폭 확대된 강연 프로그램과 전 세계 치과인을 위한 특별한 시간으로 대놀 사이트를 통해 실시간 생중계됩니다. 이번 행사는 앞서가는 디지털 치과의 매력, 전치부 신미 수목편을 주제로 최고의 연자들이 명강연을 선보이며 해외 7개국에서 200여 명의 치과 의사들이 함께합니다. 박정철 원장, 이대희 원장, 임현창 교수의 디지털 전치부 수술 강연과 김세용 원장, 이현정 교수, 박시찬 원장의 고철 세션 강연에 이어 이탈리아 닥터 마르코 탈라르코가 최종 보철물 계획 후 수술을 시작하는 디지털 솔루션 강연을, 체코 닥터 피터 하이니가 디지털 에스테틱을 주제로 강연을 진행합니다. 또한 김기성 원장, 이수영 원장, 임세용 원장이 상악 전치부 발치 즉시 식립 시 심리적 고려사항 및 디지털적인 접근법에 대한 열띤 토론을 펼칩니다. 오스템 미팅의 꽃 라이브 서저리에서는 손영희 원장, 김용진 원장이 상악 전치부 임플란트의 친밀성 극대화를 위한 상황별 원 가이드 활용법을 주제로 2가지 케이스의 디지털 수술 현장을 공개합니다. 더불어 OIC 세미나실에서 임정빈 본부장, 김창우 원장, 김병국 원장, 김세진 원장, 정혜영 교수의 강연으로 진행되는 개원 박람회를 비롯해 김민수 원장, 이종국 원장, 지대경 원장, 이근혜 원장의 투명 교정 강연과 박지선 매니저, 홍선아 교수, 강호덕 원장, 김여빈 실장, 정보람 실장의 치과 위생사 대상 보험 청구 강연 및 트리오스 강연을 진행합니다. 이번 행사는 임상 증례 및 연구 포스터 160편 발표와 시상, 44명의 연자와 9명의 좌장 등 총 61명이 직접 참여하는 대규모 학술 행사로 최고의 강연 프로그램을 만나보실 수 있습니다. 또한 노비에 마련된 대형 전시 및 핸즈온 실습, 새롭게 리뉴얼된 오스템 제품 전시관이 전격 공개되며 최신 전자기기 및 OIC 세미나 수강권 등 약 5천만 원 상당의 푸짐한 경품과 함께 현장 이벤트로 개원 상담, 무료 프로필 사진 촬영, 스탬프 투어, 얼리버드 200분을 위한 선물이 풍성하게 마련됩니다. 특히 현장에서 새롭게 론칭하는 신제품 트리오스 5를 직접 체험하실 수 있으며 사전 예약하신 분들께는 약 600만 원 상당의 임플란트 스튜디오 소프트웨어를 드리는 특별한 혜택까지 참석하신 모든 분들을 위한 다양한 서비스가 준비됩니다. 오스템 미팅 2022 서울 지금 시작합니다.
네, 안녕하십니까. 오스템 미팅 2022
Hello, I'm announcer Yusu Kim, MC of Osstem Meeting 2022 Seoul. First, I would like to thank for your support for the Digital Dental Technician Contest completed yesterday. Before we start, the audience of technicians and the clinicians and others who joined the various programs yesterday gave us hot response. Thank you for your support once again. Now it's 9:03 a.m. Let's get started with the Osstem Meeting 2022 Seoul under the theme of advancing digital dentistry restoration in anterior region, focusing on aesthetics. Here today in the auditorium of Osstem Implant Head Office and Seminar Room on the 3rd floor, we'll have abundant special programs at private practice exhibition, clear aligner. The dental hygienist class will begin at 2 p.m. Your participation will be highly appreciated. If you come to the dental site, you can see all the lectures, live surgery, as well as seminar room lectures broadcast online. Especially today, you can link on the window at the bottom of the dental screen. You can watch various lectures in real time going on in the seminar rooms. Have a good time. And Osstem Meeting is getting more attention as years go by dentists around the world. Riding on the momentum, we have some 100 80 people from 7 overseas entities.
Thank you all the foreign distinguished guests to being participating here.
To have more meaningful time together with viewers in various places around the world, we have interpretation service for the overseas audience. The Academic Congress in the auditorium is simultaneously interpreted into English and Chinese to 26 countries. The auditorium and the seminar rooms on the 3rd floor is being videotaped currently. Please switch off your cell phone or set it on vibration mode. We have various events and programs that we have organized. For those who log in to our dental site online, we will send coffee coupons and dessert set coupons to 3,000 of them. At the beginning of each session, don't miss the giveaway application pop-up window that appears for about 3 minutes on the dental site. Now you will see the pop-up window. Please apply now. The winners will be announced after each session, and coffee coupons will be sent as text messages. For those who watch us until the end online, we have prepared many giveaways such as Galaxy Z Flip 4, Galaxy Watch 5 Pro, Galaxy Buds 2 Pro. Please stay with us until the end. Don't forget to log into the dental site to participate in all the online events. Don't forget, if you sign in for a membership in advance, it will be more convenient for you. If you are watching on mobile phones and want to join the pop-up event, remember you need to use the landscape mode. Now, offline lucky draw. We have a lot of giveaways for you who came here in person. Lucky draw will be carried out after the program. Galaxy Z Fold 4, Galaxy Flip Z 4, Galaxy Watch 5 Pro, Galaxy Buds 2 Pro, and OIC single class coupons are prepared for you. Please stay with us, and we ask for your support. And events by floor for those who are here. On the first floor, 160 posters received in October are displayed. Free profile photo taking zone, which was popular during the private practice exhibition, and the experience zone of Terios 5, which will be launched for the first time in Korea, are operated with product exhibition booths. On the second floor, you can visit and experience various products in the Osstem product exhibition hall. Look around the event venues and get a total of 7 stamps on the stamp paper you received on your entry here, included in the registration kit you receive at the arrival. If you have all the stamps on the paper, bring it to the reception desk on the first floor. You will get awesome spoon set and electric toothbrush. For those who participate in the lectures, we have gifts for you. You will select 10 best questions asked during Q&A session, and they came to the real-time chat or the floor or big mouth cleaner. An electric toothbrush set will be gifted. If you are selected as best offline questioners, fill out your personal information at the registration desk, and online best questioners will be contacted individually. Now let's get started with Osstem Meeting 2022 Seoul. We have to commemorate today's event, President Jang Won-gun of Korea Academy of Aesthetic Dentistry, President Oh Hee-gun of KCOMS, CEO and VP of 3Shape have sent in congratulatory messages. Let's watch together.
안녕하세요. 대한신미치과학회 회장 장원건입니다. 올해 오스템 미팅 2022 서울의 개최를 진심으로 축하를 드립니다. 매년 오스템 미팅은 전 세계의 모든 치과 의사들의 큰 축제처럼 아마 그렇게 행사가 진행되고 있는 것으로 알고 있습니다. 저도 매년 오스템 미팅을 통해서 많은 것을 배웠는데요. 올해 과연 어떤 주제일까로 궁금했었는데 디지털 치과의 매력, 전치부 신미 수복이라고 주제가 정해져서 신미치과 학회 회장으로서 아주 더 큰 관심을 가지고 보게 되었습니다. 과연 이 어려운 주제, 그리고 모든 치과 의사들의 내가 어떻게 치료하면 좋을까를 늘 고민하는 이 주제를 어떻게 풀지 되게 궁금했는데요. 준비된 프로그램과 또 연자 선생님들, 또 해외 특강 연자들을 보면서 역시 오스템에서 준비하면 다르구나라는 생각을 했습니다. 코비드 19 이후에 정말 모처럼 몇 년 만에 개최되는 행사인데요. 코로나 이후에 개최되는 이 오스템 미팅 2022 서울편을 통해서 아마 모든 전 세계 치과 의사 선생님들께서 아마 많이 배우고 어떤 그 잔치와 같은 장이 되리라고 생각합니다. 성공적인 개최를 정말 진심으로 기원하겠습니다. 감사합니다.
안녕하십니까. 저는 제15차 에이코미스 아시아 구강아간면외과 학회장을 맡은 오희균 교수입니다. 코로나 팬데믹이 끝나는 시점에 2022년 서울 코리아 오스템 미팅이 아주 성공적으로 개최됨을 진심으로 축하드립니다. 오스템 미팅은 세계 최고의 임플란트 기술력으로 임플란트 판매량 세계 1위를 지켜온 오스템 임플란트가 지난 20년 동안 매년 개최하여 온 세계적 수준의 글로벌 학술대회로 각 분야에 재능하신 연자분들을 모시고 그들의 소중한 경험과 노하우를 서로 나누는 귀중한 자리가 될 것으로 생각됩니다. 이번 오스템 미팅을 준비하신 최기옥 회장님과 엄태관 사장님을 비롯한 오스템 임직원 여러분들께 진심으로 축하와 감사의 마음을 전합니다. 금년에도 오스템 미팅에 참가하신 여러분 모두에게 아주 유익하고 큰 만족을 드리는 시간이 되리라고 생각됩니다. 감사합니다.
Hello, I'm very proud to represent 3Shape here over the next minute or so. First of all, I wish to congratulate you with the 2022 Osstem meeting. Osstem is a truly impressive company recognized around the world. Also want to say thank you for the great collaboration between Osstem and 3Shape.
Yeah, we are super excited to present Trios 5, our new generation of Trios scanners. It sets a new standard for ergonomics, a new standard for effortless scanning, and defines a complete new level for hygienics. So please go and have a look at our new Trios 5. It's a fantastic new scanner.
Our partnership is now 4 years old. I think we share the same passion for innovation and for our customers. And then we believe in the Korean bali bali, faster, faster. We also want to move forward in the market, and I know so does Osstem. And we actually have a very good example, Rune. Thank you.
Thank you.
축하 말씀 전해주신 장원건
Thank you,
회장님, 오희균
President
회장님, 3Shape 대표님과
Won-gon Chang and Chair Hee-gun Oh, CEO and Vice President of 3Shape for your messages. Now 9:13. Next, 26 to 26 countries, this is a broadcast. Let's get started with the first session. We have Professor Hyung-jun Kim of Yonsei University who will chair the first session. He graduated from Yonsei University Dental School and he has a PhD degree from Minhen University Dental School. He served as director of Korea Congress of Oral and Maxillofacial Surgery and ACOMS member, and also worked for the AAD of research as a research ambassador. Please welcome him with a big round of applause. He is currently a professor at Yonsei University Oral and Maxillosurgery Department.
네, 방금 소개받은 연세대학교 김형준
I'm
교수입니다.
Professor Kim Hyung-jun of Yonsei University.
오스템 미팅 2022에 오신 여러분들
I would like to welcome you to the 2022 Osstem meeting. Now let us begin the first
오늘
session.
준비해 주신 모든 강연을 함께 즐겁게
I
청취해
hope
주시고
you enjoy all the
좋은
lectures
질문 많이
prepared,
해주시기를
and I
바라면서
look forward to
첫
your
번째
intriguing
소개하겠습니다.
questions. I'll
오늘 첫
introduce the
번째
first
연자는
lecturer.
현치과의 박정철
The first
원장님이십니다.
speaker is Dr. Park Jung-chul
원장님의
of Hyo
강의
Dental
주제는
Clinic. The title of his lecture is Maxillary Anterior Implant Treatment Using One Guide System.
해주시겠습니다. 먼저 박정철 교수님이 올라오실 때 큰 박수로
Please welcome Dr. Park
맞으시기를
Jung-chul
바랍니다.
with warm round of applause. Greetings. I'm Dr. Park Jung-chul of Seoul Dental Clinic. I am honored to present at Osstem meeting. I would like to express my gratitude to Osstem for inviting me. Today, I'm going to talk about my clinical experience using one guide in upper anterior. In treating upper anterior area, I would like to share with you what I find is important. I would like to talk about my clinical cases as well. These are considerations for maxillary anterior implant treatment. We need to provide a treatment result where the patient does not complain. And that is something that we all have in mind when treating these cases. It's the same for me, but some people may worry what if they come across these cases, and many people find anterior treatment difficult. In order to get aesthetic result, we need to satisfy soft tissue, hard tissue, and prosthesis contour. It's quite difficult to do so. In order to satisfy such conditions, there are considerations that we need to make. First, in terms of surgery, I find 3 areas important. First, we need to consider how much soft tissue can be recovered and what the patient expectation is. Second is in terms of soft tissue support and implant support, what can be achieved and how much bone should be recovered. And the angle of implant position and angle needs to be considered. In the anterior area, aesthetic results are of key. As shown on the image, the tooth axis and alveolar process direction, if they vary, you need to it is very difficult to do implant placement in an accurate manner. If you have good deft hands, it may be easy, but I am kind of clumsy, so it's not so easy to do so. Therefore, I use in the upper anterior area, one guide system. The benefit of one guide system is that you can do accurate diagnosis pre-op and come up with a predictable treatment plan, and you'll be able to execute that plan accurately in the anterior area. It also helps in fabricating provisional and prosthesis as well. I'm going to talk about diagnosis, treatment plan, and surgery. I'm going to share a couple of cases. Let's look at my cases. When we talk about clinical cases, we need to divide these cases into different categories, and I think I need to provide a treatment protocol per different categories. I have decided to use the Ilian category. Type 1 is no bone resorption and there's no soft tissue atrophy. It is a good candidate for immediate implant placement. In the case of type 1, although it may be in the same category, depending on biotype or the thickness of buccal plate, tooth axis and alveolar process direction, we need to make precautions in doing implant placement, so we need to differentiate them. This is the first type 1 case. Due to tooth fracture, immediate implant placement was required. The patient has thick soft tissue and buccal plate. The tooth axis is slightly distally inclined, but you do not need to correct the implant angle. You just need to do a good job in placing the implant. In terms of diagnosis, you need to think of final prosthesis first. The crown position, the contour, antagonist relation needs to be considered in determining the final prosthesis. After that, we go into surgery. We need to do a top-down approach. We need to determine the position of the implant, consider the bone-to-implant relation, soft tissue the vertical position and the relation with adjacent teeth to determine the final position. As we do diagnosis, you come up with a certain idea as to where you need to be more careful about. In this case, I was cautious about the drill slipping. Therefore, I've realized that I needed a path drill. Gap filling was also required. After I go in, if extraction can be done nicely, placing implant can be done very easily. In the planned position, implant is placed, gap filling is done, and provisional was provided on the same day. After 2 months, ISQ was checked, the final prosthesis was fabricated. This is pre-op, post-op, final prosthesis CT image. You can see that implant has been placed in proper position and buccal plate is very thick. You may not think that guide is necessary, but if you use guide, simple cases can be done in a simple way without complicating things. This is the second case of type 1. Biotype and tooth axis is very nice, but the apical lesion exists. Because of this, primary stability is important. The buccal plate is thin. After surgery, we need to compensate for potential buccal bone resorption. In order to do so, implant position is very important in this case. In doing diagnosis, you need to determine the crown contour first and set the implant position. Because the implant distance is quite tight, the safety zone is 1.3 millimeter, so I thought it was okay. In this case, in number 21, the apex side of the implant was quite close to incisor area. In order to get to good primary stability, I needed to be more cautious in terms of drilling, and gap filling was required. Extraction was done, the apex lesion was removed, guide was used to place the implant. Collagen xenograft was used for dual zone graft, and prefabricated provisional was provided. After 3 months, final prosthesis was provided. This is pre-op, post-op, after prosthesis delivery CT image. In this case, due to apical lesion, it was difficult to get primary stability. It was close to incisal canal and the space was tight. But by using guide, I was able to place implants without difficulty. Third case of type 1, the biotype does not look good. The mesiodistal position of tooth looks okay, but the tooth axis and alveolar process vary significantly. Therefore, implant placement direction is very important. The implant placement direction, bone graft to compensate for buccal bone loss were considered important. This is final prosthesis image. In determining implant position, in this case, the tooth axis and alveolar process direction varied significantly. You need to drill in the slope. There's a higher possibility of drill slipping, so you need to be careful. If you use path drill within one guide kit, you'll be able to solve this problem easily. Surgery was done after extraction was done atraumatically. Guide was used. Implants were placed in planned positions. After gap filling, abutment was connected for provisional provision. In the buccal plate, the collagen xenograft was used in a tunneling manner for bone graft. This is post-provisional. This is provisional before final prosthesis, and this is at final prosthesis. Pre-op, post-op, and final prosthesis CT. The tooth axis and alveolar process direction varied significantly, and in this case, it is difficult to set the implant placement path. But by using a guide, I was able to place the implant in a simple manner, and this is the fourth case of type 1. Immediate implant placement was planned, but it was difficult to get implant position, so I changed to socket preservation. As shown in the case before, the direction of tooth axis and alveolar process vary, and there is a perforation in the apex area. When you place implant, you need to think of the angle and position of the implant and do GBR nicely here. For diagnosis, final prosthesis image was checked. You need to check the implant position. There was bone level difference between the buccal bone and palatal bone, so it was slightly placed too deep because I tried to place it towards the palatal area. Between buccal and palatal area, I tried to find the right position, but it was quite difficult. In doing immediate implant placement, I needed to do a bone graft in the perforated area. If we could do it all, it would be best, but this is not easy. After extraction, I changed my strategy to delay the implant placement. After extraction, socket preservation was done as much atraumatic as possible, but because there was perforation in the apex area, I was unsure whether debridement was done, and tunneling technique was used to check whether it was fully debrided. For bone graft material, collagen xenograft was used and it was sutured. 5 months later, I fabricated guide for implant placement. When I did diagnosis, flatless surgery was possible and appropriate implant position could be determined. Guide was used for a very simple surgery. 2 months later, final prosthesis was provided. This is pre-op. This is if I had not done a guide diagnosis here, if I had done immediate implant placement, I would have placed the implant too deep, or I would have removed the implant because it was placed too deep, and then I would have had to do socket preservation. But by using a guide and doing pre-op diagnosis, the patient was able to get a relatively simple solution. This is Elian type 2. There is no soft tissue resorption, but there is a partial resorption of the buccal plate. Elian recommends a socket preservation or ice cone technique, which Elian himself has devised. In the case of type 2, there is no soft tissue atrophy. Therefore, immediate implant placement is possible, or you can place the implant after doing socket preservation. The first case of type 2 is immediate implant placement case. The patient was wearing bridge from 11 to 22, and there was horizontal fracture of number 22. Bridge was dislodged. The perio condition was not good in number 11, and the number 11 was fully dislodged along with the bridge. I applied implant bridge plan ranging from 11 to 22, and the implant to be placed in number 11 required GBR, and in number 22, immediate implant placement could be done. In number 23, there was an implant already, therefore I needed to be cautious about vertical position of the implant, and guide surgery was determined. In doing diagnosis, I come up with a final prosthesis image first. The implant position is based on final prosthesis image, and considering the alveolar bone soft tissue, the position was determined. The diagnosis process is always an area where I spend most time in. If the guide is adapted properly, implant placement can be done nicely. When you do GBR together and use guide, you can focus more on GBR because you don't need to worry about implant position. Therefore, the burden when you do surgery is decreased, and it really helps. Transmucosal GBR method was done for bone graft, and provisional was provided. 2 months after surgery, impression was taken, and final prosthesis was delivered 3 months later. This is pre-op post-op CT image. If there is no soft tissue atrophy, you can do immediate implant placement with GBR. You need to place a implant within bony envelope. It's crucial, but if you use guide, you can get significant help. This is a type 2 second case. This is a case when the patient received treatment from 2012. The implant bridge from number 12 to 23 was dislodged, and the 22 implant was dislodged along with bridge. And Number 22 was dislodged rather than number 12. I could not place the implant in number 22. I placed the implant in number 21, and in number 12, it was difficult to place the implant, and just bone graft was done. After stitch out, the patient did not come for about a year. The reason was because surgery was too painful, and the patient was afraid. When the CT was taken, the bone was nicely regenerated, and I tried to console her. I promised her that I won't open flap and that there will be no suture. And surgery was done. This is after prosthesis delivery. This is pre or post-op image. The patient suffered during the GBR process, but the implant placement was done in a simple manner, flapless using guide. In the case of Alien type 3, there is both hard tissue and soft tissue resorption. In this case, in order to restore the lost tissue, we need to do delayed implant placement. This is a type 3 case in the anterior area. This is pre-op image. There is a lot of gingival atrophy and mobility in teeth. There's a lot of bone resorption in all teeth in the upper anterior region. After extraction, socket preservation was done because it was difficult to do immediate implant placement. When you do socket preservation, you would see epithelialized granulation tissues, and you need to, if you attach it to buccal flap, you can use it as a membrane. In the case of edentulous area, MS implant could be of great help. In this case, for provisional, in the number 11 and 22 MS implant, and this will be later removed. This is after surgery. This is 3 months after socket preservation. 6 months after socket preservation, guide was used for implant placement, and the white shows the border of the bone. If guide diagnosis is right, flapless surgery is possible. Flapless surgery was done for the implant. In the central incisal area on both sides, tunneling method was used. Additional bone graft was done. This is post-op panoramic image. Impression was taken, and abutment was connected. In number 21, there was a bit of a gingival atrophy. I recommended connective tissue graft, but the patient already gone through a lot of surgery, and if the patient said if it is not mandatory, the patient didn't want it, the patient could not visit frequently because of the work, and it took about 7 months up to final delivery. Number 21, it's kind of troubling, but the patient did not complain, so it has room for improvement. This is number 13, number 21, 23, pre-op, post-op image. This is the conclusion. With Industrial Revolution, a lot of people were afraid that machine would take away people's jobs. That was the Luddite movement, but they were unable to go against the trend of Industrial Revolution, and I think machine has made our life much more inconvenient. The digital dentistry movement within the dental field is now making the lives of patient and dentists more convenient alike, and I think this is a trend that inevitably everyone will follow. A lot of people find anterior implant treatment difficult, and that's the same for me, but by using guide system, you'll be able to overcome such difficulties. In a lot of cases, you'll be able to place the implant in the planned area. To put guide system in one definition, I would like to tell you this. There may be someone who's never used it, but if you use it, you cannot quit using it. Go ahead and try. Thank you for listening. Thank you, Dr. Park Jung-chul, for the wonderful lecture.
오늘 Q&A는
The Q&A will be held after listening to the 3 lectures. After the session ends, we will invite the speakers to the stage and entertain the questions. Let me briefly introduce the second speaker while the second speaker prepares. And I'll introduce the second speaker. The second speaker is Dr. Lee Dae-hee of Lee Dae-hee Seoul Dental Clinic. The title is Gateway to Healthy Implant Tissue in Anterior Zone with one guide.
이대희 원장님께 큰 박수로 환영해 주시기 바랍니다.
Dr. Dae-hee, please welcome him with a big round of applause. Good morning. I'm going to talk about upper anterior region where aesthetic is important and what do we need to be cautious about for healthy peri-implanted tissue. So regarding aesthetics, many criteria appeared and it reached to Belger, pink and white aesthetic. The harmony is the conclusion. If you look at the laboratory supported white aesthetic, the soft tissue, the pink aesthetic is based on bone. So especially in the extraction socket, biologics should be understood. So this is from the handout of Belger. Bundle bone is abundant in labial side and not lingual side. So we need to have 2 millimeters of the most corona bone wall. So we need to place an implant deeper than 2 millimeters. So regarding the extraction socket, bone and soft tissue, many others need to be considered. But today I'm going to talk about the factors influencing aesthetic outcome, 5 factors. First, implant position. As Dr. Park said before, implant placement. And implant platform should be in the safety zone. This is external. This is bone level implant. On the right, whether you have GBR or not, when an implant is placed deeper, the bone level implant compared to external. As long as the Tarnow's rule is not violated, the papilla can be maintained. So rather than external, this is better for anterior region. When bone is present, how deep do we need to place the implant? That is another topic that we can discuss. Mesiodistally, the patient has a little bit distally placed implant because there is a canal. I will show you later. From about 10 years ago, I just ignored the canal and I removed the nerve and I placed the implant there. I will show you the video later. So a patient came like this. This is one body implant. After placing it near the canal, it is placed. And if you don't remove the nerve and the bone graft is not done, this happens. ISQ value, buccolingually, ISQ is low because there's no bone on the lingual side. Mesiodistally, ISQ is high, so this is unstable osseointegration. Therefore, we need to remove the nerve and do the bone graft to increase the BIC and achieve osseointegration. Next, angulation. Bone-driven implant position or restoration-driven implant position. So superstructure's apical extension is the implant. Implant should be considered the apical extension of the restoration. So if you place an implant based on bone, especially in the upper anterior region, if you just consider the cervical region, gingiva would have recession and bone would be resorbed. So you need to consider that implant is an apical extension of the restoration. So it should be uprighted like this, and you need to do GBR. Sometimes I see a guided surgery is done, and it is based on bone, and this is not good for long-term aesthetics. So I always communicate with the lab. I don't participate in the abutment design, but if you look at the upper anterior region, the abutment and implant are not bent. They are somewhat straight and uprighted position. So number 11 and 12, subgingiva caries was observed. So extraction was decided, and they were extracted using one guide. 2 implants were placed immediately, and jigs are not made, so temporary is used to fabricate the jigs. Intraoral scanner or model scanner can be available. However, stone model is used, and after extraction, the fitness is checked before surgery. That is very important to ensure the fitness, so we don't have to adjust the fitness during surgery. Number 11 and 12 are extracted, and a guide is connected. The first drill is the path drill. Using the path drill, it is a kind of a side cut drill. Lingual wall, cortical wall is drilled. Number 12 is okay, but at number 11, it didn't work properly. So cortical is scraped. If it doesn't work, it means it is going okay. So if you are suspicious, you can remove it and check. So without the path drill, if you use a guide drill, the drill can deviate, so it can move labially. So you need to use a path drill. So on the apical side, bone graft was done like this. At number 11, implant was placed. Incisive canal, the nerve is removed as much as you can, and the bone is grafted. Without bone grafting, if you just remove the nerve, when they drink something hot, they will have burning sensation for some time, and neuroma can occur. So that should be prevented. BIC should be increased, and osseointegration can be ensured with this technique. So like this, the canal is invaded. So curettes like this can be used. Here, bone graft was done. Provisional is connected. This is 6 weeks later. Second, intra-socket graft. In 2013, in the 5th ITI consensus, immediate placement with gap filling with low resorption rate, that is recommended. Mostly cover screws are used, and bone graft is done, and healing or abutments are connected. But here, the bone graft should remain equal or below the platform. The bone graft above that is useless, and it may cause infection. So when you use a guide, cover screw or bone graft needs to be done, and this is after removing the cover screw. low resorption rate is observed by xenograft and alloplast. In 2014, I did the immediate placement and using the alloplast. It looks well maintained. However, after 6 years, suddenly inflammation occurred and the patient came with gingival swelling. So the bone here looks like bone, but if you raise flap, it's something like rock salt. It's not a vital bone. So the patient received the bovine putty, but it wasn't satisfactory in terms of the outcome. So we did a supplementary technique, and tunneling technique was used for connective tissue. However, there is not much bone below, so the outcome was not satisfactory. So principles of intrasocket grafting. When you do condensation, you should be using alloplast or xenograft. Porcine xenograft is not used with a low compressive strength. I use composite graft, combination of allograft and xenograft. Second, the thickness of a backbone. If it is thin, after 10 or 20 years, the bone would be resorbed, so gingival recession would occur. So always, other scholars, especially for maxillary anterior, they said the minimum width of 2 millimeters of backbone wall is necessary. So Dr. Grunder said the same thing. Why 2 millimeters? Maybe cortical and cancellous bone coexist in that thickness, especially in protrusive movement. The lower anterior would be striking against the upper anteriors. That's why 2 millimeter of bone is required. And GBR, like Dr. Jong-chul Park, apical semi-lunar incision is made for that technique. Then 2 millimeter or more bone can be maintained. For loading time, many people talk about papilla level. A papilla is determined at the time of surgery. Restorative procedures, whether you do delayed or early immediate loading, restorative procedures did no influence on papilla. Many scholars said the same thing. However, the mid-facial soft tissue, mid-facial soft tissue recession is different. Immediate loading, the immediate loading would reduce the recession, but soft tissue should be handled more. According to Dr. Grunder, CT graft can make only 0.34 millimeter gain in average. So 1.4 millimeter positive effect if you do immediate loading. So soft tissue augmentation results would be similar to that technique. After soft tissue preservation, the papilla doesn't look very good. However, after 5 years, the papilla is filled, and the facial flattening and recession exist. 8 years later, the same. So this is the price you have to pay when you don't do immediate loading. And soft tissue augmentation may be needed, but the patient was close to 80 years of age, so the patient was not concerned about the aesthetics. It was lucky for me. So immediate loading is done using a guide. The soft tissue is maintained 1 year after. There's no recession or facial flattening. That is the advantage of immediate loading. It is for aesthetic result, and the facial gingival margin can be preserved 1 millimeter or more if you do immediate loading. Mid-facial contour, it can be achieved with contour augmentation or soft tissue augmentation, early tissue support, or running room can be used. Soft tissue augmentation can be done with various methods. Dr. Lim will talk about this in more details later. Last, soft tissue condition. Thin or thick biotype can be the classification. Of course, thicker one is better. To change the thin biotype to thick biotype. So while you place an implant, the pouch technique can be used. The pouch technique can be done massively like this, but Dr. Thomas Han said crescent-shaped free connective tissue would be good enough. And Giovanni Zucchelli technique can be employed. CTG is used coronally positioned flat. $500 is the price of this book, which is very expensive, but it's worth it. So little by little, the situation is improving. Lastly, when we place an implant, the GBR can be done, and soft tissue augmentation can also be done. PPG, palatal pedicle graft, is the technique that I use. PPG is done because blood supply is maintained. So after bone grafting, at the same time, palatal graft can be done, but it will bring in the shrunk result. So according to Professor Maynard, when alveolar bone is thin and attached gingiva is deficient, recession can easily occur. So after bone grafting, implant is placed, and the second surgery, connective tissue graft, can be done, or at the same palatal pedicle graft can be done. So OIC Master Course Advanced Surgery, delivered by me and other director doctors, talk about this, and I believe the courses would be very helpful, and your participation will be appreciated. Thank you for your attention.
네, 이대희 원장님 훌륭한 강의 감사드립니다.
Dr. Dae-hee, thank you very much for the excellent presentation. We will have Q&A later while the third lecture is being prepared. So would you show the slide? I would like to invite the third speaker, Professor Hyun-Chang Lim.
임현창 교수님은 경희대학교 치과대학
Dr. Hyun-Chang Lim. He has graduated from Kyung University. The title is quite interesting. What if soft tissue augmentation and digital technology is the title. Please welcome Professor Im Hyun-chang with a warm round of welcome. Greetings, I'm Professor Im Hyun-chang. I work at Periodontology Department at Kyung University. Today I would like to talk about soft tissue augmentation and digital technology. The two previous speakers have provided wonderful lectures, so I don't know what else to add, but I would like to share with you my cases and the academic background that I have. I would like to share 5 patients. This is the summary of 5 patients. Let's look at the first patient.
In the case of this patient, the patient received the implant treatment overseas, and there was a gingival recession. There are many implants that are not in use these days. In number 13, in these days, you do not use as long implant, but you can see a very long implant being placed. There was resin filling here, but there was continuous inflammation around that. After removing resin filling, as shown, you can see very severe gingival recession. The patient was older, but the patient still wanted to fix it. If you look at from top, this is a very old type concept. Bone-driven implant placement was done, and implant was placed very buccally. As shown, if you look at the contour of the gingiva, the implant placed in the canine area is very buccally inclined. PST, the peri-implant soft tissue dehiscence, has been of limelight recently because implants are being placed for a long time, and with age, gingival recession has become a major issue. If you look at the different reviews, in most cases, if the implant is placed towards the buccal side, the odd ratio is 15.8% PSTD occurred. And the patient that I'm showing you, the buccal implant was placed buccally inclined. Therefore, these kind of problems were bound to occur. Root coverage. In the same sense, if you do implantoplasty, you can compensate for the gingival recession. Tripedizodal method was used to open flap. If you look at the implant, it was buccally placed. Therefore, the epithelial tissue space for that was lacking. In order to secure space, implantoplasty was done so that the epithelial connective tissue can be formed here. From the palatal area as shown, a fairly thick graft was harvested and it was sutured like this. After 6 months, prosthesis was delivered, but if you look at 1 year later, you can see that the problem was fairly resolved and the patient was quite satisfied. This is after 4 years. A gingival recession did occur, but compared to initial visit, the conditions have improved. Around the implant, the gingival recession, there are a lot of discussions on this. 2 professors have released a lot of studies on this. First is Professor Brook from Zurich, and second is Giovanni Zucchelli from Italia. When similar treatment were provided, Zucchelli overcame 96.3% of gingival recession. In the case of Zucchelli, about 66% of gingival recession recovery occurred. If you look at the difference in the treatment protocol in the case of Buccal, the implant prosthesis was adjusted, and in abutment level, soft tissue growth were promoted, and therefore the results was much better. In my case, the implant was older, therefore abutment level alteration of abutment was not possible. But if you consider this, in managing the peri-implanted tissue, you can adjust the prosthesis as well. This kind of an issue is very problematic. If you look at the recently published study, various cases have been divided into classes and treatment protocols have been suggested as shown. Please refer to it. The next case is the implant was placed suboptimally, and I want to talk about how I overcame this issue. As shown, the patient was in mid-30s, and in number 11 was missing. It was about 2 months after extraction, as shown. Early implant case. As shown, in the labial side, there is resorption. Bone healing is not perfect, but there is palatal bone on the apical side. There is bone healing, and primary stability can be achieved when doing implant placement. Flap was reflected. Implant was placed. As Dr. Park has mentioned, he showed a lot of great cases using guide. In this case, I did not use guide. I just relied on my hands to place the implant as shown. Prosthesis-wise, it is more placed buccally than the ideal position. Recently, if the implant is positioned buccally, statistically, in a quantitative manner, there were efforts to measure it. If implant is buccal position, compared to the contralateral natural tooth and compared to ideal contour, 2 millimeter less, over 2 millimeter, if it is palatally placed, it would be ideal, and if it exceeds that scope, the implant would be placed more buccally. Implant dehiscence has occurred, and using the conventional method, I used the bone graft material and used double-layer membrane to get the primary closure. The surgery was problem-free. 4 months later, despite my efforts, around the implant shoulder, there is still a defect. And if I just leave it untouched, it can lead to recession. Therefore, from the palatal side, I grafted the connective tissue and the suture. I looked at different reviews, and there's a study that consoled my mind. In this study, rheumatic zone, when you do GBR, DBBM, bovine bone, if you use this, and when you combine it with autogenous bone. These were compared after 4 to 6 months. In both groups, around the implanted shoulder, bone fill did not occur perfectly. The conclusion is quite interesting. At implant shoulder level, the augmentation thickness seems to be disappeared after the healing phase. If you look at this study, it does not talk about how guide helped in positioning the implant in ideal position. I think around the implanted shoulder area, bone fill was not done perfectly because of this factor. In the case of this patient, if you look at the biotype, it was very thin biotype. When the biotype is thin, long-term wise, in the case of upper anterior, there's danger for gingival recession. Along with residual defect, there was need to compensate for that. Biotype modification was required. I needed to change from thin to thick biotype. As shown, epithelial connective tissue graft was done. About 4 years later, if you look at the result clinically, it's not a problem, but there was the residual bone defect, and I think additional follow-up may be necessary. I trusted in myself, so there was human error. There is a lot of discussion about human error. If you look at the study, it divides my character in 5 different categories, and depending on who your character or personality is, you can see the different classification. In order to compensate for human error, rather than just relying on our brain and hands, we need to design using computer first to provide treatment. This is the best way to reduce human error. Implant was placed in a different dental clinic, and aesthetically it was a failure. 1 year ago, the implant was placed, immediate implant placement was done. But at the time, there was no bone graft, and soft tissue graft was done. If you look here, even without looking at the CT image, it is quite buccally inclined. It has only been a year, but you can see the implant abutment. And the patient was extremely stressed because of this. If you look at the CT, the buccal bone resorption, there's very little buccal bone left, and the implant is very buccally inclined. The patient had no trust in the implant. As shown in the first case, you can do epithelial tissue connective tissue graft, but the patient wanted a new implant treatment. Therefore, using the kit for removal, implant was removed, and in order to prevent the buccal bone loss, I did connective tissue graft, and
then provided provisional. After 2 months, there's a bit of bone fill, and you can see that surgery could be possible. Early implant placement was chosen. More palatally than the original position, implant was placed, and after that, bone graft was done, membrane was used, primary closure was achieved. About 4 months later, below the provisional, there was tissue depression. At first, clinically speaking, I thought that GBR melted away around the shoulder area, but when I opened the flap, the critical bone was formed about 2 millimeters. The tissue depression is not at the hard tissue level, but it's at soft tissue level. At the soft tissue level, the tissue depression, it requires a soft tissue graft. The connective tissue graft was done. Tiny graft was harvested and sutured. If you wait for tissue molding, you can see aesthetically nice results. Implant was placed and final prosthesis was delivered. This is a clinical image where the final prosthesis was delivered. Bone graft was done and many procedures were involved. In terms of aesthetics, I believe the soft tissue plays a great role. Let's summarize the case. After removing the implant, the tissue was sunken, GBR was done for augmentation, and soft tissue augmentation was done. Final prosthesis was provided in order to do tissue contour to augmentation was done. If you look at a study, if you look at the Swiss Zurich University study, early implant placement was done along with GBR and soft tissue graft. How much contribution to the contour would it lead to? About 60% bone augmentation served to tissue contour. About 40% of tissue augmentation contributed to the final prosthesis contour, so you cannot overlook that. In the fourth case, this is a combined case of what we've just seen. If you look at the information, the thin phenotype, soft tissue insufficiency, and the patient has high smile line, although you cannot see the image here. And the patient had high aesthetic demands. This is from occlusion. In order to get primary stability, there will be no problem. I did not trust my hand and my brain. Because implant position is very important, I use surgical guide to place the implant. Following the design provided by the prosthodontic division, I used the guide to place the implant. Collagenated graft material and membrane was used for graft material. Primary closure was done. This is at the time of implant placement. After 4 months, there was a bit of tissue depression at the coronal level. In the case of the depression, it was not the hard tissue level, it was soft tissue level depression. Epithelial tissue was grafted, healing abutment was connected, and at the same time, such graft was done. In this case, labial epithelial tissue was grafted. When you use tunneling technique, at times you cannot fixate it in the desired position. As shown in this image, on the labial flap, I connected the graft material so that the epithelial tissue graft is positioned to the desired position. This is comparing the initial photo with the final prosthesis delivery. It has not been 6 months since final prosthesis delivery, and it is not fully stabilized, but you can see more aesthetic result here. This is the final case. When you do epithelial tissue graft, the graft around the surrounding structure can be improved here. In the case of this patient, number 13, number 12 was missing, number 13 had to go through orthodontic movement, and in number 13, implant needed to be placed, and the patient was referred from orthodontic division. Number 13, as you know, number is different from number 12, so it looks quite weird. And the patient wanted this to be solved. Fortunately, in number 13, there was resin filling. It thought I could remove here and expose dentin. It was like this. If you look, the bone amount was sufficient, so surgical guide was not necessary here. This is a T image. Implant was placed in prosthetically ideal position. When I opened the flap, CT graft like that, trapezoidal flap was formed, and in number 13, flap was extended up to number 13. From tuberosity, you can see semi-lunar type of graft was harvested. It was fixated, and suture was done like this. This is a tissue maturization. In the case of number 12, the tooth contour is different. You cannot really make it like number 12, but by using epithelial tissue, you can solve tissue defect and gingival recession. So when you do surgery, not just to look at the site in question, but if you look at the surrounding tissue, you can get a better result aesthetically. In doing soft tissue graft, you can get the grafts from 3 different areas. First is anterior palate, posterior palate, and tuberosity. In the case of anterior palate, there's rugae, therefore this is something that you need to consider last. Most cases, you get graft from posterior palate or tuberosity. In the case of tuberosity, you can get a lot of volume and the patient experiences very little discomfort. So I get soft tissue graft from tuberosity area mostly. If this is not likely, I use the posterior palate. As Professor Zukel has mentioned, I graft the FGG and do the epithelialization. In terms of fixation, as shown in the fourth case, I attach it to the labial flap. That is my first choice. The reason is because I can fixate it in the desired position and you can do it in a minimal way. That is why I really prefer it. Other techniques involve tunneling technique. You can pull it towards sideways or towards the apical area and you can fixate it. Around the implanted shoulder area, a lot of contour. If you want to do that, you can use the palatal flap to fixate it. And up to the implanted shoulder area, more graft material can be fixated and you'll be able to gain more soft tissue volume. I need to talk about implant position once again. As shown on the left, the implant is placed in the ideal position and implant is placed more buccally in the left. If you place the implant ideally or if it is buccally inclined, the amount of bone graft in the case of buccally inclined implant increases and soft tissue augmentation is more protruded towards the buccally. So it becomes more vulnerable to external forces. In the second case, despite a lot of effort, there can be unwanted results. Implant position, especially in the anterior upper, is very important. From the beginning, you need to use the surgical guide to get a good position to get good results. Digital guides. It can lead to optimal hard and soft tissue augmentation, and it can also lead to long-term stability of the graft. Do you know when people memorize dinosaur names? You memorize it when you're a baby, and men in 30s or 40s memorize the names because their babies love it. The contour or the look, you cannot really get a good grasp. This is a dinosaur and it always looks angry. The bone is important, but in order to get the right appearance, the soft tissue contour is very important. And considering that, you need to place the implant good and do good bone graft. But if there's something lacking, you can compensate more using.
네, 좋은 강의 감사드립니다.
Thank you for the excellent presentation.
네, 세 분 연자분께서
So three speakers are seated on the stage, and we will have a Q&A. First,
채팅창에
on the chatting room,
질문 중에서
we received some questions.
중요한 내용을 골라봤습니다.
I have selected some important ones
순서대로
in the order of presentation. Dr. Park.
선생님의 질문입니다.
This is a question from TS. In anterior immediate implant placement case, if the buccal bone is excessively thin, if the residual root and the apex of the root is sound, what if we use the socket shield technique where we use the residual root? What's your opinion on that?
요청하셨습니다.
In the case of socket shield technique, this has been discussed long term. There's also a dedicated tool for socket shield technique. I've never tried it. That the reason is, first, it's technically very sensitive and difficult to do. It's not an easy job. And I think it's more easy to just take it out and do GBR and to leave root. My personal prejudice, I do not do the socket shield technique. If you look at the literature for long term, there are ways to maintain it. If possible, you can use it. On literature, there are good results.
네, 혹시 다른 두 분 연자분들 중에
Are there any other
답변
opinions? Could you also answer
하실
this
분
question?
계시면 부탁드리겠습니다. 네, 이대희 원장님.
Dr. Lee Dae?
Socket shield technique, I've done 20 to 30 cases, especially when endo treatment is done. Infection source, gutta percha must be removed first, and should be shaved with a diamond burr. Epithelium, the root fragment over the socket needs to be removed. That is important. If that is just left, if you place an implant lingually and 2 millimeter or more horizontal gap, then 3.5 diameter implant can be placed. There's no room for 4.0 implant. So bone grafting, whether to use bone grafting or not, can be an issue. If everything is okay, after discussing it with the patient, that approach would be okay. But if there is mobility or inflammation that's contraindicated, gutta percha should be definitely removed with a reamer. That's the most important thing. Thank you very much. That was a very good explanation based on the principles. I believe the questioner and other doctors who have been wondering about this question must have been answered. Thank you for the answer. To Dr. Dae Lee, ice cream, the nickname ice cream posed a question. In many situations, in the upper anterior region, immediate loading cannot be done. In the buccal recession or flattening can occur later. Other than soft tissue surgery, is there any other options to address the problem? That is a very good question. When the patient has a deep bite and the periodontal situation is not good in the adjacent teeth, immediate loading cannot be done. So as I said, facial gingiva can go down 1 millimeters. There is a risk. So a few years ago, temporary abutment began to be used as an alternative. Custom healing is made at chair side. So the shape is pushed. The bulk gingiva is pushed out using a custom healing abutment, or some other companies use anatomy healing. So there are many different sizes that copied the root section. I haven't used them at all, but that sounds good. But if you have to use a temporary, and if you have to attach a flipper over it, it is rather complicated. So, but that still can be an option. Thank you. Any other answers from other speakers to this question? I agree with Dr. Lee. If you use a temporary healing, if you make it as a customized version, attaching and detaching process should be used, and mentally it's a little bit burdensome, so I don't really like it. Thank you. Dr. Lim, do you have anything to add? No. Thank you. So let's look at the last one in the chatting room. This is the question to Dr. Lim. The nickname Good Good raised the question.
Using cover screw, if you do transmucosal GBR, and if you do not change to healing abutment, if you use healing abutment and do transmucosal GBR, what kind of changes are there? Transmucosal GBR, I use that method at times. When I do that, in proximal area, it needs to be adapted appropriately, but if that is not possible, the adjacent papilla can be lost in the posterior area. The papilla is not very important. Therefore, transmucosal GBR is not bad, but in the case of anterior area, we need to preserve as much as possible. And if you make one mistake, it can lead to complications in different stages, especially in the case of young patients with high smile line. I do not use transmucosal GBR. I do uncover later. If the patient has very sensitive about aesthetics, and I believe that this was a very good question and the answer was very good as well. Do you have any other comments to make? Whether or not to open flap, and whether to do transmucosal GBR. Around the healing, the gingiva healing, if we can get it, it's good. But below that, if there's good hard tissue support and if the GBR has been done nicely, soft tissue healing would go in line with that. Long-term wise, if you open flap and do GBR, how much difference would it lead to if you do not open flap? There are some literature that say that there's no difference in doing transmucosal GBR. I connect the healing. At times, people punch the membrane, the resorbable membrane, the tissue adaptation or biocompatibility. There are products with excellent those qualities, and you can get good results with that. I use these products very frequently. Thank you. Dr. Lee, would you like to add? No.
So at the beginning, we were concerned whether we can overrun the time, but the speakers have been punctual, and we addressed the questions from the chatting room, and now we can open the floor to the audience here to receive questions. Please identify yourself first before asking a question. I am Sang-eun Kim from Cheonan. This question goes to Dr. Lee. As you said before, root remnant is remaining, and if you do bone graft in the gap between the implant and the xenograft, or collagen or other materials can be used. But what is your preferred material of bone grafting, as you have a lot of experience? So when root is remaining, if the root is on the buccal side, xenograft is meaningless. Xenograft is not resorbed well, so the labial plate needs to be maintained. Then it can be used. But if root is remaining, I use allograft. Does that answer your question? Yes, thank you very much. Any other question from the floor? If not, let's conclude. Oh, okay. The last question. I'm from Olchikwa Dental Clinic. My question goes to Dr. Lee. Incisive canal, as you talked about, you did the grafting. Do you use membrane in that case? It depends. If the canal is very wide, I use membrane. Otherwise, if the entry is small and bigger inside, I don't use it. So placing an implant, the foramen is not a contraindication, right? That's right. Does that answer your question? Thank you. From early in the morning, you have been with us. Thank you very much. And please give a warm round of applause to the speakers who gave us good presentations and good Q&A. Let's conclude the first session. Thank you.
Thank you, Professor Kim Hyung-jun, for chairing this session. Please give him a warm round of welcome. Now, those of you who have been chosen as the best question, please go to the registration. And those of you who have been chosen as best question online, with separate contact will be made. First is the coffee coupon event winners. Coffee coupons will be sent to 300 people, and now we will do the lucky draw right now. On the screen, you can see the numbers and the name. Please check. Coffee coupons will be sent via text. You can check the results on the notice board on the site. If you have not won coffee coupon this time, there is still more chances to win. With the start of second session, as I'm talking, I can see more and more people are entering the auditorium to participate in Osstem meeting. There are so many people here, 7 different overseas branches, as well as 180 per staff have also participated in today's event. You can see various booths in the first floor and the second and third floor as well. We can have break up to the 35 on the right side of the auditorium. There is break area. There's also a poster announcement in the first floor as well. We'll reconvene at 10:35.
When you have no option but to remove an implant, you can use this EFR kit, which helps you remove implant without affecting the surrounding bone. An implant removal tool should be easy and convenient to use when removing an implant. Turn the remover screw clockwise with the screwdriver included in the EFR kit to fasten the remover screw. Next, turn the remover body counterclockwise to remove the implant. First, turn right and then turn left to quickly remove the implant easily. An implant removal tool should minimize the amount of bone loss which may occur while removing the implant. EFR kit applies torque directly onto the implant, allowing the clinician to remove only the implant without affecting the surrounding bone. Since the EFR kit removes the implant by rotating it in the opposite direction of its thread, the same implant can be re-implanted immediately upon removal. An implant removal tool should be capable of removing different types of implants. The EFR kit is equipped with various types of remover screws. Clinicians can remove both Osstem and non-Osstem products. The EFR kit allows clinicians to remove a variety of implants, making surgery and treatment much more convenient. Use the EFR kit for quick and easy implant removal. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneJet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneJet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD. I would like to introduce T2. The T2 provides clear images and helps accurate diagnosis for dental treatment. T2 offers a multi-FOV sizes that help take images including facial, implant, TMJ, orthodontic treatment, and other images depending on the type of dental treatment. All you need to do is take image of the area you need to examine, and low dose of radiation is used for generating better image quality. The T2 comes with easy-to-use software including the 1.2, 1.3, and VSET, which helps you deliver accurate diagnosis and set accurate implant treatment plans, and ultimately convince more patients to proceed with treatment. Make your treatments more efficient than ever with the T2 that provides clear images and helps deliver accurate diagnosis. Introducing the SM5, the dental implant surgery engine that provides safe surgery with its accurate torque value and drilling ability. First of all, SM5 provides accurate drilling results thanks to its outstanding chucking force. The implant can be safely placed since the implant is firmly fixed, minimizing unstable vibrations. Moreover, the torque value and rotation speed can be checked with ease on the LCD panel during the surgery. Try the SM5, the surgery engine that has outstanding chucking force and that displays the torque value and rotation speed during surgery. Selecting the right bone material by comparing it to the patient's existing bone quality and conditions is crucial when expecting the satisfactory result from the GBR. Defects may occur on surgical sites such as the anterior maxillary sinus and ridge, which will require bone graft materials that facilitate the process of forming new bone osteogenesis while maintaining the bone volume. With that said, here is the Osstem implant's xeograft EOS with phenomenal volume maintenance and osteogenesis. For bone graft materials, it is important to have a faster remodeling feature. Similar to the human bone, EOS particles have a cancellous pore structure. The structural property of EOS, when fully saturated with blood, significantly contributes to the process of new bone formation. The success of bone graft material must be verified with various clinic cases. EOS is designed to graft bone in a socket after the tooth extraction, and the treatment of peri-implant defects with guided bone regeneration. EOS can be applied to the sinus lift to place the implant in a maxillary sinus, and to augmenting and reconstruct of the alveolar bone. It can be used to treat and prevent various bone defects. A bone graft material must be easy to use in a variety of surgical situations. EOS collagen plug contains 10% of bovine type 1 collagen. It is specifically designed for post-extraction socket augmentation to maintain the volume and allows for better aesthetic and implant placement. The surgical can cut and reshape the plug to better fit the defected site. The EOS pen is a bone graft material delivered in a syringe-type container that allows the surgeon to hydrate the material with just one hand. And the syringe's inner diameter is available in two specifications, 5.4 and 3.5. This allows the surgeon to select a better suited syringe for each case. In summary, EOS forms new bone rapidly, which can be applied to any surgical site due to its similarity to the human bone. EOS is a perfect solution for both the surgeon and the patient. Try now.
We can see the fervor and passion in the second meeting. Now we will begin the second session. In the first session, we will choose best questions raised from both offline and online. We did not announce the winners. Now I will announce them. The best question winners in the first session is Good for online and Dr. Kim Sang-wook for offline question. Please take note of it. Osstem meeting convenes various people from the dental field. We have very meaningful program here today. The program in the main auditorium is simultaneously interpreted in English and China and is sent to 26 countries. First, let's go to the booth in the first floor. We will look at the new products as well as steady sellers. Currently, there's also poster zone where evaluation is being actively done. Let's look at the booth. Ms. Emmanuel.
Hello. I am announcer Im Hanu, the MC of Osstem Meeting 2022 Seoul. I am at the exhibition hall on the first floor of Osstem Implant Magok R&D Center, Building B. We have 100 or more Osstem products. Behind me, many people are coming and going. So 180 dentistry-related people are here, so you can enjoy. Look around the exhibition. We have coffees, snacks available, and there's a photo zone where you can take commemorative pictures. And in the morning, many people used this photo zone, and this is a hot place, and we have a special tour prepared for this event, and I have Ms. Chang who is with us. Hello. Would you introduce the tour? For every visitor, we have prepared a stamp tour. In the first floor, you can get the stamp paper and visit the various stamp zones and get the stamps. You will be able to get many stamps, and on the first floor there are 4 out of 7 stamp zones. So there are 4 stamp zones on the first floor alone, so please visit them. If you get all the stamps, what gifts do you receive? What pick? Electric toothbrush and a spoon set, and there's toothbrush and toothpaste are all available for you if you get the stamps. And now I'm going to introduce the poster zone. So the session presentations are going on. 180 clinical research results are posted. Many people are competing with the results, and the award ceremony will be held after the presentations, and the good products will be introduced. The bestseller, K3, the successor, K5 will be introduced, and AOS and Dios Plus. K5, the next model of K3 unit chair, and the #1 bestseller in Korea. Now, CBCT T2 is available. The GBR zone, Zero Graft AOS, and Alloplast QOS Plus. If you cannot make it here in person, make sure you join us online. We will come back with the various leading products again. Announcer Kim. Hannah, would you come back, please?
We were able to see Osstem's prominent products ourselves. Within a short while, we will begin the second session. We will do an event before we begin the lecture. In the dental site, you can see the second event pop-up screen. Try your chance at winning coffee coupons. The result of the lucky draw will be announced after the second session, and coffee coupon will be sent via text. There's something to note here. The longer you watch, you'll be able to increase your chances of winning coffee coupon as well as baked goods. Please take note of this and stay tuned. We will now continue on with the local Korea's most prominent lecturers. The second session will be chaired by Professor Kwon Gung-nuk of Gyeonggi Dental University. Professor Kwon has been the visiting professor at Faculty of Dentistry at the Geneva University. And let's welcome Dr. Kwon Gung-nuk, Professor Kwon.
네, 소개 많았습니다. 감사합니다.
Thank you for the introduction. Let's get started with the second session. I am Keung-nok Kwon from Kyunghee University. So, Osstem meeting 2022 Seoul. So we have time to think about the advanced dentistry, and we will share various ideas. And I hope you enjoy the meeting. And let me introduce the speaker for the second session. The first speaker is Dr. Seung Kim of 21st Century Dental Clinic. Is going to talk about analog to digital transition, the anterior implant prosthetics. Please welcome me with a big round of applause. Professor Kwon, thank you for your kind introduction. I am Seung Kim from 22nd Century Seoul Dental Hospital. Congratulations on the Osstem meeting 2022, and I would like to thank all of dentists who are with us, and I would like to thank the Dr. Gyuk-che and other people who have put this together. Thank you very much. Today I have prepared the aesthetic prosthetic treatment for maxillary anterior natural teeth and implants, a transition from analog to digital. Our ultimate clinical goal is to fabricate the most optimal prosthesis and hope that this will stay intraorally without any major problems. So that can be achieved in a conventional way, or we can follow the digital workflow to achieve the goal. I adopted the digital approach in 2010, about 10 years ago. Sorry about that. At that time, I was under a lot of stress. I purchased these at high prices, but I couldn't really use them. From single inlay to crown, when prostheses were received, delivering it to patient's mouth was great trouble. But since then, digital approach has been advanced quite a lot. So from 2018, I began to actively apply digital dentistry clinically. So hardware or software, various equipment is in our hospital. The digital equipment proves to be really efficient and helpful. From posterior treatment, implant posterior treatment, especially in the posterior region, digital workflow takes up over 80% of the work. So digital workflow, the presence is really felt important. So we applied digital workflow to anterior region because anterior region lags behind. As you know, it is a static region. Optimal aesthetic outcome should be achieved. You cannot do it all alone. You need to consider patient factors, and you need to have aesthetic sense yourself, and we need to have a good lab technician to achieve the aesthetic outcome. So within the industry, there are many people who are really keen on aesthetic outcome, but I have my goal. My goal is bilateral asymmetry in the result of the treatment. So in the anterior region, I used analog approach quite a lot. As you know, rubber impression is taken on the model. The final prosthesis is fabricated. And the natural tooth, this workflow began to be used for prosthetics for natural teeth. So the first one I utilized was the provisional restoration. It takes a lot of time if you use the conventional method, and it depends on the skill of your hands. But with the digital workflow, all the work becomes very simple, and the result is more aesthetic. And I began with the provisional, and later the definitive restoration. And modelless, I began to utilize the digital approach for the final prosthesis as well. Especially for male patients and who do not have high aesthetic demand, and I use it for bilateral symmetry cases. But with the advancement of digital workflow, coloring, staining technologies have been improved quite a lot. So in the unilateral case, digital workflow is applied for fabrication. So the result is quite satisfactory. However, still, on the model, the final prosthesis is fabricated when aesthetic demand is quite high from a patient. If for a patient where full zirconia cannot be really applied. So if you look at this case, so 2 upper incisors were treated in another hospital, and the patient complained about the color. So if you look at the adjacent teeth, the color is quite unique. Depending on the skill of lab technician, full zirconia and coloring can be utilized. However, normal lab technicians, a rubber impression is taken on the model PFZ. On the zirconia coping, porcelain is fused. So this was required. So for anterior region, the analog approach still is working. And in my clinical cases, the digital workflow was applied finally to prosthetics for anterior teeth. And you understand the reason why, because implant treatment requires a prosthetic treatment as well as a surgery. So there are so many things that we need to consider. For anterior implant prosthetics, rubber impression is taken on a model, appropriate prosthesis is fabricated, and it is delivered to the patient's mouth. That is the conventional approach, which I employed for quite some time. But a digital workflow began to be applied to provisional first. So for conventional prosthetic workflow, digital workflow can work as well. So in implanted treatment, digital began to be used for immediate provisional restoration. So after placing implants in the anterior region, when primary stability is good in various ways, we can do immediate provisional restoration can be provided. How do you make that? There are so many different ways. So when do we need to do, where do we need to do it? Immediately after placing an implant? Or in the next appointment? Or is it going to be done in our clinic, or is it to be done in a lab? So are we going to use a digital workflow? How can it be done? With what? Starting from abutment, and the various materials can be utilized. And considering all of these, there are so many different combinations. and the connection type, whether it is to be cemented or screw retained or combination type, ER type. All these need to be considered. Broadly, we have a digital and a conventional workflow. When you apply a digital workflow, it is easy and efficient, and it is quite easy to fabricate. So there's a constraint of time, but let me introduce some of the approaches. Number 21 is extracted and implant was placed. Primary stability was good, so immediately the provisional restoration was fabricated. So the first thing we need to consider, stuck abutment can be chosen. Stuck abutment. There are two types of stuck abutment: one-piece non-hex type and two-piece hex or non-hex type. One-piece non-hex is chosen, and the process is easy, but the problem is that provisional should be cemented. So after the cementation, various prosthetic steps need to be done, so it should be removed, cemented, and that should be repeated. So cement-related problems are bound to occur. Therefore, clinically, this is not a favored option. So rather than that, two-piece stuck abutment can be used. So combination type, ER type, provisional can be fabricated, regardless of the position of screw access hole, whether it is labially positioned or incisor edge or cingulum, lingually positioned. So combination type can be fabricated. The appropriate stuck abutment needs to be connected to an implant, and if necessary, adjustment needs to be made. Depending on implant position and the path, a little bit of adjustment should be done. Intraorally, the adjustment is not done, so it is marked and it is connected to an analog, and the necessary adjustment is done. After that, in order to apply digital workflow, intraoral scanner is used. Depending on the type, metal reflection can be accepted, and the coating is not necessary, but sometimes it should be coated. In the process, the margin area is not scanned properly. After surgery, that part cannot be properly registered. So the abutment needs to be removed, and the abutment should be scanned separately and stored in a library. So the scanned data is sent to a designer, and the provisional is designed. The scanned data is evaluated. After that, here at the bottom, this is the removed abutment, scanned and stored in a library, and it is merged with the original scanned data, and the problematic margin area can be solved, and margin is set, and provisional is designed, and that can be fabricated in two different ways. One, PMMA can be milled in a milling machine, and 3D printer can be used to print it. After that, the prosthesis will come to a clinic, and I do permanent cementation, so it can become one piece. Then the following prosthetic process will become very simplified. We don't have to remove it and attach it again. So this is the delivery process. It is checked, and permanent cementation is done by me. Of course, it can be done by a lab technician. I evaluate everything and everything is okay. Then I do it myself in my clinic. So it is set. After that, after a certain period of time, it transitions to the final prosthesis. So this is the final, and it is delivered. Another way, many companies provide a link abutment or tie base. Osstem has two types. Personally, I choose the 3 shape, and a patient came and implant placement plan is established and implant is placed and graft is done and post-op CT view. Appropriate tie base or link abutment is chosen by myself and implant is connected and the appropriate scan body is connected and intraoral scanner is used to scan it. Using a tie base, as I explained before, the previous one requires some adjustment, but this one doesn't require adjustment to fabricate a provisional. So this is the adjustment. Due to constraint of time, let me skip over it. And it is scanned. Tie base is connected to an implant, and the opposing teeth and occlusion are scanned. And the scan data is sent to a designer, and they are merged to determine the implant position, and then link abutment the specification would be produced. And provisional is designed, and using your favorite material, PMMA, milling or 3D printer can be used. And when that comes to our clinic, I check the fitness, and in the mouth, we cannot do the permanent cementation. So analog is connected, so I do the permanent cementation myself. You can leave it to a lab technician. That's okay too. So after that, it is connected to the implant. So when we fabricate immediate provisional, digital workflow can be simply applied like this. If necessary, the final prosthesis is fabricated. To fabricate a definitive prosthesis, we use the conventional method, the rubber impression taken, and this is the conventional way. And custom ER type conventional, and it is set in the mouth. But recently, in the final prosthesis process for interior, I use digital workflow. There are many different workflows that we can use. I want to explain all of them, but let me just summarize. In general, in the implant level, you take the rubber impression, and on a model, appropriate abutment is chosen, and prosthesis is fabricated. Stock abutment or customized abutment can be chosen, and the cement retained or combination type or ER type prosthesis can be fabricated. This is a general workflow, but sometimes combination of tie base and mesostructure can be used. For thin gingiva, titanium would be showing, which is not aesthetic. So ready-made zirconia abutment I have used, but this is expensive and there is disadvantages. So instead of that, I use tie base plus mesostructure combination. Tie base plus mesostructure. Zirconia coping is fabricated, and that's permanently cemented. So it's kind of making customized abutment, and it is delivered. So follow-up checking was done. So tie base is more and more used, and manufacturers are upgrading the product. And there are many different heights, 2 heights. And open type tie base, depending on the path of implant, straight has some limitations. So in order to resolve the problem, open type is available. Access in the cingulum. Mesostructure doesn't need to be fabricated. Directly tie base and ER type combination can be used. So sometimes, rarely, the tie base has some limitations. So instead of tie base, I use this kind of ready-made abutment. Ready-made abutment and the zirconia coping are combined. So there are many different methods, especially when implant path is diverged, ready-made cannot be used, and angle type can be used with a combination of mesostructure to produce customized abutment. So the path is labially positioned, so modelless distal impression can be taken. So for various methods, I want to talk about this for a long time, but why did they give me just 20 minutes, which is regrettable? So, brief summary. Tie base and link abutment can be used for anterior immediate provisional restoration after implant placement. Second, customized abutment can be made in your clinic if you do not have a customizing machine. Customized abutment, the authentic problem should be used, but some milling machines cannot be used for authentic ones, so tie base can be used in that case. Personally, model or model-less approaches, CAD/CAM custom abutment is usually I use. I'm overrunning the time. Apologies. So, as I explained before, in the anterior region, when you transition to digital, provisional to definitive restoration, you can adopt the approach little by little, step by step. So, if I'm given more time, I will be able to elaborate on more detailed workflow. Let me conclude my presentation. Thank you. Dr. Kim, thank you very much for giving us a lot of information for a short period of time. I believe you have a lot of questions, but the Q&A will be held at the end of this session. So if you're watching, you can pose the problem or questions real time on the chatting room, and good questions will receive good gifts. The next speaker, second speaker.
The second speaker is Professor Lee Hyun-jong of Yonsei College of Dentistry. The title is Anterior Cantilevered Implant Supported Restorations, a Third Digital Analysis. Please welcome Professor Lee with warm round of applause.
안녕하십니까. 연세대학교 치과대학
Greetings. I'm Professor Lee Hyun-jong of College of Dentistry, Yonsei University. Thank you for inviting me here. I'm honored to speak here. As Dr. Kim Se-young has mentioned, Dr. Kim Se-young has provided a wonderful explanation on aesthetic prosthesis for anterior region. I want to go into more specific category. Anterior cantilever implant is what I want to talk about today. If you add Pontic, there is major aesthetic plus in terms of prosthesis. So I want to address it briefly. As a dentist, we're always concerned whether the cantilever is okay, whether there's going to be a lot of torque or overloading. How much of it is okay? If we're to use cantilever, what kind of precautions should we have? In the anterior area, 2 implants have been placed here. The space in a lot of cases is not ample. MD space is not sufficient. If the implants are placed too close, aesthetically disasters can occur. As you know, implant to implant distance needs to be at least 3 millimeters. Morphologically, that is okay. At most, you can have 2.5 millimeter, but basically you need to have about 3 millimeters. When you place the implant, at times the space can be very tight. Aesthetically speaking, if 3 anterior teeth are missing, if you replace all with all implants, if there is sufficient space, you can do that. At times we use bridge. If 2 adjacent teeth are missing in the upper and central incisor number 11 and 12, while we're trying to place 2 implants here, at times there can be many limitations. Vertical soft tissue limitation. Let's take a look on this topic. Implanted distance. Soft tissue height is not easy to achieve when you place 2 implants adjacent to each other. If you add Pontic, they morphologically and the gingival contour, you can get more aesthetic results. You can get more favorable results here. Many studies have proven this point. Selena research, there are many researches. 2 implants, when you place them in the anterior area, when you use 2 implants, there are unfavorable factors. It is widely known. In my case, personally, when you restore natural teeth, we come across these cases frequently. 1 central incisor and 1 lateral incisor when they are missing. At times, it can be difficult to place the implant. I use a 1-wing, single-wing Maryland bridge. Same as natural tooth and implant, you can use cantilever the implant supported restorations here. Number 21 is placed and number 22 is Pontic. The patient has been using this for a long time. If you look a closer look at this case, in single implant cases, if you add cantilever, on the cantilever side towards the Pontic, we do not do occlusal adjustment so that occlusal force is concentrated there. At times, there can be food impaction. So on one part of your mind, we have this kind of uncertainty. This year, CIDR released a very good review in single cantilever implant prosthesis and implant prosthesis without cantilever. In terms of survival rate analysis was done. If you look at this result, the 2 graphs, let's take a closer look at the graph on the top.
The blue
캔틸레버가 없는
is
스타일의 임플란트
implant
픽스드
of
보틀물이고
fixed prosthesis
빨간색
without
라인이
cantilever, and red is
캔틸레버가 있는
cantilever
경우인데
design.
상당히 오래 봤습니다. 여기서는
And
옵저베이션 피리어드가
The observation period here was over 10 years, almost 15 years. The survival rate,
또큰 차이가
there's no major
없었습니다.
difference.
많은 다수의 임플란트를 조사를 했는데요.
A lot of
하지만
implants
이제
were reviewed. However, survival rate without complication was also considered.
뭐 생존은 하는데
It is surviving, but there could be problems such as screw loosening. There can be small issues.
생존에 실패했다고 보진 않지만
Even if,
그러면
just
캔틸레버를
because
했을
there's a
때
small
빨간
issue, we don't
라인이
consider that as a failure.
그런 컴플리케이션이 하나도 없이 성공적으로
Complication-free
생존한
successful
확실히
survival.
그 파란 라인인
The difference
캔틸레버가 없는
shows
것보다는
that
좀 떨어지죠.
the one in blue without
그래서
cantilever
뭐
design is better.
자잘한 보철적인 컴플리케이션
There may
보통은
be
읽어보면은
small
스크류
prosthetic
루즈닝이라든지
complications such as screw loosening or porcelain chipping.
기본적인 그 보철적인
The prosthetic
그런
complications
문제점들이
may
하나씩
rise
발생한다는 것을 알 수가 있습니다.
with this
그래서
design.
주로 이제 뭐
In most
디시멘테이션이라든지
cases,
포슬린 치핑 이런 경우들이 좀
there were
보고가
decementation and
되었고요.
porcelain
이런
chipping.
자잘한 문제 빼고는
These are
생존
smaller
자체는 또 오래 할수
issues,
있다라는
but survival
것이
rate
보고가
itself is
되었습니다.
favorable.
그래서 주로 웬만하면은 그 이전 방금 보여드렸던 논문에서 디시멘테이션이 되는 경우에는 이제
When there's
템포러리
cementation,
세멘테이션을 했을
you
때
use
아무래도
temporary
칸틸레버까지
cementation.
달아놓으면
If you add a temporary provisional as well, at times a decementation can occur.
완전 파이널한 레진 세멘을
If
이용해서
you use resin
ER
cement
타입이라든지 이렇게 콤비네이션
and
타입으로 강하게
do
붙여놨을
combination
때는
type
그런
cementation,
디스멘테이션이
such
당연히
decementation
보고가 거의 되지 않습니다.
is
그래서
reported less.
가능한
If possible,
안테리어 칸틸레버를 할 때는
and when you do anterior
임플란트 위치를
cantilever,
잘
you need to
진단 단계에서부터 잘 위치 계획을
set
해서
the implant position
설치구로
accurately at
스크류홀을
diagnosis
나오게끔 하는
stage
것이
so that the
여러모로
screw
유리하고요.
hole is towards the palatal area.
좀 전에 보여드렸던 이
If you
케이스를
look at this
이제
case,
오랜만에 와서
the
환자분들
patient
스캔을 해서
came in after a long
한번 교합이 되고
time, and
있는
I wanted to
상태를
see
한번
how
확인을
occlusion
해봤더니
was being done.
전치부 11번 여기가
In
이제
number
임플란트가 심겨져
11,
있는
this is
크로스
where the
섹션이고요. 뭐
implant is
교합은 그냥
placed.
무난하게
The
되고
occlusion is
있고
okay.
그 펀틱 쪽
And in the
캔틸레버
pontic
쪽은
area, in the
애초에
cantilever
교합이 좀안
area,
되게
the
좀 뛰어났었는데
occlusion,
잘
I
이것이 또
made
유지가
it so
되고
that
있는
occlusion,
상황입니다. 사실
occlusal force is not
개개인의
concentrated
상황에
here.
따라서
It may
많이
differ
다릅니다.
from patient to
처음에는 교합이 안
patient.
되게끔
At
조금
first,
떨어뜨려
I
놔도 또
if
대합체가
you
전출돼서 교합이 되는 경우가
make
많기
it
때문에
out of
늘
occlusion,
체크업할
the
때
antagonist
과도한 힘이
can
가해지지 않고
be
펀틱 쪽에 가해지지
extruded,
않게
but
주의를 하긴
so
해야
that
되는데 이
the
케이스는
occlusal
이제
force may be
대합체가
concentrated.
마침
Therefore, whenever the patient comes in, you need to check the occlusion. In number 23 on the mesial ridge, there was occlusion, and so the occlusal relations did not collapse for this patient. As mentioned, basically, the lingual, you need to make the screw hole towards the lingual side in order to provide a good cantilever design prosthesis. From the diagnosis stage, you need to make accurate diagnosis. In the lower, it's very good. More than upper, it is better to use in the lower because MD width is lacking. Placing two implants can be a challenge. In the lower, you can use cantilever design in this case. Using cantilever design, according to research, the survival rate is not poor. And aesthetically, the gingival height or tooth contour, it can be more favorable. That we have come into consensus, but there are still uncertainties. The cantilever design itself, it is unfavorable compared to the design without cantilever. In this lecture, I want to share with you my 3D modeling analysis, stress analysis. If you have to do cantilever design, you can use this to bear in mind. cantilever length or cantilever connector area form, these elements come into the play. Even if it's same cantilever design, it can differ in the amount of stress it gets. There's a lot to explain here, but compared to a B form, it has higher resistance against the de-cementation. Computational stress simulation was done. On the prosthesis, various occlusal forces were applied. Because of occlusal force, and if there's no antagonist, there's no problem. In the end, because force is applied, so about 1 million cyclic loading is applied per 5 years, so issues can occur. There are many issues, many factors that come into the play: diameter, material, platform, bone level, tissue level, platform. There are many factors. Among these factors, occlusal force and the direction of load, these two are what we can prevent and intervene in by doing occlusal adjustment. Out of the different factors, these two are primary factors that they have the highest significance. The patient's masseter muscle, the occlusal force, does not change due to masseter muscle, where the cusp angle, whether it's steep or not, depending on the direction of the force, there is a high difference in terms of stress. At times, it can differ up to 10 times. This is implant, bone level, and tissue level implant. In this case, the same force is applied, but depending on the angle, in the platform area where stress is concentrated, you can see that the amount of stress increases and decreases. It is the same 200 Newton centimeters, but depending on the degree, whether it's 0, 30, or 60, the amount of stress applied differs. It's the same amount of force. The amount of force is the same, but depending on the direction, the problem which occurs frequently in the platform, in abutment platform interface, the amount of stress that is concentrated here differs significantly. Directional force is therefore very important. In the anterior cantilever design, the combination that we can think of is the upper central incisor. If the two of them are missing, in the lateral missing, we can add pontic. We can place the implant in the lateral and do pontic in the central area. We would place the implant with better bone condition, and we need to consider the antagonist. We need to consider many factors in determining the implant position. There are many factors. In the anterior cantilever design, when placing implant in the anterior area, we need to consider the occlusion, whether there's overjet or overbite, and the occlusal clearance, whether there's occlusion at the cingulum level or incisal area. In terms of stress distribution, these factors show different results. If the occlusion is towards the incisal tip, or some other people, due to different reasons, because of severe overbite or overjet, it can be in contact with the cingulum. There are many variables. I want to give you a rough sense. We cannot model every single case, but I would like to share with you some categories to give you a rough idea. 7 categories will be shared. In the anterior area, 4 mm TS implant, 4 by 10 mm implant is assumed to be placed. This is a central incisor, and the lateral incisor is pontic. This is a cantilever design like this. The occlusal contact, whether it goes to the implant, we need to be careful. It is not concentrated on a pontic. Even if we are careful, there can be contact points made on the pontic side as well. And when a force is applied to the implant, whether it is applied to the incisional edge or cingulum, depending on these different variables,
분석을 한번 해보았습니다.
analysis was done.
그래서 로드 케이스 1부터
Let's look at load case 1 to load case 7.
자료를 한번 보여드릴 텐데요.
This is an analysis.
제 컴퓨터가 약간
I am having a bit of technical issues. To give you a verbal explanation,
다시 키는 도중에 제가 간단히
as I'm restarting my computer, I'm going to briefly give you a verbal explanation. In line with the results,
중요한 내용은 인사이저널 팁 쪽에서
when
힘을 받을 때
strong force is applied to the incisal tip,
힘을 받을 때
or when it is applied to cingulum, and from the cingulum, when the direction of the force is
힘의 차이가 굉장히 많이
applied in from which direction, there is a difference in terms of load, and the antagonist form needs to be considered when designing the prosthesis.
지금 보시면은
As you can see,
일단은 로드 케이스 1이라고 설명을
this
해보면은
is defined as load case 1. There's pontic.
펀틱에서도 조금 먼 쪽에 오블리크한 힘이 가해질 때
When oblique, far oblique force is applied,
쪽의 힘이죠. 그리고 또 달리
cantilever
로드 2는
force is
펀틱
maximized,
중에서도
and
조금
load
임플란트
case
쪽에
2
가까운
is
쪽에 많이 힘이 가해졌을 때
pontic near
물론
oblique.
오블리크입니다. 힘의 방향은
The direction of the force is oblique.
교합이나 가이드를 안 가게 해놓고 임플란트
So
쪽에만
that
힘이 가는 거죠. 이
force is
인사이저
only
엣지 쪽에
applied
힘을
to
가긴
the
하고요.
implant, and it is concentrated on incisal edge. In load case 4, on the load is applied to the cingulum area. Can you see the color? It is shown in darker blue. The darker the color, it means less stress. I'm going to show you the statistics.
로드 케이스 5는
Load case 5 is
중절치, 측절치가
lower central incisor and lateral incisor missing. That is the assumption. The occlusal force is applied to the incisal edge, and vertical force is applied. Load case 6 is lower case, and it is closer to the pontic. And load case 7 is a pontic far vertical force. What kind of differences will it show? Let me show you a table. It's kind of difficult to decipher. This is how I have organized it. This is the result. The top shows oblique force, the top 4 show oblique force, and the lower 3 shows vertical force being applied. In the case of upper, there's very little possibility of vertical force going to the maxilla. The lower images are for mandible. The stress unit is megapascal. The amount of force is actually the same for all cases. Depending on direction and the position, there can be such drastic differences. Please take note of this. Implant cingulum, when the load is applied to implant cingulum, compared to when it is applied to edge. So I defined it as the top part of edge. When the force is applied in the cingulum towards the implant platform, force is concentrated. You can see that the amount of force and stress that is detected is different. In the anterior area, when force is applied, depending on the tooth form and antagonist form, you can see that force can be applied in direction, and in the cingulum area, force can be applied like this, depending on the cingulum form. If we change the cingulum contour, the amount of torque that occurs can be reduced. As you provide clinical treatment, there are many variables, and we need to consider many design. And depending on the form of the antagonist, the occlusal contact may vary.
대합치를 물론 환자들은 대합치를 막 건드리는
The
것을
antagonists,
좋아하지 않는
the
경우가
patients
많긴
don't
많습니다.
like us
하지만
touching
그렇게
upon
대합치
antagonists,
형태가
but
예를 들어서 인사이절 팁
if
쪽에서 굉장히
there's oblique force coming from the incisal,
맞물릴 수밖에
if
없는
there's oblique force
형태라든지
applied to the
사실 이건
incisal
전치부나
tip,
구치부나 마찬가지인데요.
this is the same for anterior and posterior area. If the form of antagonist, if the direction of the force is not towards fracturing the implant, if it is towards the implant platform, in order to design it like this, so we need to do an enameloplasty on the antagonist. By doing that, you can get better designs.
결국에 이제 정리를 하자면요. 이 전치부에서
So
봤을
to
때
summarize, if you look at the anterior area, cantilever design for anterior area in terms of survival rate, it is okay. In terms of stress distribution, we need to pay a lot of attention so that the patient can use it well for long term. Control of load direction is primary factor to minimize the stress, the form and the antagonist alteration, and depending on the design, the load direction needs to be controlled, and this it has immense impact on stress. The antagonist, overjet, overbite, these factors need to be considered, and if possible, you need to consider enameloplasty of the antagonist so that you can provide a good design. When using anterior cantilever design, you'll be able to use it long term without major problems. This is the end of my lecture. Thank you. Please give him a warm round of applause. Because a lot of contents, because they want to deliver a lot of contents, but because of limited time, they're suffering. Let's move on to the third lecture. Third lecture is by Dr. Park Si-chan of 늘푸른 Dental Clinic. The title is Guide to Digital Aesthetic Implant. Consideration for aesthetic implantology. Please welcome Dr. Park with a warm round of applause.
Nice to meet you. So this is the third speaker. The current hot topic of dentistry is digital. So we are talking about aesthetic implant using digital dentistry. Scanners, milling machines, software, and there are many different factors that we have to deal with. This is a new technology, so we need to apply it appropriately, which is not easy. So I'm given a short period of time, but I'm going to talk about how efficiently we can utilize the tools. What we are going to talk about here is that we plan implants with a digital approach, and we do guide surgery, and the final prosthesis would be manufactured, and what tools can be utilized considering what factors. Recently, about 3 or 4 years ago, the situation was quite different from now. CAD/CAM specialized materials have been advanced, and the materials used in analog dentistry has been improved, changed, so that they can be used conveniently in the digital dentistry. So I'm going to talk about the various materials, tips how to use such materials clinically. when we talk about digital tools for aesthetic implant restoration, we need to analyze face, occlusal plane, and symmetry. In the past, we looked at the photos and we just checked them visually with a naked eye. But what references need to be considered with what tools? That's something I want to talk about. For full mouth restoration, I'm going to talk about a full arch ready-made smile. So for a big case, what is important is that we need to transfer the intraoral situation to an articulator. So using a virtual articulator module, we can transfer the patient's oral situation to the articulator to establish a treatment plan. And then whether the plan would be effective or not needs to be checked. Before fabricating the final prosthesis and the surgery, we need to apply the diagnostics before surgery or definitive restoration fabrication. We need to check and evaluate. So mock-up is the process. And how can we apply it digitally? So in summary, for a full arch cases, half of the work is to transfer the ready-made smile to patient's mouth and with just a slight adjustments. So when it comes to digital dentistry, what is useful is that the several goals need to be achieved. First, dentists or lab technicians need to follow simple workflow efficiently, and treatment plan established at the time of diagnostics need to be adhered to until the end. So a lot of preparation is required. If you do not make a thorough preparation, the final prosthesis would have a lot of problems. So from surgery, from diagnostics, a guide needs to be made, and provisional or final prosthesis need to be made in a very smooth flow of work. So the planned prosthesis should be similar to the final prosthesis. So in a digital approach, establishing a proper plan is very important. How can we achieve effective outcome? First, I talked about ready-made smile. So occlusal plane symmetry is evaluated in a model. So half-aligned teeth model can be brought in and evaluated, and the width can be adjusted, inclination or the size of teeth can be adjusted. That will lead to time-saving effect. So the prosthesis is fabricated like that. This looks a little bit unfamiliar to you. This is all-on X type unibody prosthesis. PMMA and screws are used. This is not final but provisional. So it is connected to the patient's mouth, and we check whether the plan is accurate or not. Conventionally, we used a lot the 2D photos. We relied on 2D photos. Depending on the angle of taking the picture from the top, below, or side, the result can be different. So the people working in the dentistry and the patients prefer this angle from above. So when prosthesis is not aesthetically made, taking pictures from that position gives better aesthetic result. So we can check the symmetry as well. So single 2D photos are moving into 3D pictures. 3D images are made for designing. So 2D photos are used, and through computerization, so the designs can be applied to a patient and used for communicating with the patient. Recently, a lot of improvements have been made to intraoral scanners. And the facial scanners are improved quite greatly, and the prices have become affordable. But the facial scanner requires careful handling. It is not easy to do the scanning. There are many variables, the exposure time, how many polygons, and how to handle or treat the data. There are many variables. So the scanners actually turn a collection of many photos. The facial scanner, whether you apply texture or not, makes a difference. With a cell phone, 3D model can be acquired. With the texture applied, much better resolution can be achieved. So if you want more objective model, textureless model would be more accurate. So if you amplify the situation, texture versus no texture. So to get details, and markers are attached to merge facial and facial scans. So dentists are doing very precision work, and if they cannot be merged accurately, that's a problem. Using a program, they are merged 30 micron, 30 to 40 micron level precision can be achieved. So the data can be effective with that precision. So this is the merged data, and the model is analyzed. Incisal edge to the cusps of the molar, that is the line connecting those to analyze. And for clinicians, what is important is where to have the occlusal plane. In terms of overall face, campus line is the criteria. Campus plane, based on it is inclined in the front side or the back side. So this is the analysis. Usually, you can see the change of the screen. On the CAD, orthographic projection is what you see. That's a virtual view. So that is the thing to be considered for designing. a virtual patient with patient data. This was done in 2011, a long time ago, which is remarkable that the virtual patient was made at that time. How to integrate or merge the data for designing work. So 2D smile design is used for various analysis. And recently, this is the courtesy of Dr. Sang-jin Seo. Without a facial scanner, CBCT and intraoral scanners are used. In order to do this, large FOV data is required. The CT has various values. Ounce field units also need to be used to get this data. For full mouth rehabilitation, occlusion needs to be lifted or adjusted. So in a virtual articulator, they can be raised, and it proves to be useful. So people's body do not vary from person to person too much. They are converging on the average values. So analog or virtual articulators, they're rigid. So we cannot easily get mobility information from that. So for flexible data set, premature contacts are removed. Then the plane shows the contact points very well. So virtual articulator markup and facial scan are used in this case. A lot of attrition in this patient. Using a virtual articulator, it is raised. Due to COVID-19, global communication is facilitated thanks to COVID-19. So I communicated with a doctor in Turkey for this, and mock-up file is received by me, and we do 3D printing, and Osstem temporary material is used, which does not generate heat. So it is checked in the intraoral situation of a patient. So data is set. So there was no problem, so we proceeded with the surgery. For full mouth patient, where do we need to start the implant treatment for full mouth case? We start with a denture. Denture should be fabricated to make a surgical guide, and that they can lead to final prosthesis. But in the diagnostic phase, if we actually we need to do the designing so that it can go all the way to the end. So in a complicated case, surgical case, this is a total edentulous case, and denture is seen in the mandible. A denture is fabricated to check the oral situation of a patient. The molars are very tight. So in a temporary, it is extended in a library. So if it is a screw retained is used through relining for accurate surgery. Stuck abutment library can be used. Stuck abutments can be used, and custom abutments are used for the final prosthesis. Stuck abutments are connected after surgery. The VD was quite small, so anterior flaring occurred. So virtual articulator was used to raise the occlusal plane, and on the mandible, orthodontic treatment was done, and on the maxilla, natural force is used. So we didn't transition to custom abutment in this patient. The patient provisional was used until the final, and there was some minor contact adjustments to move to final. At the beginning, in the designing, so the currently using provisional can be used to do the checking. The last step, many materials are being introduced and improved. Clinicians need to understand the new materials and use them a lot. Then the prices would go down to the affordable level. One-piece denture is fabricated. Facial information and intraoral information are integrated. The vertical dimension can be adjusted outside, but the horizontal position of smile can be using Gothic arch trace. For composite, on the chair side, gingival line can be checked. So chair side quick layering can be done with the composites for gingival line, and the prosthetic type needs to be determined in advance. And actually, as I showed you before, this prosthesis is made of PMMA plus screws. So if you use a cylinder, the process is quite complicated, and the patient didn't come back. So the follow-up period was just for about a year. On the chair side, relining stain glazing can be done because of the advancement of the technique, and zirconia is stain glazed at the chair side to make the final prosthesis. So one piece prosthesis can be used, and the zirconia can develop cracks. So hybrid prosthesis with metal frame and zirconia, or metal frame plus PMMA is very promising. So using digital approach, ready-made smile can be made. Thank you. Thank you. So you have introduced a digital approach in many different areas. So we don't have a lot of time, and I will invite the 3 speakers on the stage one more time so that we will have a Q&A session. 3 speakers, please come up to the stage.
As we summarize the questions, we will ask the question to Dr. Kim Se-woong. I think he was out of time.
이름이 다그닥이라는 분인데요. 맞은 부위를 보완하기 위하여 어버트먼트를 따로 빼서 스캔하신다고.
So you remove the abutment, and when you make prosthesis, and they can be connected. Do you think it can be connected perfectly? So would you answer that question? In general, when we do the scanning, especially after surgery, in the process of fabricating a provisional, the area can be covered with blood. And if the implant is in deep position, scanning cannot work very well. So the scan data doesn't have a good margin information. So abutment is removed. Intraoral scanner can be used to scan it, and the scan data can be stored in a library. And original scan data and the one in the library can be merged. Then the margin area can be more clear. Then margin fitting can be improved. Does that answer your question? And we can open the floor for questions to these speakers, or do we, if you want to ask some questions, please raise your hand. Please identify yourself first. I am running Kim and-chang Dental Clinic in Cheonan. Dr. Lee talked about anterior cantilever. If there is a lack of space, anterior cantilever can be chosen if conditions meet. You did talk about the size, a 3.5 size. Can you still use cantilever in that case?
Personally, I use a 4.0 at least in the anterior area. 3.5. It does not, there's no review that says that you cannot use 3.5, but epidemiologically, if the bone level type wall is too thin, I think it can be unfavorable. Personally, I use at least 4 millimeter. Are there any further questions? I'm Kim Jong-yeop of Busan Dental Clinic. I have questions. You talked about anterior cantilever. There's mediodistal cantilever, but because of bone loss in the anterior area, there's buccolingual cantilever force. Did you look at the occlusal load distribution about this as well? To Dr. Park Si-chan, if you have facial scanner, and we all agree that it helps in communicating with a lab technician, but in how many cases do you make a virtual patient? In my case, you do not, the indication is very narrow. What do you think about the indication? So I'll answer first. Thank you for the question. First, mesiodistal pontic cantilever, even if you don't do it in the anterior area, if the clinical crown is longer in the anterior area, I think a prosthesis, all prostheses have a cantilever effect. That is a good point. In the anterior area, even if there is no cantilever force, as mentioned earlier, even if you use the same masticatory force for occlusion, depending on the position of the antagonist and depending on the direction of the force, there can be significant differences. Once the load is applied, to put it simply, the force towards the labial side, it is important to minimize that. Depending on the condition of the antagonist, at times it is not easy. In single position, if vertical design is made and if the antagonist incisal goes towards that area, it'll be best scenario. At times the overbite is minimal, therefore, at times edge bite might be necessary. In different clinical cases, it may vary, but in personally speaking, towards the incisal tip, if there's a strong occlusal force and if there's tendency towards the labial side, I try to minimize this situation as much as possible.
To be honest, I don't do it in all cases. So when a patient is very demanding, once a prosthesis is delivered, adjusting it afterwards is not welcomed by a patient. So demanding patient, I do not use it. In the crossbite or the key is not good. We use the data set. Facial scan itself is not easy to do, and there is a very expensive facial scan. So T-scan and photos are used in many cases. As I showed you in the lecture, I didn't emphasize it due to constraint of time. One shot of CBCT can reveal the face. I believe that's a game changer. So I believe Osstem's product would be very well sold worldwide because of that. So this is an international seminar, and we have many guests from other countries. So I will take a question from a foreigner.
I'm Dr. Nigam Buch from India. I have a question for Professor Hyun Jong Lee. Do you recommend to modify link abutment if we get to have the access towards palatal screw access?
Could you please?
Yeah, do you recommend to modify link abutment?
Link abutment, yeah. Actually, for me, I'd like to use customized abutment compared to the link abutment because here in Korea it's more popular and easy to use, and whatever I can change what I want. But when you use the link abutment, it could be modified also because Dr. Seung also introduced you. There is some availability to modify it to make it a screw hole to the lingual side or not.
And do you require a special prosthetic driver to handle that angulations?
Yes, I use angular driver if I should do that, use that, yes.
Thank you.
네, 시간이 조금 남은 관계로 한 번만 더 받았으면 합니다. 혹시 또 궁금한?
So we have some time, and we will entertain just one more question. Do you have any more questions?
없으시면 제가
If not,
채팅방으로 나온 김샘 원장님께
this question is from the chatting room to Dr. Kim.
아까 저기 김샘 원장 이료 닉네임 이료라고 돼 있고요.
Idio is the nickname. So do you use the link abutment stock one and the customized one, and what is the difference in terms of price as well? I don't quite understand the question. Tie base is also called link. Custom abutment versus link abutment. Comparing those two, which one is more precise and what is the price difference? Tie base is also called the tie abutment. That's a stock abutment. Generally, I use for provisional, for immediate provisional, I use them. And the stock abutments can be used when implant position is good. If not, there's a limitation of using the stock abutment. Outer crown would not be quite fitting. So customized abutment can be fabricated when the position is good. Customized abutment. So customized abutment can be used to address angle problem, margin problem, or position problem. So in my clinical experience, customized abutments are used much more. Of course, customized abutments are way more expensive, and there's a lot of competition in the industry, so the prices has come down drastically. So the custom abutment, can it fit with the Osstem implants? That's the worry we use. Then you can use a tie base. Thank you. I believe there are more questions, but we need to conclude here. So we will choose two good questions to receive coffee coupons. Dagdak is the nickname, and the gentlemen from abroad are chosen to receive Starbucks coffee coupon. So this concludes session 2. We have 3 speakers. Please give them a big round of applause. Thank you very much. So this concludes the session 2. Thank you.
Thank you for the wonderful lectures, and thank you, Professor Kwon Keung-lo, for chairing today's session. Once again, please give them a round of applause. Those of you who have been chosen as having raised the best question, please check with the registration desk. Those who have been chosen as the online best question, we will contact you separately. I'm sure I can see many people have filled up the seats, so there are many guests from abroad. We're honored to have you here today.
I'm so happy that this hall is filled with so many foreign distinguished guests. Thank you once again for the participation and interest in not only the speech here, but also many programs and events being held in the first, second, and third floor of this building. We really hope to have you till the end. Thank you. 네, 그럼 이제 바로 저희가 또 두 번째 스페셜
Next, we'll move on to the second live program. We're going to the booth, exhibit booth. First, we're going to look at K5 and T2. In the first floor, let's look at announcer Im Han-il. Greetings again. As mentioned earlier, I'm back. I'm announcer Im Han-il. Today, I'd like to introduce the major Osstem products here. First is a unit chair K5. It gained a lot of attention at CITEX event, and it has received a lot of limelight since. And now, let's talk with Mr. Hwang Hong-kyu of Overseas Equipment Team. K5 is a wonderful design, and it has been recognized by many awards. It has narrower back and has a tilting function. It provides elevated experience, so you can get design and convenience in one package. That is right. Wireless foot design of K5 allows for more streamlined treatment environment, and with this device you can get sterilized water all the time. Come and experience this product at Osstem Twin Tower. I really look forward towards using this device. What is the next device to be introduced? The T2 has 6 types of multi-fold. It ranges from 15 by 15 to 5 by 5, and it has endo mode. You can get clearer images. You can apply it in different clinical situations. I think it has very good satisfaction. It was sold #1 at GAMEX exhibit. What is the reason behind such popularity? I think it is because it has a convenient dedicated software. You can do mock implant placement, check bone density, and use different implant libraries. Treatment and consultation becomes much easier. You can use it at the second floor and use the software yourself. If you're interested, come and visit us. T2 and K5, it will definitely make your treatment easier. So what kind of other products are available? We'll show you in a short while.
So we'll have lunch until 1 p.m. So we'll have lunch break until 1 p.m. Enjoy your lunch. And during lunch time, please look around the event places. On the dental side, Digital Dental Technician Contest, 8 people's presentations are uploaded in the dental site. So many people have been waiting for this moment. 300 people who connected to us online. And we'll have coffee coupons, and 200 people will get a sweet dessert set. So winners are displayed on the screen. Congratulations. So in the bulletin board, you will see the winners, and we'll have lunch break until 1. So if you go out through the left door of this auditorium, you will find the lunch place, and on the first floor, Trios 5 Experience Zone and Exhibition Hall are operating, and stamp tour gifts will be provided if you get the stamps, and please look around the Osstem product zone as well.
President Choi Kyu-ok, thank you once again. Please give President Choi another warm round of applause. Osstem Meeting 2022 Seoul, which is receiving a lot of attention from dentists around the world, is currently being sent to 26 overseas countries and is being simultaneously translated to English and Chinese. 180 associates from 7 overseas corporates have come to show their support. I hope the Osstem meeting turns into a festival for all participating in the dental field. Now we will begin this third session. I'm sure a lot of you are interested. We're going to talk about the aesthetic considerations for doing immediate implant placement in the upper anterior as well as digital approach. Now let us introduce Dr. Kim Ki-sung, Dr. Lee Soo-young of Seoul Line Dental Clinic, Dr. Im Soo-young of the Line Dental Clinic. Please welcome them to the stage.
Hello, my name is Ki-sung Kim. Hello, I'm Dr. Lee, and hello, I'm Dr. Seung Lim. Today, we are going to talk about. I'm looking forward to the good discussion. So this is what we are going to discuss. Aesthetic consideration and digital approach for upper anterior immediate implant treatment, and we are going to talk about advantages of a guide. Clinically, when we place an implant in the upper anterior, you may have experienced aesthetic failures. The patient was referred to us, and there's a recession in the gingiva, and there's a post-discharging. So, what is the reason of the gingiva recession in this patient? First, as you can see on the CT, the angle is labially inclined, and so when 4 upper anteriors are extracted, not many cases we place 4 implants, but the 4 implants were placed. And if you look at the angle of a placement, it looks like it was immediately placed. If it is a heel ridge, I don't think they would go out of the bone housing. Yes, regrettably, the placement angle is not good. It's labially inclined. In number 11 is outside the bone housing. So flapless surgery was done without an assistance of a guide, I think. So in order to prevent this, we are going to talk about how to adjust the placement angle of implant, 3-dimensional implant placement positions. So in the upper anterior region, in order to place implants, we need to place at the center of the extraction socket, and it is very important in terms of labiopalatal for immediate placement. 2 millimeter of gap that needs to be maintained so that it should be placed palatally. So implant placement is done against the gingival line. 4 millimeter or more distance should be made. So 2 millimeter gap should be obtained to prevent the problem. The implant angulation, it is related to the prosthetic type. Implant axis, if it is in cingulums, the screw type implant can be made. However, if the angle is incisor or labial, cement type can be used. What I want in terms of angulation is this one. When a final prosthesis is made, it should be a little bit palatally, the implant axis should be made. The screw hole like this needs to be made. This is the best implant angulation, but we cannot obtain that always. If you look at this, the second and third one, implants are placed and the screw hole prosthesis cannot be fabricated, but reasonably cement type aesthetic prosthetics can be made. But if the fissure type is too much in the labial side, we will have a failure like the case we saw before. So today we are going to talk about the 3 axes, the important ones, the long axis of teeth and alveolar bone axis and implant axis, the long axis of those, how they are related with each other. First, the teeth and alveolar bone, the angulation should be considered. Lateral, canine, and the incisors have a different situation, and root apex direction is different from patient to patient. So if you look at angulation in the same patient, central incisor 8 degrees, lateral incisor 16 degrees, and canine 23 degrees. So as you go toward canine, the angle is becoming larger. So root apex angulation can affect the implant placement angulation. Class 1 apex is something like that, but in the central incisor, lateral incisor, canine, more than 70% is class 2 type. It is labially inclined. That is the cases we see a lot clinically. So we'll talk about these two. The tooth implant angulation, the tooth axis and implant axis needs to be closer to tooth axis. That is restoration-driven regulation, and implant is placed toward the alveolar bone. So this is surgically convenient, surgery-driven angulation. In actual patients, if you look at here, the root apex is type 2. So it is more labially angulated. So the tooth and alveolar bone axis are diverged. In this case, especially personally, I think I prefer surgery-driven angulation because so after placing an implant in the anterior, so we need to get initial stability more than 30 Newton centimeter. If restoration-driven angulation, so it is not easy to get initial stability. So palatal bone needs to be secured, and we can place long implants like 13 millimeters for better initial stability, and the labial perforation can be reduced. Therefore, I prefer surgery-driven angulation. What do you think? I believe you prefer restoration-driven angulation. Yes, I like restoration-driven angulation because of retrievability. For various reasons, retrievability should be secured, and the prosthesis sometimes need to be retrieved because of gingival inflammation or contact loss or fracture of a prosthesis. So prosthesis needs to be removed and modified. So in the upper anterior, there was a porcelain fracture. If it is permanent cemented type, the prosthesis should be retrieved. But if it has a screw hole on the right, the prosthesis and abutment was disconnected, and the crown is separated, and it was repaired outside of the mouth. So in terms of repair, this provides good convenience. As I said before, the implant angulation is related to the angulation of prosthesis. Recently, I like ER-type prosthesis. In the past, ER-type prosthesis required like a screw-type implant axis. It should be on the singular, but recently, angled torque driver can be used. So the axis of implant can be adjusted within 20 degrees. So retrievability is the reason why I prefer ER prosthesis. I agree with Dr. Kim as someone who majored in prosthodontics. So as a dentist, it is easier to manage if we have retrievability. Actually, we are talking about the immediate placement, and there are different types. Type 1 is something I prefer. Labial bone or gingiva are remaining, and the extraction and placement is done. In this case, bone graft, which is not quite familiar, can be avoided. And so that is more convenient. So this is the type I want to use. And the digital planning software can be used, more accurate. And we can communicate with the surgeon for the planning, and the remaining bone and gingiva can be identified, and the retrievability that we want to have and aesthetics can be acquired in the planning. So this digital planning is what I prefer. I also retrievability of maxillary anterior region is good, but what my question is, compared to tooth axis, implant axis, how much angulation can be acceptable? So prosthodont ER type for retrievability can be achieved. When I design, maybe 10 degrees, up to 10 degrees can be accepted, but beyond that, it's not possible. What do you think? Then let me show you my clinical case. So upper anterior ear implant prosthesis using one guide system, and the clinical application of angled torque driver in the upper anterior at number 11. The crown fractured, and the guide surgery was planned for implant placement, and a traumatic extraction was made, and one guided drilling was done for guided drill, and implant was placed sufficiently palatally and in sufficient depth. After osseointegration, the next step is important. Screw-type temporary prosthesis is used for subgingival contouring, which is very important. So soft tissue contouring is done that appears similar to adjacent teeth. So impression coping is used for impression taking, and prosthesis is made. CAD-CAM custom abutment and final restoration is done. So from the implant planning, angled torque driver was considered when I determined the axis of the implant. So 20 degrees inclination of this needs a little bit of modification of abutment. The palatal side should be open sufficiently, so 20-degree angled torque driver can enter, and in the prosthesis 1.5 by 2 millimeter hole needs to be made so that the driver can access. So in the mouth, they are connected. So abutment screw is tightened and loosened, and that is checked, and abutment is delivered, and the final cement is done. So ER-type prosthesis was fabricated with a hole. As I said before, ER-type prosthesis, so that is one of torque drivers. Angle torque driver, the width is 1.25 millimeter. The head is like a soccer ball, so it has many faces, and abutment screw can be tightened, and the up to 20 degrees can be accepted. So palatally, the hole can be made. However, there are some limitations. The torque driver limitation is 20 degrees. So in this case, the implant axis was determined based on that. As Dr. Lim said, here, the alveolar bone and the tooth axis are over 20 degrees, so angle torque driver it doesn't work for ER-type prosthesis. So there is some limitation in the angle. So up to 20 degrees, it's much more than I thought. So personally, I think in our hospital, more than 90% of the cases we use a cement type because it is angled, and I thought the retrievability is not possible. 20 degrees is quite a big range of angles for retrievability of ER type. Dr. Lee, I believe you use this technique a lot too. Yes, if you look at panorama or photo or CT of a patient, the crown that will be made later is hard to envision, so we cannot just determine it will be 10 degrees or 20 degrees angle. So at that time, we need to use digital planning. If you use digital planning, as Dr. Kim or my favorite ER type can be made more easily. If you look at this case, the access hole and the actual implant, there's a 20 degrees of angle.
In this case, we can consider ER type. If you look on the left, you can see that the access hole is positioned in the cingulum. The implant is placed here, but in this will lead to implant being placed outside of bony housing. It will lead to a result that we saw earlier. If you just randomly place the implant, then it will lead to such catastrophic result. On the other hand, if you look on this side, if you get the sufficient stability and if it is placed in the bony housing, the access hole will be positioned on the labial side. We need to adjust the implant placement in between these two. If you tilt it slightly, the access hole is here within 20 degrees. If it is possible, implant placement angle can be tilted slightly. I'll show you the planning software briefly. As you can see, if you align like this, prosthetically, you can see ideal prosthesis, but the implant itself is placed outside the bony housing. So we're going to tilt it so that the implant can be placed within the bony housing. It is slightly towards the incisal. How will it be like if we adjust slightly using this software? You can see that labial or palatal area, sufficient bone is there. 3.25 diameter was used first. If the bone housing is okay, then you can increase the diameter of the implant as well. I changed to 4.0, and after that, angle torque driver is used. So within 20 degrees, we're going to check whether it can be tilted. Clinically, when you see various patients, at times you cannot do this. In those cases, I just place the implant in a surgically favorable position. After doing that, the prosthesis would be cementation type. There's a major plus in using the planning software. This is the abutment that was fabricated. The angle driver was used. You can see that it can be accessed from the palatal side. If you look at Dr. Kim's case, it was quite interesting in the past. When I didn't use digital dentistry, I did that. When abutment came from the lab, we would increase the screw hole towards the palatal area, and then we fit it and check the crown. You need to check whether the angle driver can access it mechanically. If you look at the planning software, which I've just shown you, you can check the abutment or the final restoration that goes up on top. But the access hole, you don't need to manually punch it in the designing phase. You can check it so angle driver can access it for sure ahead as you design the prosthesis. In the case of this crown, you do not need to do any manual work. It is absolutely accessible by the angle driver. As mentioned earlier by Dr. Lim, if it is within 20 degrees, that is the premise. It's not easy to do this. If you line it hard, long and hard, to get it within 20 degrees, and in the apical side, if the labial bone is too thin, you have to wonder whether it's going to be maintained. How can we compensate for this? This is something that always was on top of my mind. In the case of the upper anterior area, in order to prevent long-term recession, the labial bone needs to be preserved. The labial bone needs to be thick. As shown in this case, if there's apical lesion and if there's bone loss on the apex side, in this case, if you look clinical situation, perforations are frequently observed. You have to do graft in this case. If the gingival line is ideal like this compared with adjacent teeth, if this is maintained, that is the key. If we make circular incision or vertical incision, especially if the biotype is thin, recession is bound to occur. That's inevitable. When you do immediate implant placement in the upper anterior, in order to avoid a recession and to do graft, what kind of techniques can we apply? This is a EBF, aesthetic buccal flap by Steekman. In the keratinized zone, horizontal incision is made and 2 vertical incisions need to be made so that you can access the apex side, and on the apex side, if there is perforation, you can do the repair. Or you can graft up to here and make the labial plate thick. You can try outside graft on the apex side if there is perforation. In the cervical area, without touching the cervical gingiva, we can do the graft here. I think it's an excellent technique. In this patient, I planned it like this. If the angle is like this, then it can be said as restoration-driven angulation without perforation. It seems viable, however, the residual bone is too thin. The problem is that in this case, it is very difficult to get primary stability. In my case, I provide fixed provisional after providing immediate implant placement. Therefore, in my case, I tend to choose surgery-driven angulation. I tilt it by 25 degrees. That is the design. As mentioned, if you use the surgery-driven angulation, you can get contact with more sound bone and more stability can be gained. If necessary, you can use up to 30 millimeters of implant. EBF technique is slightly different. In the keratinized zone, horizontal and vertical incisions are made, but if you make a vertical incision, this kind of scar line can be problematic in the future. Therefore, in my case, at mucogingival junction, I make horizontal single incision. And I ablate it. This is going to be called as junctional epithelium. If you make a single incision, there's going to be less scar, and flap opening and suturing becomes much more easier. EBF of this type is favored by me. Temporary provisional is inserted, and it is fabricated. Let's look at the actual video. Extraction was done. On the apex side, already there's a perforation. GBR is necessary here. I do not open flap here. And I use the guide that I fabricated, do drilling, and place the implant. You need to drill in a slope, therefore it is better to use guide to place the implant in the accurate position. For long-term maintenance of space, I prefer xenograft in this case. At mucogingival junction, incision is made. I do not approach just the apex side. I ablate to the coronal side as well, so that graft material can come up to this point. In order to augment the labial bone, I fill up the perforation and augment the labial bone. The most important thing here is that it needs to be tension-free. With sufficient incision, it needs to be tension-free to prevent it from opening. By minimizing scar lines, 6-0 suture needs to be done. 6-0 is used for suture. How long do you give healing period? It depends on the primary stability, but if you get 30 Newton centimeter, I provide a final prosthesis within 3 months. Soft tissue is scar-free. Because this area, it's margin, so you cannot really see it. I'll show you a follow-up case. After healing is connected, I send it to prosthodontic department and the provisional is delivered. Like this, an EBF case, let's look at the follow-up. It was a similar case. I chose the surgery-driven angle. Perforation did not increase, but because of the labial plate was very thin, in order to augment it, I did EBF. Additional, on the outer side, graft was done using xenograft. You cannot see the scar line. It's at 3 months. If you had done suture because you do mucogingival junction, you cannot really see it. After surgery, this is 3 months. This is after 3 years. You can see that on the labial side, the form is maintained. I think the type of bone material you use is also very important. There's a lot of bone here. I don't think that's a bone exactly. I think it's not melting away. If you use allograft, a lot of resorption can occur, but if you use xenograft, this kind of bone can be maintained long term. It's a dilemma. In most cases, I place implants in the surgery-driven manner, and I do cemented prosthesis, and I use temporary cement. I use cement quite frequently, and I don't want to face cases where it's dislodged. At times, around the implant and gingiva, there's inflammation. I observe that very frequently, and during follow-up, when I remove the crown, you can see the excess cement over there. It's causing problems. The problem related to cement, it's a challenge for me. What's your opinion on that? In the anterior area, I do not use temporary cement. Regarding excess cement, I'd like to give you my 2 cents. In my opinion, what is important is the abutment margin. In most cases, in the upper anterior, for aesthetic reasons, I always use CAD/CAM abutments. The margin location. In most cases, labial margin needs to be 0.5 to 1 millimeter subgingival margin. If there is a gingival recession, there can be aesthetic issues. However, if you do soft tissue contouring sufficiently and to stabilize it, take impression and then provide a restoration, gingival recession does not occur significantly. So I do about 1 millimeter of subgingival. In the palatal side, I do supragingival. So at times, I use equigingival or supragingival margin. On the palatal side, the implant cementation process is done. If you look at the video, I'm going to provide more explanation. In my view, minimal cement needs to be used. As you can see, this is much less than what you normally apply. In my case, I just use minimum amount of cement. and do setting. In the setting process, I do it very slowly. It is done in a very slow motion. After that, I remove it and I check the amount of cement. Currently, the amount of cement is appropriate, and now I'm attaching again. If it's lacking, I can add more. If it's too much, I can remove it and start from scratch. The cement that I use is resin modified glass ionomer cement. Just because you detach it once, it does not affect the amount of bonding. To provide you a summary, I just use minimum amount of cement, and I set very slowly, and I check the amount of cement and then attach it once again. Before that, what is absolutely necessary is that our abutment margin needs to be where we can remove cement within the oral cavity. What's your opinion on that, Ms. Dr. Lim? I agree with your opinion on that. Margin position is very important. When I looked at the video, the amount you mixed way much than what you use. I use 3 times. I think your dental clinic is more luxurious than mine. How can we approach it using digital technology and find the right margin? I think cement issue is very important, especially in the anterior region because of the aesthetics. In order to maintain gingiva in a healthy and beautiful manner, cement is a very important issue. There are 2 issues. We can use ER type. The crown can be removed along with abutment. In this case, it's not a problem because we can remove the excess cement cleanly and we tighten it in the oral cavity. If we can make ER type, or at times I use titanium one-piece abutment. This is something that I prefer. But there are limitations to this. In the case of thin biotype, you can see the gray area here. In this case, there are some issues. In this case, if I can make an ER type, I position the margin 1 millimeter deep and then attach it again. I use angle driver here. That is possible, but if you cannot use the ER type here, or even if you can use the ER type, if the biotype is not thick, in the cervical area, if you can see through, it can cause problems with aesthetics. In this case, I use hybrid abutment. You need to divide a hybrid abutment. It can be divided as meso part and link base. Meso part is what is fabricated by the lab, and the manufacturer provides a link base. The superstructure is designed and milled, sintering is done, and you attach it to the base extraorally. And by doing that, you can remove excess cement, and then you can tighten it in the oral cavity by appropriate torque. The benefit in doing this is that the position of the margin can factor in the gingiva. Adequate gingival margin can be achieved. The meso part is made of zirconia, therefore margin line is not really visible, and in the cervical area it looks very bright, therefore it does not harm any aesthetics. I use this very frequently. Up until now, there were limitations. Digital dentistry was not really widespread in the past, as much as it is now. From manufacturer's perspective, making different types of link must have been quite tough for the manufacturers. So the gingival height was only 0.1. There was only one version. In this case, emergence angle can be very hard to achieve. In the case of posterior area, it's okay, but in the anterior area, if there is only 0.6 degree, if you have such a steep emergence angle, so appropriate emergence profile cannot be achieved. As Dr. Lee has mentioned, we prefer about 3 millimeter of gingival height. Fortunately, Osstem has released a public B. This is a link abutment. The prosthesis height is 4 millimeter. And there's also another option. There's open type. When you design a lower interior, you can have various options. It is very good for excess removal.
because gingival height ranges from 1 millimeter to 4 millimeter. You can check this in the digital dentistry, but you can choose public B-link abutment for appropriate gingival with appropriate gingival height to make an appropriate restoration. If you look at the image, one guy was used for implant surgery. We were able to tilt it. We used the angle driver. Hybrid abutment was used, and the margin was equigingival margin. It was easy to remove cement. This was a similar case to a hybrid abutment. When I use it, I make the margin equigingival margin. This is a typical case we see. This is an implant that is not placed prosthetically favorably. I want to place the implant here, but actually that's not possible. In order to make the implant within the orange bone housing, you need to place it as shown in the orange. Opening a hole now faces the labial side. In this case, a link abutment is used, so you can remove cement in the cervical area and you can get aesthetic result. You can catch two birds in one stone when you use this product. I think I'm almost up with the given time. Dr. Lim, the 4 anterior case that Dr. Lim has shown using one guide. You said you were going to use one guide future on? After choosing this theme, there was a patient who came. So I wanted to present this case. Implants were placed last week. 4 implants. The patient wanted to remove them all. Such inflammation, I think it's better to go delayed. But the patient did not want any removable prosthesis. At the time of implant removal, the patient wanted fixed implant prosthesis. That was how it was planned. The 4 implants were removed. Number 12 and 22 implants were to be placed, and temporary provisional were to be provided. Then number 11, there was roof. I thought I could remove it because I'm not going to place the implant. I think the person placed the implant flapless. The patient wanted immediate temporary restoration after implant removal, therefore I used one guide to place the implant. As shown, when the bone quality is bad, you need to do accurate drilling to do implant placement, and it's very difficult to do so freehand. If you use guide, it could be of help. In order to solve the recession, CT graft is necessary. Connective tissue graft was done, and temporary provisional was provided. The design was like this. A distal angulation was done. I thought that there would be more bone here, and did labial angulation to get more contact in the labial bone. I thought 11.5 would suffice, but when you open, the reality is always different. You can see a larger bony defect due to the residual root. Between number 12 and 11, I thought there was going to be septal bone, but there wasn't. I was not able to get stability from the lateral wall, so I changed my plans to number 13. Fortunately, I was able to get stability above 30 newtons on both sides. ISQ values of over 70 were achieved. Fortunately, temporary provisional could be provided. Volume maintenance is very important, therefore I used the xenograft for bone graft. Personally, I prefer PRP. PRP is very important in volume maintenance. Resorbable membrane was used, and CT graft was done for one-time surgery. This is after surgery. Prefabricated custom abutment and temporary were delivered on the same day.
You used the guide and provided a nice treatment. In number 11, this was a failed implant. I was able to remove it very easily. In number 21 and 22, I used a tool to remove it. EIR kit was easy implant removal kit was used. If you use it, you can remove implant in all cases. You can remove it atraumatically. As a clinician, this tool was really wonderful. In the past, I used trifine burr, but if you use that, you would remove all the bones. So the tool were really effective in removing failed implant. The residual root was much bigger. It's not root rest, it's just a root. CT graft was done. Personally, this is something that I've learned from you. So using one studio, I was able to fabricate it. I think I'll be more active in using it. You got the primary stability, yes. I worried about number 12, but I used the 4.5 by 13, and I used AOS with PRP. AOS is there. You can maintain the volume. You do not need to use non-resorbable membrane. Even if you add saline, the form is not damaged. This is absent bone. I think this is space maintaining bone. And resorbable membrane can help with healing. CT, how you apply the connective tissue graft. I connected to buccal flap, and free CT becomes a buccal flap, and you can suture it with the palatal flap. If the connective tissue is fully exposed, the blood supply can be a problem. Therefore, this connective tissue graft is very important in preventing a recession. I think it is very good if you do it together with bone graft. This was how I completed the case and provided provisional. Before extraction, I looked at the tooth axis and alveolar bone direction. If the angle is narrow, you can provide prosthetic-driven angle. In the past, I didn't consider it, but now I'll probably provide a prosthesis like this. I think retrievable prosthesis is better, but if the angle is beyond the 20 degrees, I think it will be surgery-driven angle. I agree.
So in many cases, the tooth axis is the incisor side, so bone housing and access hole angle needs to be within 20 degrees when we plan, or otherwise we can do surgery-driven angulation, or we need to go to cement type. And hybrid abutment needs to be utilized for aesthetic results and for the health of gingiva. So that is the summary of what we have discussed. What about the conclusion? Yes, the conclusion. There are 3 items. So maxillary anterior region is a challenging area. So angled torque driver, the recently launched one, can make ER-type prosthesis much easier, the screw type. And EBF technique is recommended if labial perforation happened, as you showed. It has the advantage of maintaining gingiva margin while allowing grafting at labial area. So it was explained in the morning, but one guide digital surgery is recommended if anterior immediate implantation is planned. for accurate positioning and angulation of an implant. So do you have any more comments? So this is a very good opportunity, my honor, to be with you. EBF, modified EBF may be the correct name. So regarding that, I learned a lot in this opportunity, more than anything else. So surgery-oriented person, expert, has been invited into this world, so it is my honor. I also, to be honest, I didn't really prefer to use a guide. It is cumbersome to send it to the center and they get it back, but you said it can be done within our clinic, and I installed the studio and used it, and it's fun. And I think I will use more guides because it can be printed in the clinic. So today, we talked about this topic, and I hope this has been helpful to all of you. And discussion is finished. Do you have any questions? First, if you have any questions, please raise your hand from the floor. Microphone.
I'm Dr. Burak Yurtbilir from Bornomar Clinic, Turkey. It's a great pleasure to be here with you, and thank you for your great cases and discussion. My question is about coaxial self-angulated implants. Some other brands produce this kind of implants, and they called as site-specific implants. My question is, have you ever experienced or heard about this kind of implants? If your answer is yes, what is your comments, especially in prosthetic point of view? Thank you.
이게 좀 알아듣기가 조금 어려운 상황인데.
Actually, I don't understand English quite well. It sounds like a prosthodontic-related question. Would you say that again very slowly, please?
Some other brands,
some other brands
produce coaxial self-angulated implants.
angulated implants.
They called as site-specific implants.
Okay.
Have you ever experienced about this kind of implants? Especially in canine area, there is no any possibilities to make correct angulation, and there is no any possibilities to make screwable prostheses. My question is, have you ever experienced about this kind of implants? If your answer is yes, what is your comments, especially in prosthetic point of view? Thank you.
자, 그러면은 이제 말씀하시는 게 저희가
So what he's talking about, we have talked about custom and link abutment, hybrid abutment. The question is, as among the, he's talking about angled implant, implant with an angle. I believe it is from Bornomar. Is he talking about from some other manufacturer? So angled abutment, if it is used in canine with a severe angle, have you experienced angled abutment? Angled implant. Okay.
I don't have that kind of experience. But how about you? 어떠세요? angled implant을 사용해 본 적 있으신가요?
Have you experienced angled implants? No.
As we said, there is a tooth and the bone is maybe more than 30-degree angulation. But even if so much angulation, we can place the surgical angulation, and after that we can use the custom abutment or angled abutment. We can solve that problem. I think we don't want to do the pre-angled implant. Yeah, surely.
네, 또 객석에서 질문이 있으신
Any other questions?
네,
임세영 원장님 그 아까
Okay, Dr. Lim,
호라이전털 버티컬한 거고요. 전치부에서.
you talked about horizontal and vertical in the anterior region. I'm here.
저 여기 있습니다.
I am here.
그 굉장히 저는 왜 그런 생각을 못했을까 하고
It was shocking. I was thinking, why couldn't I think about that too?
볼을 넣는 방법
So,
소개가 돼 있었잖아요.
bone grafting using a tunnel, and do you use a tunnel technique in the posterior region as well? In the anterior region, the detachment and periosteum is detached, and what is the correct amount of detachment? In the anterior region, the vertical envelope is easy to access, but the vertical incision would remain as a scar, something I don't want. So that's why I use horizontal incision. Apical perforation. Grafting is also goal, but I also detach at the top. So, but I do not touch the coronal part because if I do it, it is like a full incision. So I ablate from the coronal side, and then bone is grafted, and labial plate can be formed to prevent gingival recession. In the posterior region, I don't prefer this technique. This is for aesthetic purpose. So in the posterior region, I use normal standard incision. So, Dr. Kim?
네, 정말로 아주 좋은 강의였다고 생각하고.
Thank you for the wonderful lecture, and prosthetically and surgically and periodontally, it was a very meaningful lecture. I majored in oral maxillofacial surgery. My name is Kim Yong-rae. Next to me, there's Osstem's president. I asked a question. You two have a lot of experience in the upper anterior area. For angle, 10 degrees, 20 degrees. In the past, when I used Browning mark in the upper anterior, 10 degrees to 15 degrees, there was an abutment that tilted twice. It was called angled abutment. And 15 degrees, it was angled. And you fix it, and then on top of it, you use a screw retain the angled abutment. These days, from Osstem, I try to find it in the lab. We cannot get it. So I asked the president. The president says most probably there are. But the speakers here today, you've used Browning mark for long term. I'm not sure whether you really understand it, but free angled, the abutment that is angled twice. Do you have experience? Does Osstem have that kind of product? Osstem has angled abutment, and it is angled by 17 degrees and 30 degrees. You fixate it first, and on top of that, the prosthesis is delivered. Why don't you use it frequently? As Professor, you have mentioned in the lab, it's not widely available because we have transitioned to digital dentistry. In order for you to have that, you have to have a lot of stock by size, and there needs to be A type and B type depending on the facts. Whether it is towards the face or if it is towards the surface, because it is angled, the angle, it is tilted depending on the implant angle, you need to choose it. But clinically speaking, within 60-degree scope, it is not easy to do it. Even if you connect it, you need to adjust it so that the surface looks pretty when you place implant using the upper, unless you use guide the hex position, it is difficult to place up to the hex. Of course, There are angled abutments without hex. In those cases, within patients' oral cavity, it is difficult to transfer. In the past, when digital dentistry was not widespread, that was the only option you had. Or else you had to make UCLA abutment. A lot of people use that now, but now we can easily make a custom abutment. Therefore, from the lab, they don't really have the stock. They just fabricate a custom abutment. That is the recommendation these days. And as a clinician, you can use a custom abutment almost like a stock abutment. So in Osstem, you have a free angled abutment. Yes, we do. About 25 years ago, the patient got fractured bridge. In order to replace it, I couldn't find the component. In the end, I had to do cemented prosthesis. In this, if you scan it and send it over, you'd have gotten an easier solution. Thank you.
Dr. Kim, I have used angled abutment. It is not used very much because on the labial side, so unless you place it deep, there is metal showing on the labial side in the past. So it should have been placed deep, otherwise the metal would be showing. Due to constraint time, we need to address some chatting questions and any technique to tighten 36 degrees or more. So there are two things. If you do not use a guide, I feel the bone quality at 2 millimeters, whether final underdrilling should be done or to follow the standard protocol is determined. If you use a guide, the advantage of that is that you cannot feel the bone quality. So the bone quality is not felt. So I check house field value. If it is under 800, I decided to do underdrilling from the beginning. And if you go as planned, if 36 or more primary stability is not achieved, you can increase the length. So we don't use the 5 millimeter in the anterior region. We can go up to 4.5 the diameter, or we can after that we can increase the length. So that's the way to go. So due to constraint of time, we will give the best questionnaires from the floor. The doctors, I don't know the names, but I thank you and congratulations. The Shula is a nickname who asked the question. He is selected, chosen to receive the gift. This concludes the discussion. So I felt that during discussion with these two doctors, the digital approach it makes the ideal objectives can be easily achieved using digital approach. So all the speakers in the morning and during this discussion, I feel that one guide, the digital dentistry tool is quite powerful and effective. Do you have any further comments? It was my honor to be invited here, and it was a very interesting topic, and I had a good time. Thank you. And I feel the same. It is my honor, and I will learn more digital dentistry. So, analog master is entering into the digital world. That is the big achievement of this discussion. And Dr. Seung Lee and all the doctors, thank you very much. And all the doctors who joined us online and on this auditorium, thank you very much.
Thank you, Dr. Kim Gi-sung, Lee Soo-young, and Dr. Im Seung. So, it's the time we've all been waiting for. There's going to be a coffee coupon event. You get to win not just coffees, but also the delicious dessert. A total of 600 people will be able to win these amazing prizes. Let's do the lucky draw. On the screen, there are the winners here. There are so many people. A total of 600 people won the prize. Please refer to the notice board on the dental site. Those of you who have won the prizes, coffee coupon will be sent via text. Now it's 2:35 right now. We're going to have a brief break for 8 minutes. The fourth session is live surgery done by Dr. Kim Young-jin and Dr. Son Young-hee. I look forward to your keen interest. See you soon.
Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 millimeter short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. Presenting the IM-Cure kit. The IM-Cure kit is used when you're treating peri-implantitis. When you treat peri-implantitis, the two-step polishing technique uses a smart brush and a smart scaler can minimize damage to the implant and remove inflammation. Treat peri-implantitis with the IM-Cure kit. Introducing the MS kit. The MS kit is designed exclusively for MS implants. The MS kit is designed exclusively for MS implants, which are used in areas where the bone is narrow, such as the anterior mandibular region. With the MS kit, you can place an MS narrow ridge, MS denture, or MS provisional implant with a quick and simple procedure. Try using the MS kit when placing an MS implant. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic one-jet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. One-jet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, One-Jet LCD. Introducing the Digital Lab Analog offers 3 advantages when you're creating a digital working model. First, you can place the dedicated positioning jig in its correct position with great precision and in line with the direction of the hex. Secondly, the triangular shaped holding component at the bottom, along with the screw, prevents unwanted rotation while fabricating the prosthesis. Third, easy removal of a lab analog from the model without any damage is to unfasten the screw. The Digital Lab Analog creates an error-free digital prosthesis. Introducing a link abutment is used for aesthetic restorations placed in an interior region. The crown component of a link abutment is made using zirconia, which helps produce a natural-looking crown shape and obtains the appropriate cervical color. Even when you're placing a prosthesis in the anterior region where space is narrow, using an open-type base can help fabricate the implant without removing any structure. The link abutment lineup features products that can facilitate different heights and gingival thickness requirements. Clinicians can select the right product for a specific placement condition and the patient's intraoral environment. Try the link abutment when placing aesthetic implants in the anterior region. Introducing the 2 key strengths of the SM3, the dental engine that provides strong and stable torque. First, the 20-to-1 gear ratio provides a strong torque of max 80 Newton. Drilling can be easily performed thanks to its strong torque. Second, the SM3 can maintain a constant torque level thanks to its handpiece calibration function. Try the SM3 that can maintain strong and constant torque of 80 Newton. With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically, which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have 2 separate buttons, each for focusing and image-taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neckline is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth with inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients.
Osstem Meeting 2022, we will now start the fourth session. Now we will go to the first floor exhibit booth once again. We will look at the KS system and the newly launched, which is looking for a new launch of Trios 5. I look forward to the products. Let's call announcer Im Ha-neul. Miss Im Ha-neul, please come in. Greetings everyone, I'm announcer Im Ha-neul. It's currently 2:45. Are you enjoying 2022 Osstem Meeting Seoul? I'm sure you're looking forward to the products that I'm about to introduce. They're very special. The first is TS Systems upgrade version. It's the KS system. What is the difference? Let's look at it with team leader Seonbo of Overseas Implant PM team. KS system, can you tell us about it? KS system is a combination of Osstem's know-how. The internal design is the biggest that is different. Compared with the existing product, the connection is narrower and deeper with 2.4 times the strength. Below the abutment, there are 3 little components. This allows us for us to sense that implant and abutment has been connected. You can get the tactile sense, thereby minimizing connection error of prosthesis. If abutment is connected right even before screw is tightened, the connection with the implant is held. Therefore, you can use it very conveniently. I believe you can use it on site. The next product is the last. It is absolutely the highlight of today. This is first shown in 2022 Osstem meeting. Team leader Cho Sung-gun of Digital Implant Project, could you provide details? What product are you going to provide explanation of? This is Trios 5 of 3 shape. It is launched for the first time. I'm sure you've looked forward to it. We are now unveiling it in Osstem Meeting 2022 Seoul. This is a reveal for the first time. What is the difference? Compared with the product, it is 30% smaller and 20% lighter. Therefore, it's much more convenient. Via Wi-Fi, data is transferred between treating rooms. It has new LED vibration feedback function, among others. Come and check it out. The trios, the renewed trios, I'm sure it will meet up to your expectation. How did you enjoy Osstem Meeting 2022? If you come to the first floor, you'll be able to enjoy much more products and different events. We are here until 6 p.m. If you're intrigued, please come and visit us. This was announcer Im Hanil. That was great. I think you should definitely go there yourself to check the different products out. I hope you go to the first floor and see the exhibit booth. There's also product display room in the second floor, so please go and see for yourself. Next is the highlight of Osstem Meeting. It's the live surgery. The live surgery will be done by Dr. Son Young-hee and Dr. Kim Young-jin. The chair will be Dr. Kim Kyung-won of Twin Dental Clinic. Dr. Kim Kyung-won has graduated from Seoul National University and he has completed maxillo-oral facial. He's a specialist of oral maxillofacial surgery. He's a dentist at Twin Dental Clinic and Director of Education and Research Institute at Osstem Implant. Let's call out to Dr. Kim Kyung-won.
안녕하십니까. 김경원 원장입니다.
Hello, I'm Dr. Kyung-won Kim, Osstem Meeting 2022. So, the highlight of the meeting is the live surgery. And through the discussion of three speakers, I believe it was a very fruitful time. And they talked about one guide. How much of one guide have you used in this live surgery? Dr. Young Hee-son of Ijeon Dental Office and Dr. Kim Young-jin of Pocheon is going to talk about how to maximize aesthetic effect in the anterior region by using one guide. So live surgery will be done. First, let's hear from Dr. Son Young-hee regarding the treatment plan. Good afternoon. My name is Young Hee-son from Ijeon Dental Office. 2022 Osstem Meeting live surgery will be done with this case. I will briefly introduce the case. First, I'm going to talk about information about the patient and treatment plan, and I will introduce a similar case in order to make you understand the case and the surgery better. The patient is 70-year-old male. Chief complaint, upper anterior bridge has mobility, and he's complaining about the discomfort. Currently, from number 21 and 23, there is a gingival recession, and there's a mobility there. PMH, PDH, no remarkable situation. If you look at the intraoral situation, number 21 and 23 are connected with a 3-unit bridge, and the crest of bulbous is quite severe. And in the posterior region, there are many implant restorations. And if you look at the CT, number 21 and 23 CT views, as you can see, labial bone plate is missing or very thin. If you look at the pontic area, the resorption is quite severe, so implant cannot be placed as it is. To place implants, alveoloplasty needs to be done to place implants. If you look at intraoral situation, number 21 and 23, gingival recession and perigingival swelling, a slight swelling is observed. So before surgery, the bridge is removed, and then after treating, the temporary is maintained. Today, the temporary will be removed and tooth will be extracted. Number 21, 23 will be extracted, and number 21 and 23 immediate implants will be placed using one guide. For number 21, a T3 4 by 10 millimeter. At number 23, TS3 4 by 11.5 millimeter implants will be placed. After the placement, internal external socket grafts will be carried out. For external socket graft, pouch technique will be used for the grafting, and after the surgery, custom abutment and PMMA temporary will be used for immediate provisional restoration before finishing the treatment. One guide design. This is the design for number 21. As you can see, the maximum palate lead is planned. Number 21, and if you look at number 23, labially, they are beyond the safety zone. Implants are placed. So when we place like that, usually the distance between the implant's outer surface and the labial bone plate, outer surface, is called IP, and the gap should be 3 millimeters or more, ideally, so that implants can be free from remodeling. And according to the plan, IBP is less than 3 millimeters. It will be a little bit over 2 millimeters. So, as Testori said, IBP of less than 3 millimeters. An implant is placed like that. Internal and external socket grafts should be simultaneously done. So in the afternoon, we will do the surgery like that. So this is the placement direction. It is we'll try to place an implant on the cingulum, but it is not completely on cingulum. Inside edge is a little bit invaded. That is the direction. This is the design for the template. So the screw hole is designed and the temporary crown is designed. So with this form, the margin is equigingiva margin. So a similar case, due to upper anterior fracture, implant was placed using. I brought this case to show you the pouch case. One guide is used to place the implant. After the placement, the cortical perforation was carried out, and the collagen membrane is fixed with the bone tacks, and the pouch is made, and the graft material is put in there. So a pouch is made, therefore it is called a pouch technique. Urban's sausage technique is different from this. The upper part is open, so that is the only difference. But other than that, everything remains the same. So what we need to do to the open area at the top, another collagen membrane will cover it before finishing the surgery. So in this case, no provisional is made. So the treatment went well, and the final prosthesis is delivered after the delivery X-ray. So pouch technique can be used, will be used with the external socket graft. And when you do socket graft using the pouch technique, maximum graft containment can be achieved, and the graft material, as much as we want, can be used. That's the advantage. In doing the surgery, we need to consider these things to consider. Both implants are to be placed in sockets. So initial stability is the issue. So for number 3, one size bigger implant is chosen to maximize the basal bone engagement to increase the primary stability. And if primary stability cannot be secured, at number 22, 3.5 by 10 millimeter implant would be additionally placed for increasing primary stability. 3.5 millimeter diameter mini implants will be placed, but inter-implant distance would be 2.6 millimeters, which is less than 3 millimeters. So I'll try to achieve a primary stability from the existing 2 implants. So socket graft, internal and external socket graft material. For internal socket graft, FDBA cortical chips will be used, and for external socket graft, considering remodeling, xenograft, EOS, and EOS collagen will be used. The membrane for pouch technique is skied membrane. So it is based on natural collagen, and it is cross-linked. So when it is hydrated and fixed, it tends to be torn out. So hydration will not be done before fixation. So if fixation is not feasible, then memory holding suture will be used to stabilize the membrane. And 1 feet custom abutment, we are the supra-gingival margin would be most convenient, but aesthetically there will be a problem. So acute-gingival margin will be set for the provisional restoration. So this has been the introduction of the patient. And let's go into the surgery. Thank you. So, Dr. Son, live surgery, please. Let me start the live surgery. First, I'm going to extract the tooth in the anterior region. Periotomy is to be used. So it is important to do the extraction atraumatically. Periotomy is used. So in order to extract the tooth easily, so I'm going to extract the tooth. So using just the periotome, and the teeth are pulled out with the forceps. Extraction is very important in this case. If you use an elevator, the alveolar bone would be pressed. So now the extraction is done. And template adaptation. So teeth remained, so the fitting could not be done now. It is fitted and it fits very well. When the teeth designing one guide, on the computer we did the extraction, so the one guide fitting does not always work perfectly, so we need to check. So in this extraction socket, granulation tissue or others are removed. Open the mouth, please. So one guide is fitted again. So the guide is not shaking. It is stabilized on the adjacent teeth. So is the guide fitting? Yes, it's fitting very well. And I'm going to drill into the extraction socket, and the drill can slip in the inclined slope. So 4 by 10, 4 by 11.5 will be placed. So path drill is used right now. So 10 millimeter implant will be placed, and the path drill of 7 millimeter long is used. So extension is used because previously the full length drilling was not done. So 7 millimeter path is used. So short drill must be used first. At number 23. So there's a little bit of resistance. The cortical bone at the palatal side. So not to make the drill slip. Important thing about one-guided system is a double contact concept. So 10 millimeter, 11.5 millimeter is the ultimate drill length. So 7 millimeter short drilling is done first. 13 millimeter path drill is used. So 10 millimeter. The full length is 13 millimeters. So according to the laser mark, up to the second line, 10 millimeter path drilling is done. Now up to 11.5 millimeters, that's the top laser black mark. Up to the laser mark, it is drilled. So the path drill is used to prevent the drill slip. One guide drill is a taper drill. So in the upper anterior, as we discussed during the discussion, path drill plays an important role. So 3.5 by 10 millimeter. So 3.5 by 10 millimeter one guide drill is used. And 4 by 10 millimeter drill is used to the full length. Number 13. .5 by 11.5. So 3.5 by 11.5 full length drilling for number 23. 4 by 11.5 is planned. 4 by 11.5 millimeter. Double contact. The end of the drill and the apex and the template need to be in contact. So double contact should be made to prevent the slipping. So we are checking whether it is a full length drilled. So when we use one guide drill, you may be worried about heat generation, but if you use the pumping action, according to our taste, the heat generation is not a problem in drilling. And the one guide drill that we use has very good cutting efficiency. So you do not need to be concerned about the heat generation, just to use the pumping action. So drilling is completed. Now implants are to be placed. So at number 21, 4 millimeter diameter and 10 millimeter long implant is to be placed. So the implant using no mount driver. So So about 80% of drilling is done up to yellow line, and implant is placed. This is 4 by 11.5 at the position 23. So 80% of insertion is made. Looks like the stability is pretty good. So a drill extension was used before. Now it's all removed. It doesn't happen if we didn't have a drill extension. And it happened because of the drill extension that we used. Unlike one guide drill, no mount driver, there's some 2 millimeter difference. So implant driver is used. Torque wrench is used, and the tactile initial stability is felt to find the final position. So hexa positioning and depth control is enabled using this driver. So initial stability is over 30 Newton centimeter, pretty good. And number 23 position, implant driver is used. Please open the mouth. Now it's inserted. Hand wrench, one guide template, and implanted driver's yellow portion is adjusted. Hex control and depth control can be done. And now the initial stability is over 30 Newton centimeter, pretty good. So the placement is over. Path drill is used by Dr. Son. So the sloped palatal bone, on the bone, the step is made to prevent the slip. As Dr. Son said before, for GBR, the flap is open. Flap will be reflected and GBR will be done. Vertical incision and crestal incision a little bit palatally. So the tooth behind number 23, vertical incision for papilla preservation. So the distal tooth is implant. So to preserve a papilla, the incision is made like that. Vertical incision can be made from top to bottom, but Dr. Son made the incision the other way around, and you can make the incision as you want. In full thickness. I thought the GBR may not be necessary, but number 21 and 23 and the GBR was considered and decided to do it. So if it is placed, if they are placed in the palatal side sufficiently, it would have been okay, but there is some deficiency. So we open the flap completely to do GBR. Labial bone is quite thin. So there was a breach used for a long time, so the bone is deficient in number 21 and 23. Labial bone is very thin. And GBR is necessary. It can be okay at the beginning, but over time, resorption would occur. So when you do GBR, the full thickness is used here. Flap elevation is almost complete. On the palatal side, partial elevation is being made. As you can see, implants are positioned palatally. On the CT, you can see it is the planned positions. Cortical perforation is to be done before GBR for better blood supply to graft material. On the labial side, cortical perforation is made. So what drill are you using? Anchor drill for one guide. So anchor drill is being used to do cortical perforation on the labial bone to provide blood supply to the bone. When you do grafting, some doctors do it before surgery, but Dr. Son placed the implants with one guide, and this is maxilla, so not a lot of perforation would be required. So one guide template. So anchor drill is used to perforate the labial bone. So let me remove the soft tissue here. For GBR, if soft tissue is involved in GBR, it's not good, so soft tissue is removed. As I said before, a pouch technique is to be used. Squide and bone tags are used. A membrane is fixed first, and then graft material would put in. Os guide. Os guide is positioned. You don't really need to trim it. Is it 2 by 3? Yes. 20 millimeters by 30 millimeters, and bone tag is used to fix it. The bone tags in GBR kit can be used. Bone tags are used to fix the membrane. So bone tags are included in the GBR kit. It is a bone tag. It is not bony screws. It's one size. So I was wondering whether it is 6 millimeters. So bone tags are used to fix it. So it is fixed. No, it's not fixed. It's my mistake. So it should go in perpendicularly, otherwise it will bend. So alveolar bone is sloped, where bone tag is applied. Usually I succeed. My success rate is quite high. So it is where nasal spine is located. So the position is not really favorable position. So I will do it again like this. Though it is near anterior nasal spine. Sorry about that. So, and I will move beyond the interior nasal spine. The angle is not very good, so actually this is bent. So also bone tag is good, but my hand is not working very well today. Number 23, it is fixed pretty well. So beyond the nasal spine, it is fixed. So I have never been unsuccessful like this before. So let me do it again. The bone tag included in GBR kit is used. So it'll be fixed at the side. Now it is fixed. Because of the shape of the alveolar bone, the angle was not really good. And we need to secure the volume by grafting. So membrane is fixed and a pouch is made. So upper side of the patient, the bone keeps bent, and I've never had this kind of problem before. Now it is fixed. AOS collagen is used for the grafting. So it is launched recently, AOS collagen for socket preservation. This can be used to make a shape. Below the membrane, the collagen is inserted. Looks like the volume is sufficient. So extra socket. Outside of the labial bone, a pouch is formed, and AOS bovine bone, AOS collagen bovine bone is packed in. So outside is important to keep the shape. So bovine bone, which is slow to resorb, xenograft is used. AOS collagen is used here. So volume is sufficiently secured. And holding on to here, and this will be removed later on the anterior side. It is fixed. So on the labial side, sufficient volume is secured, and the volume is distributed. Using the collagen membrane, a pouch is formed, so the form is made. So at number 23, the same. Over it, over the alveolar bone, it's bottom area of the patient. Now it is bent. It looks like the patient's alveolar bone is very hard. So extra socket grafting is almost done. And now internal socket graft. And temporary abutment will be mounted first. Please open your mouth. Intra-socket graft material will go inside the implant. So before the socket graft, suction please. So inside the implants, we need to prevent graft material go into the inside of implants. Please open your mouth. So one guide is used and hex is matched when implants were placed, and the prefabricated we use a guide with hex positioning. Implant depth is controlled, so prefabricated abutment is connected, and internal socket graft. And before surgery, I plan to have allograft, but AOS collagen, the xenograft, is chosen over it. So inside xenograft, AOS collagen is put in the intrasocket, and abutments are connected so that the graft material doesn't go into the implants. And the remaining area will be fixed. One more bone tech at number 23. I believe it will be completed once it is fixed. Now fixation is completed. As you can see, there is some exposure. So one more membrane will cover it where bone is exposed. So Oss guide will cover it. So Oss guide is being cut, matching the defect. I'll hydrate it first. So it is hydrated first. It is a collagen membrane, so manipulation of it is easier. Open your mouth, please. And beneath the palatal flap, it doesn't require any stabilization. So for non-resolvable membrane, fixation is important, but this is a collagen membrane, so it is adapted to the form pretty well. Now the flap will be periosteal incision releasing should be done before raising the flap, but this is a pouching technique, so periosteal incision is made right now. before grafting, periosteal incision can be made, but I usually do it after grafting. If you use Osbuilder, you can identify the surgical site better. So after the grafting, you can make it more tension-free. Periosteum is released tension-free. The flap is adapted. So you can pull it tension-free. So suturing before finish. So periosteal releasing incision tension-free. So it is not that we pull it using suture. It should be tension-free. So that will make wound opening less. And number 21, the most important area is where nylon suturing is used. The 40 nylon is used. So flap needs to be inside. The flap should be inside. So it's where papilla is. Now it looks like it is positioned pretty well. Through tension-free adaptation is achieved, and interrupted suture is good enough in this case. So between the two implants, as we expected at the beginning, if stability is not good enough, in the worst case, we would place one more implant, but over 30 Newton centimeter primary stability has been achieved, and pre-made, prefabricated abutments are connected pretty well. Now horizontal mattress suturing. As you can see, the flap is tension-free. Please open your mouth. So adjacent tooth is implant. So I need to do it in 2 sutures. In the crestal area. The incision is near the implant. As you can see, it is tension-free suturing. Now the surgery is almost complete. So proximal area before crestal. distal to vertical incision. Maybe 2 sutures for the vertical incision. Yes, that's what I want. So I'm applying too much force because I'm nervous. Yes, when we do live surgery, we get nervous, but you're doing pretty fine. So a vertical incision is sutured in the distal side. So one more suture. Now I'm going to the proximal area. So a vertical incision is all sutured up, and in the proximal area, now surgery is almost complete. So when you raise a flap, so you can suture like this. We use a nylon these days. There's a reverse cutting. So in the attached gingiva area, suturing can be difficult, but he's doing pretty well. Temporary prosthesis can be adapted, and you can do the attachment later. We have another surgery, so he's pretty nervous. If we can give you enough time, it'll be better. But in live surgery, sometimes unexpected things happen, but without a problem, it is being finished. So the adjacent nut can be pushed in, preventing the suturing at the desired site. So vertical incisions are all sutured up. And now I can just work on here. So surgery is almost complete. Here, a little bit of tension. So it's almost tension free, and so figure of 8 is used. Horizontal matrix suture was done once before. So we are running about, we started actually 10 minutes behind, so the surgery time is almost as planned. So we have one more surgery to do, and Dr. Son is rather hurrying up, and it looks like it's all done. So you can put it in. This is rather low. Please bite on it. So the implants are placed according to the plan, and temporary prosthesis is fitting very well. Thank you very much, Dr. Son. You had a difficulty with the bone tech, but thank you very much. So this concludes the surgery. Thank you, Dr. Son. He did a good surgery, calmly. Live surgery Q&A will be done after Dr. Kim's surgery, inviting the two surgeons. Dr. Kim is preparing another live surgery. And let's hear from Dr. Kim how he is going to do the surgery.
Greetings, I'm Dr. Kim Yong-jin. I am extremely honored to take part in 2022 Osstem meeting Seoul's live surgery. I'm honored to do this together with Dr. Son Young-hee, whom I look up to, and I promise I'll try to do my best. Before going into surgery, let me talk about the surgical plan. This is 55-year-old male patient without any systemic issues. He has 3 implants placed by another dental clinic on the left. Today we're going to focus on anterior and upper right posterior area. This is condition before surgery. The anterior prosthesis is as shown in number 21. Severe gingival resorption can be observed. In 22, period condition does not look good. A guide is going to be used to place the implant in the upper anterior. Prefabricated 1-fit abutment and PMMA bridge is going to be used for immediate restoration. Guide is going to be used. Trios is going to be used to fabricate guide. Oral scan is sent to Osstem One Guide Center and merged with CT data. Prosthesis design is made. This is number 14, 16, and the anterior 4. The prosthesis design is made. Guide surgery is planned for immediate implant placement. In surgical planning stage, you can see severe labial concavity on the anterior zone. Appropriate implant diameter and length was chosen in 11. Due to labial concavity, I don't think the implant will be exposed, but the implant apex area buccal wall is going to be very thin. Hence, I'm considering augmentation. Bone width for 14 is fine, and in 16, implant is going to be placed like this. If you look closer, look, a crestal approach is needed here. 5.0 by 8.5 millimeter implant is going to be placed. The residual bone is about 4 to 5 millimeter. One cast will be used for sinus lift for implant placement. Template design. On both sides of anterior, in number 2, in 12 and 22, immediate implant placement after extraction will be done, and in 14, 16, simple implant placement will be done. One guide will be used for number 12, 14, and 22, and in 16, one cast kit will be used for crestal approach for implant placement. There are additional things to consider. In number 12, apex to the implant, the residual bone is very limited. Therefore, in a simple manner, I will not reflect the flap extensively, unlike Dr. Son, and am going to do contouring augmentation. The biggest area is number 21. because there's stark difference in gingival level, I'm not going to place implant here, but for aesthetic anterior prosthesis, augmentation is needed. I need to consider the soft tissue, therefore, in a simple manner, socket preservation is going to be done. In number 12, on the apex side, contouring augmentation will be done using tunneling technique. I'm going to share a similar case. In number 11, extraction was done. In number 22, it looks very similar. Because there's concavity, guided surgery was not here. Implant was placed first, post-op panoramic image and PA was taken, but it looks fine. In post-op CT, it is partially exposed. In order to augment it, I could have opened a big flap, but a very small vertical incision was made distal to the vestibule, and the membrane was lifted. A pouch technique was used. Rather than granule type, I used a collagenated graft material, AOS for contouring augmentation in the apex of number 12. I'm going to do something like this. I did not use membrane. I'm not going to. You may be curious of long-term prognosis. Post-op CT, 2 weeks, 3 months after final prosthesis delivery. As you can see on CT, membrane was not used, but the bone augmentation was done nicely in the apical area. Labial contour is nice. This is possible because AOS collagen contains collagen and stabilizes graft material. Even if you don't use membrane, such healing can be achieved. This is another smaller case. Number 22 is problematic on the apex side that there is severe concavity. One guide was used. In planning stage, I assume the apex area is going to be very thin. Extraction was done very carefully. One guide was used to drill and place implant like this. Vertical incision was made distal to the vestibule like this, and I did a full thickness flap elevation. Collagenated graft material was used for augmentation. I'm going to show this when I do the live surgery. This is the most difficult case. In number 21, gingival recession can be absorbed. The difference of gingival height with adjacent teeth is too stark. How can I overcome this? I can do connective tissue graft, but I didn't think it would be predictable. Collagenated graft material was used to do socket preservation. It's a similar case. In number 21, I'm not going to place the implant here, but for soft tissue contour below the pontic base, I'm going to use collagenated graft material for socket preservation. Pontic base in a ridge wrap form will be used to protect that area. After 3 months, it looks slightly different, but because the pontic is in ridge wrap form, ideal gingival regeneration was achieved. This is final prosthesis. Gingival regeneration was achieved without a problem. In this case, the gingival recession amount is smaller than the case today, but I'm going to take the same strategy. If the gingival recession is too much, even if you use collagenated graft material like AOS, there could be stable soft tissue regeneration with the epithelialization superior structure, but if there's too much exposure, it can lead to unwanted consequences. The plan for today is like this. So for this patient, 2 implants were planned for number 11 and 21, but the implanted position and distance of implant in number 11 was not good. After placing implant in number 21, final prosthesis will be connected to number 12, which was already placed. In number 11, gingival recession is excessive. I used collagenated graft material for socket preservation. This is panoramic image. 11, number 21, extraction was done, and in number 11, as shown, if the patient has chronic period disease in the anterior area, there is granulation tissue in the palatal area. Due to chronic periodontal disease, soft tissue is thickened. I do not remove such granulation tissue and attach it to the buccal flap and make a space. And in the socket, I remove granulation tissue fully, and I use collagenated graft material. After I use the granulation tissue, which I've attached to the buccal flap like a dressing material, like a membrane. Today, major things to look out for is that I'm going to use 2 implants using a guide in an area where there's apex concavity. In number 12 and 11, AOS collagen will be used in a tunneling technique manner for augmentation. In number 21, where there's severe gingival recession, primary socket preservation will be done using AOS collagen and the granulation tissue on the palatal side for socket preservation. Thank you. This is the second live surgery. Dr. Kim Yong-jin. Let's begin the live surgery. Dr. Kim, you can start. Yes, I'll begin. As mentioned in the briefing, I'm going to extract the anterior teeth first. The anterior teeth with a bridge, it's very damaged. Number 21 is going to be extracted. There's very little attached. Just with forceps, tooth is being extracted. On the apical area, granulation tissue is removed. I'm going to adapt the template. Say as mentioned. We make a template before extraction. This is one guide, the template. I think it fits well. It's accurately adapted. In number 21, socket preservation is going to be done, and soft tissue amount may not be enough. So in number 6, I'm just going to graft connective tissue graft as well as epithelium tissue. I'm going to use tissue punch first. Say ah. The diameter of tissue punch is 6.0, so I'm going to use it first. Later, in number 21, for socket preservation, Dr. Kim is removing the tissue without using guide. Are you using 6.0 diameter? Yes. To the left. Wide tissue punch is used. On the crestal side, the soft tissue is removed. For number 21, this is going to be used for socket preservation. Guide template is adapted. First, I'm going to do crestal approach. The area with the least amount of residual bone. The initial drilling depth is 3 millimeters, 7 millimeter stopper, and 4 millimeter stopper. This is one casket, a 7 millimeter drill with a 4 millimeter stopper. So Dr. Kim's going to drill up to 3 millimeter. Tissue punch has already been done. 3.1 one cast drill. So 4 millimeter stopper. So drilling is done up to 3 millimeters. 3.1 millimeter one cast drill. Drilling up to 3 millimeter is done. 3.8 one cast drill.
So before penetrating the sinus floor, Dr. Kim is expanding more for 3.8 by 4 millimeter with 4 millimeter stopper. I'm going to increase the drilling depth. This is 3 millimeter stopper. Drilling is going to be done up to 4 millimeter. The final drill. So it is better to penetrate the sinus floor like this in order to preserve the sinus membrane. I don't think it has been penetrated. I'm going to use 2 millimeter stopper and going to use 5 millimeter drill. 3.8 by 5 millimeter drill is used. One cast drill. Unlike a cast drill, there is difference in stopper. It has not been penetrated fully. I'm going to use 1 millimeter stopper. The one cast drill is 7 millimeter. One cast drill and 1 millimeter stopper is used, drilling up to 6 millimeter. I think it may have been penetrated. Yes, it has been penetrated. Sinus lift is going to be done and implant will be placed. When you do hydro lift, you use a 3 cc syringe or 5 cc syringe. Dr. Kim is using 5 cc syringe. When you do aspiration, you need to make sure that the blood is coming out. The residual bone is about 6 millimeter, and I'm not going to do excessive sinus lift. The residual bone is about 5 to 6 millimeter. I'm going to place the implant. Are you going to do it without bone graft? Because residual bone graft? Yes, because I'm going to place 8.85 implant. One cast drill was used for drilling. Membrane was lifted, and below that, without bone graft, almost like tenting, implant is being placed. Did you place the 5.0 by 8.5? Yes. TS3 5.0 by 8.5. It is being placed 80% with the engine. Implanted driver is used to get the final position. Depth control. If you use one guide template and get to the yellow part, you can get the right hex. Additional support in order to get that. In the anterior area, there can be slipping. I'm going to use it like a tent pole. It's like a vertical stop, yes. It's like a vertical anchor. Implanted driver is used so that the one guide template does not slip and slide in the anterior area. Implanted driver is in number 16 where implant has been placed. In number 14, without tissue punch, are you going to do it? Yes, I'm going to do it without a tissue punch. Initial drilling is done in number 14. .5 by 11.5 millimeter. One guide drill is used. 3.5 by 11.5. The bone quality seems to be okay, so I'm just going to do normal drilling. 4.5 one guide drill.
because 4.5 diameter implant is going to be placed and the bone quality looks okay. 4.5 by 11.5 millimeter drilling is done. The bone quality is good. In one guide drill, the amount of cortical bone looks very good. In number 14, drilling is done. Irrigation is slightly done. TS3 4.5 by 11.5 millimeter implant will be placed. 4.5 by 11.5 millimeter implant. It is placed 80% with engine, and then the implant driver is used to get the final position. Torque wrench is used. You can see that the assistant is holding the one guide template so that it does not slide. Implant driver is used to get the final position. The torque seems to be good. It seems over 30 Newton centimeters. Implant depth control is being done. 2 implants have been placed. Now we're going to move on to the interior region. Implant driver is used like a vertical anchor. Using the placed implant, this is used to fixate the plate. On CT as shown, the patient has a apical concavity. I'm not going to use path drill. I'm going to use initial drill. For soft bone, I'm going to use straight 2.2 drill, initial drill for soft bone. It's a straight form. Initial drill is originally tapered firm, but the 2.2 tape initial drill for soft bone is used. At times, the full depth drilling is not done because of the palatal bone. In this case, you can use flattening drill. When you use, what is different with the path drill? If you use path drill, as Dr. Seoul, if the root is long, you can hit the palatal wall. But if there is concavity on the apical side, there can be over preparation, so it can be unfavorable to get the primary stability. In the Q&A session, we will revisit on this topic. If the cortical bone on the crestal side is thick, the drill may not go in full depth. You can use a flattening drill. So you can use flattening drill here like this to get more cortical drill. Initial drill, you need to check whether initial drill goes in full depth. You need to make sure that initial drill is not going in fully because it is hitting the bone, palatal bone. 2.2 by 11.5 drill. 3.5 is also for soft bone. 2.2 by 11.5 millimeter soft bone initial drill is used. I originally planned for under drilling because bone quality was suspected to be not so good, but it's okay. I'm not going to do full depth. I'm going to drill up to 8.5 on the apex area because the patient has a lot of concavity. I think this will be a strategy to prevent perforation. 3.5 by 8.5. So you're widening just the superior part. TS3 is a taper design, therefore just on the top of the prep is being done. Initial for primary stability, he has chosen this strategy. Based on his experience, he has taken this strategy. Implant diameter is 3.5 by 11.5. For placing 11.5 millimeter implant, he has drilled up to 8.5. TS3 has sufficient self-taping capacity and it is sufficient for anterior.
use. Just with a 2.2 soft drill, it can go up to the apex area. I'm going to do under drilling in the apex side, so the primary stability is good. Primary stability looks good. Over 30 Newton centimeters. When you treat the anterior zone, TS3 implant can slip towards the labial side. You can see that implanted driver is used here as well. No mounted driver is used to place the implant about 80%. It is removed. Implant driver is used to get the final implant position. The primary stability looks good. Implant have been placed. Before I do graft, before I do socket preservation, I need to adapt first to see how the prefabricated prosthesis fits. In number 4, I used a transfer stock abutment. In number 14, stock abutment. Stock transfer abutment is used. Is it an abutment with hex? Yes. Because one guy was hex cut. I think it fits nicely. Can you bite? Say yeah. I think it fits nicely. In number 14, immediate provisional was provided. Say yeah. In number 16, cast drill was used and it touched the sinus. Therefore, healing abutment is connected. 6.0 diameter healing abutment is connected. In the anterior area, in order to avoid the apical concavity, I made a 1-fit abutment. I think it fits nicely. Temporary provisional is being adapted. In the desired area, it has been adapted nicely. I'm going to do adaptation. Provisional is being adapted, and now I'm going to move on to graft. In number 21, socket preservation will be done. It fits nicely. Say ah. As planned, the implants have been placed. Dr. Son, he had a type 2 patient with no labial bone. I wanted to see type 1 socket preservation. In the socket, I'm going to do graft. EOS collagen will be used. Can you close slightly? Say yeah. If you look here, in order to prevent graft material going in, the implanted driver is connected. In the cervical area, gingival contour is very important.
AOS collagen is used. I use collagenated materials. It has good soft tissue response even if it is exposed. Epithelialization can occur, therefore it can be favorable. When I use the AOS collagen, even if it is exposed, the epithelialization occurs very quickly. Within the implant and towards the internal connection, in order to prevent the graft material going in, implanted driver is used. During the morning session, cover screw was used, but now one guide the implanted driver is used. The good thing about implanted driver is that below the guide barrel, it is narrow, so it's good. It's a good tip. In general, at times you use a cover screw, but if you use this technique, unlike the general driver, one guide implanted driver, the lower portion is narrow, so you can put a sufficient amount of graft material to the internal socket. In the case where there's mobility, if there's no gingival recession, in order to prevent recession, you can do dual zone graft to prevent the gingival recession. In that sense, collagenated graft materials can be more favorable. In the case of AOS collagen, soft tissue regeneration is very good. You do not use alloplastic? Yes, I don't. Because there's organic component, I don't really use it. It's unfavorable to graft outside the socket. In number 12, graft has been done. You can see that AOS collagen doesn't crumble. I think that's really attractive. Implanted driver, even after it is removed, you can see that the AOS collagen material, the form is being maintained. If you do not do adaptation and then do dual zone graft and then do adaptation, then it's very difficult to make sure that the adaptation is done nicely. So you do try in first, and because you have confirmed that it adapts nicely, you can proceed with graft. I think this is an important tip because you're using the implanted driver. It's my first time seeing someone use implanted driver and using AOS collagen. I think this is based on his long years of experience. It's a great tip. As you do implanted treatment on the implant connection area, at times it can be quite troubling because it goes into the connection area. In doing socket preservation and implanted treatment in type 1 socket, AOS collagen can be an issue if you do it without using the implanted driver. AOS is used sufficiently. Dual zone graft is done. In the case of AOS collagen, porosity is good, so network is formed nicely. It's easy to handle. Recently, since AOS collagen has been released, I think it has gained a lot of popularity. I recommend you use it in your clinical practice. A temporary prosthesis is being adapted. If you do this, you can get the cervical gingiva contour that the patient had before extraction, and additional support that can be gained with the graft material. Therefore, based on my short clinical experience, I think it's a good idea. Torque wrench. It's difficult to do it with your hands. Rather than a handed driver, the head is smaller, so it's not easy. I hope there's longer one available.
This is an immediate implant, 15 to 20. Mini implant placement. Temporary prosthesis has been done. 15 to 20 Newton centimeter. Once this is done, because if you use a 1 feet abutment, cervical contour can be maintained and emergence profile can be given. I think a dual zone graft is very easy for this purpose. Irrigation. As you have mentioned, the AS collagen overriding mucosa covers very quickly. This area, because although it is below the pontic base, there's a lot of recession on the palatal side. There is a sound tissue here. I'm going to use that to secure space, and I'm going to put some AS collagen. After extraction, on the palatal side, granulation tissue will be used. You're going to move it to the labial side, yes? There's sufficient bone, so the granulation tissue on the palatal side is going to be moved to the labial side using the incision. I think this is based on your long-term experience. Detaching the granulation tissue, it's not easy. So he's using a new method to detach for sure. Unless there's acute inflammation, I think chronic granulation tissue, because it has good fibrosis, I think soft tissue response is going to be good. If membrane coverage is not possible to maintain volume rather than a soft tissue, I think it's better to have bony housing. In this case, using collagenated materials can be of great help in this instance. AOS collagen is used. Moldability is very good. If you put in particle, it's not easy to put in like this. And if you do suture, it's gonna collapse, but if you can maintain this much contour, it's going to be good. Primary closure can be difficult. Therefore, I'm going to use the tissue punch material. In trying to make a bone intricately, but because it's below pontic, this is for aesthetics, it's okay. I think after doing guide surgery, all procedure needs to be simple. Using the tissue gained from tissue punch, it fits perfectly. I think we are getting lucky here. As you can see, collagen holds blood very nicely. In collagenated graft material, there are many options available. If the porosity of the molecule is not good, the ability to hold blood falls. In that sense, AOS collagen is very good to be used clinically. Please go ahead and try. I think surgery is almost done. How many minutes have passed? I think we're almost right on time. Now you just need to close the case. You can see in the soft tissue gained from number 16 is now being attached. Because on the buccal side, the root was exposed, the soft tissue defect was significant. This is used. So I'm going to fix it towards the thick palatal area first. In some sense, without additional CT graft, this is a method to avoid CT graft. If additional connective tissue graft is necessary, yes, you may do it, but I'm not an excellent surgeon. I'm not really comfortable about doing CTG.
Periodontists think pharyngeo graft is very easy, but as a surgeon, CTG is not really easy. If it's difficult for you, Professor, then what would it be for me? In number 16, tissue punch was done. 6mm tissue punch. Did you get it separately? I have all sizes of tissue punch.
오스템에서 팔고 있는 마이진 거 그 드릴에 티슈 펀치
The tissue punch scent from Osstem is available. It's for Reisinger. I bought it. And there's also a trapine burr set for different diameters. 50 nylon is used. 50 nylon is used. Suture is almost complete. The palatal granulation tissue was moved to the labial side, and on the labial side there was a lot of soft tissue lacking, and now it's been compensated for. I'm sure you got a lot of clinical tips. Using palatal granulation tissue. Some people may have only thought of it as a vague idea, but as we watched Dr. Kim do it, I think it has dawned on many people that that's possible. If there's severe post-discharge or if there's a lot of inflammation, it's a technique that cannot be used, but a chronic granulation tissue, you can use it because it has fibrosity. Unless it is acute inflammation, and if the flap is flappy, you will not be able to use it. But if the patient has a chronic condition, then it will not be a major issue. Now surgery is being proceeded nicely. So I'm going to do suture just once more. Surgery has been done successfully. This is the final suture. I'm going to do adaptation once again. Can you give me the provisional? It fits nicely. Can you have the patient to do occlusion? Pontic base, I think if you can get this kind of gingival contour, I think this can be addressed prosthetically. Congratulations on successful surgery. Now we'll move on to Q&A session. Thank you.
So we have successfully completed the live surgeries. Dr. Kim may take time. He needs to take CT. So we will do Q&A first with Dr. Son. So this is your first live surgery, right? Yes. So it is your first time in Osstem meeting. You must have been nervous, right? Yes. So let's look at the questions that we received. there are some questions to be addressed by Dr. Kim as well. So you used a pouch technique. So they could have been done flapless. So that is a question. Can you answer that? Flapless is ideal and best. In the planning step, the outer surface of the implant to the labial bone outer surface, the distance is important. If it is more than 4 millimeters, internal socket graft is good enough to respond to remodeling. But during planning, if it is less than 2 millimeters and the gap is very small, and the distance to the labial bone was very small, so external socket graft was a must. Therefore, from the beginning, from the planning stage, GBR was planned. So at the beginning, internal socket graft, the allogenic graft was considered, but the EOS collagen was chosen. So you use EOS collagen quite a lot? Yes. How do you use it? EOS collagen is a graft material, 10% collagen in it. By using it, there are many cases that can benefit from it. Internal socket graft, dual zone graft can be done, benefiting from it, and it is not dispersed. And the collagen itself can have much more blood than its own volume, so it helps the blood supply, and bone regeneration can benefit from it. So for socket preservation, it is very good. So I use it really a lot. So I talked about it during surgery. One of the questions, cortical perforation is done with the GBR before placement. What about you can raise the flap? Yes, that's a good idea. When I originally planned, when I raised the flap, template can be less stable. So I decided to place the implant first, and after the placement, the cortical perforation was done. Usually, it is beneficial if you do it before placement. Non-traumatic extraction. For that, periotome and malleting. Regarding that, there is some question. Do you always use a periotome? And when you do it, do you always use mallet? Yes, I always use mallet for periotome, even though it can be just a small amount. In this case, number 23, and the treatment is done. So PDS space is very small in that case. So if you just extract labial plate, when a labial plate is thin, that is problematic. So to avoid that occasion, when endo-treated or PDS space is very thin, I use it. So in this case, a labial plate is thin. So in case of Dr. Kim Young-jun, a forceps was used to do extraction. So if you use a forceps only to luxate the tooth, the labial bone can be fractured. So that's why periotome is used. So you can refer to this when a labial plate is very thin. When you do forceps delivery only, and if you do luxation with forceps, labial plate can be broken. That would be a problem. So in this case, a pouch is used. You already talked about it. So you remove the bone tech, only the upper one, and the rest remain there. So releasing incision is done. That can invite post-surgery swelling. Do you have any medication or know-how to address it? I don't really have it. There are many ways to reduce swelling. Usually, medication, hexadesamine, can be used after this surgery, and the cold pack or compression can be applied, and there has been not a major problem when I use them. And another medications can be done, but dexamethasone is something that we use. So what is the dose and for how long? According to papers, tapering is not necessary for short-term use. So 1 millimeter 3 times a day for 3 days. So if it is used within a week, the steroid can be used without tapering. Bone tags are used quite a lot. Is there any special know-how for that? The questioner is talking about the malatin type. I believe he's talking about bone tech. GBR kit bone tech of Osstem. Actually, this is my first time to see it is bent. The basal bone of the patient is very hard. I checked it, and I never experienced this kind of bone tech bending before. In the maxilla, bone tech is good enough, but in the mandible, if you are to use a bone tech, drilling may be a little bit necessary. For bone screws, Osstem bone screws is useful in fixing membrane in the mandible. So the short one, I believe it's 1 point. I can't remember it from top of my head. So bone tech is used a lot. In the maxilla, bone techs hardly get bent, but anterior nasal spine or bone is much harder than we expected. And Dr. Kim has just joined us. Thank you very much for the wonderful surgery. Dr. Kim, so what's your impression of the live surgery?
I felt really nervous, and I learned a lot from Dr. Son, so I felt pressure. I have a joint question for you. There are many questions on the live chat. Dr. Son, you used the path drill. So we talked about that. The path drill, you both used it. Dr. Kim, you did not use a soft drill. You just used the initial drill for soft bone. Could you elaborate on that? What is the path drill like? Path drill, I used it. There are two types, 7 millimeter and 13 millimeter. The reason is because Osstem One Guide's concept itself is a double contact concept. So when you do drilling, the template needs to be in contact with the drill as well as the bone to minimize deviation. In a sloped surface, you need to do initial drilling, especially in the case of immediate implant placement. We do not want the drill to drift. The path drill is shaped like a square so that it does not slip even in sloped surfaces. The reason why I use a 7 millimeter first is because of the double contact. If you use longer drill, the drill only touches the bone, not the barrel. Therefore, double contact concept I am using 7 millimeter and 13 millimeter in this case. That's how I used it. The final diameter was 11.5. 13 millimeter path drill was just. Why didn't you use the path drill, Dr. Kim? When we place the implant, the one guide drill is tapered form. In the case of twist drill, cutting edge is on the apex side. As I mentioned in the debate with Dr. Kim Gi-sung's lecture, side cutting is necessary, but in guided drill, side cutting drill is not possible. Therefore, path drill has been formed. The path drill has back taper on the palatal side. The strong hard bones are cut. The reason why I didn't use it because the patient has short root. In the case the patient has short root, if you do over preparation on the apex side and use path drill, it may be unfavorable to get the primary stability. In the case of Dr. Swon, the root was long and it was number 1. That's why path drill was used. But in my case, in order to get more stability on the apex side, I did not use the path drill. To give you more information, in one guide kit, the path drill itself is, as Dr. Kib has mentioned, it has micro back reverse tapping capability. Therefore, it can prevent the slipping. I think post-op X-ray are available. Can we see? So I'll show mine first.
Post-op panorama. So on the panorama, 5 bone tacks are used. The implants are placed as planned. Number 23 looks a little bit deeper. But in order to get primary stability, I planned it to go a little bit deeper. On the CT, number 21 CT, as you can see, it was not pushed, and it is very well placed as planned. And the collagen graft is also observed. Number 23 is a little bit problematic. It is pushed a little bit, and I also felt it. So the EOS collagen is pushed, and if only 50% is ossified, it will be okay. So I was wondering whether I should make modification, but it is definitely pushed. So it is a little bit pushed. Dr. Kim, post-op panorama.
Dr. Kim, implant has been placed and they determined the level in number 16. Sinus crystal approach has been done nicely. In number 14, hex type transfer above and hex seems slightly less in, so I need to adjust it. This is the CT apex concavity can be observed. Pre-op, when I was doing briefing, tunneling technique to do submucosal graft, I focused on number 21. In socket preservation, I think primary stability was okay, and the apex side, so I thought it would be fine. This is number 22. And this is number 12. On the apex side, I think fortunately I did not slip because I thought it would be more closer to the apex, but I think this is a cortical bone and it has good muscle layer. Number 14, it looks good. Number 16, I did a crystal approach. I just did sinus lift. I think bone formation can be gained. So you don't need to do sinus bone graft when you just lift by 1 to 3 millimeter. And with a new surface, I think you'll be able to gain bone graft material. We'll entertain one more question to Dr. Kim Young-jin. You mentioned it earlier during your surgery, but when there's a lot of soft tissue resorption, you use the granulation tissue to compensate for that. In type 3 socket, in chronic condition, chronic granulation tissue. If epithelium has been granulated, by using periodontal probe, you'd be able to get a good sense. The pocket would not be bad, and if the palatal wall is intact, you can use the gingiva in a general method. If you open flap, it will be lost, but if you do lingualized incision and make a slight vertical incision, the GBR process itself, the soft tissue condition is not good, but by using it as a dressing material, it serves its purpose. Therefore, if it can serve that purpose, the epithelialization and ossification can occur. Therefore, by using this, a simple preservation can be good. Did you use the number 15 blade, the 15C blade? I get these questions frequently. When you use it, I've heard it. I've never seen someone use it. Is it difficult to use clinically? I think it would have been. I think it was a good choice for this case because of time constraint. We'll now end the Q&A session. We will choose the best question related to past drill. How is it like using Lindemann drill? Stoli will be chosen as the best question. You've done a wonderful job. Thank you for the wonderful life surgery. You've done wonderful jobs. Thank you so much. Thank you, Dr. Son Young-hee and Dr. Kim Yong-jin, for the wonderful life surgery, and thank you for chairing the session, Dr. Kim Kyung-won. Now we will end the fourth session, and we will now look at the winners of log-in viewer event. A total of 300 people will win coffee coupon. Let's look at the winners. There are so many winners. Total of 300 people have won the coffee coupon. Please refer to the notice board and the demo site. Congratulations once again. The coffee coupon will be sent via the text. Now we will end the fourth session and have a brief break. In the first floor, there's the result of poster contest. It's a brief break, but please go to the bathroom and go to the first floor to look at the contest result of the posters. In the fifth session, we're going to have coffee coupon session and the lucky draw. Please stay with us and try your chance at winning prizes. During the break period, on the second floor in the product exhibit room, you'll be able to view different products. I look forward to your avid interest. Let's meet up again after 8 minutes.
Autobone Collector makes collecting autogenous bone easy and simple. All you need to do is drill once using the Autobone Collector to collect autogenous bone. With the Autobone Collector, you are capable of approaching up to 15 degrees of the left and the right. And it has a pointed tip that keeps the drill safe and steady, while also preventing it from slipping. Drill once and you're done. You can collect autogenous bone immediately with the Autobone Collector. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescence scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Introducing the OneCast Kit, the digital sinus surgery kit. If you use the OneCast Kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the one guide template first, then use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast Kit for safe and precise sinus surgery. Introducing the 1485 Kit, the implant surgery kit for mandibular posterior region. The 1485 kit is used for implant surgery in the mandibular posterior region with vertical bone resorption. The implant specification and position can be elaborated with digital planning. The surgeon can prevent damage to the inferior alveolar nerve even when the residual bone height is low, in case the surgeon places a one-guide template and performs drilling with the 1485 kit's round design drills. Also, the 1485 kit helps you to place from 4mm to 8.5mm short implants at proper depth and avoid any damage on inferior alveolar nerve. Try the 1485 kit when you need to perform a surgery in a mandibular posterior region. Introducing the S5T and S5L scaler, premium ultrasonic scalers made in Switzerland. The S5T scalers can be attached to the dental unit chair. A-tip, P-tip, and PS-tip. 3 tips are included, and therefore you may choose the appropriate tip depending on the patient's oral environment. The PS tip is especially long and thin, making painless and gentle scaling possible. Scaling with the S5L scaler is easy, since it has LED light for better visibility. Experience gentle and easy scaling with the premium Swiss scaler S5T and S5L.
안녕하세요. 다시 뵙습니다. 아나운서 이만을입니다. 저는 지금 임플란트 PM팀 임종민 대리와 함께
Hello, I'm announcer Im Ha-neul again. Im Jong-min from Implant PM team is with me at the material zone in the Osstem product exhibition hall. At a glance, it is filled with so many products. What are in the material zone? Mr. Lim? All the materials in this zone needed in dental treatment are displayed, including Osstem's representative GBR products, AOS, QOS, SureOS, impression materials, resin, and nighttime file. Oh, okay. We could have special experiences in each zone we have visited, so I get a feeling another experience is prepared first in the zone. Yes, you can discharge a high C plus in the material zone. Let me show you. Anybody can easily apply high seal plus to a tray. You can squeeze it and feel the soft discharging of it. High Seal Plus has very short setting time. It takes about 2.5 minutes for curing, half of the time compared to other products which take 4 minutes. Short chair time is good for both dentists and patients. Osstem R&D Center Product Hall. We are already at medication zone the last visit. What do we have here? Various products from prescription drugs to lidocago spray, high functional premium toothpaste. You can experience chlorhexidine oral disinfectant with good taste and fragrance, which does not discolor teeth. Can I try it? Sure. As you can see here, there's a difference of chlorhexidine, which is from Osstem. Can you guess? The viewers may not feel the difference, but there's a big difference in the fragrance. And I don't have to tell you which one is from fragrance, from Osstem. It is different. Very fresh taste and fragrance, very nice from Osstem. So I believe this can be used by users. They can really enjoy it. We looked around the product exhibition hall in Osstem R&D Center. Many people watching the broadcast may want to visit it. How can they do that? If you want to tour the product hall in Osstem, please contact our sales representatives or call the number on the screen that is displayed right now. So this concludes the Osstem visit. Stay with the channel. Enjoy the rest of the Osstem meeting 2022 Seoul. I've been Haneul Im, announcer, and my name is Jongmin Lim. Thank you.
네, 오스템 미팅 2022 서울 이제 세션 5 다섯 번째 세션을 앞두고 있습니다. 다섯 번째 세션 시작하기에 앞서서 중요한 순서가 남아 있는데요. 바로 로그인 시청 이벤트입니다. 지금 바로 대놀 사이트에 로그인 하시고 팝업에 응모를 해 주시기 바랍니다. 그런데 여기서 끝이 아닙니다. 이번 세션의 첫 번째 강연이 끝난 후에 오늘의 하이라이트 통큰 이벤트의 응모가 또 준비가 되어 있으니까요. 끝까지 함께 해주시기 바랍니다. 네, 그럼 이제 오스템 미팅 2022 서울의 마지막 세션을 이어가도록 하겠습니다. 마지막 세션은 해외 연자분들의 강연이 진행이 됩니다.
The final session is by the foreign speakers. The first is by Professor Marco Talerco from Italia and Dr. Peter Haney from Czech. Let me introduce the chair of session 5, Professor Park Chang-ju of Hanyang University. Professor Park Chang-ju has graduated from Seoul National University School of Dentistry, and he has gone through training in Department of Oral Maxillofacial Surgery. He's a research scholar, Department of Periodontics at School of Dental Medicine, University of Pennsylvania. He is a professor and practicing surgeon at the Department of Oral Maxillofacial Surgery at College of Hanyang University. Greetings. I'm the chair. I'm Professor Chang-ju Park, College of Dentistry at Yonsei University. And Osstem Meeting 2022 is the most prominent dental event of the year, with no doubt. Now we are having the final session. The session speaker is my friend, as well as an author of many researchers. Professor Marco Talerco is from Italy. Italy is not participating in Qatar World Cup. The title of the lecture is Digital Solutions to Begin Surgery with Final Prosthesis in Mind for a Perfect Smile. After a brief introduction video, we'll start with a lecture.
Professor Dr. Marco Tellerico, my friend and co-worker, as the first special lecturer of the last session of 2022 Osstem meeting Seoul. He is a world-renowned researcher, lecturer, and the current president of Osstem AIC Italy, and he's a real digital guy. As you know, he has just hosted Osstem Meeting Europe successfully. His topic today is Begin Surgery with the Final Prosthesis in Mind. After a short video intro, please welcome him with warm applause.
Dear Professor Park, thanks for the warm introduction. Fortunately, you translate because the first part I didn't understand nothing. So thanks a lot. As Professor Park introduced me, I live in Rome. This is just some video from my city, the center, the St. Peter Basilica, and the Colosseum that was one of the 7 wonders in the world. I live in Rome in my clinic that is also a training center for Osstem, and I really want to take this option to really thanks Osstem OIC to invited me today. For me, it's a really pleasure, and I'm really honored to be part of the Osstem family. This is my clinic. I just want to show you because also in Europe we use Osstem K3 chair, and we took some live surgeries. Professor Park introduced the Congress that we held a few weeks ago, the European Congress in Rome, in my city, and this is the training center. My passion is digital technologies, and the topic of today is digital solution to begin the surgery with the final prosthesis in mind. And I really hope this topic is on the target of the Congress. Look on my slide, the future of digital dentistry, and I would like to give my contribution. As a researcher, I like to speak my lecture following 3 steps: science, common sense, and experience. About the science, don't worry, I will not bother you with just a few minutes to introduce some concept. The present of the digital solution, speaking about implants, are the guided surgery. In 2015, the European Academy of Osseointegration already stated that guided surgery must to be considered the gold standard in several approaches, such as minimal invasive integration with other digital technologies, aesthetic optimization, immediate loading. We see beautiful live surgeries, and complex anatomical cases. And this is the present. Why we love guided surgery? This is a very simple case, but is able to understand why we should use guided surgery. And because I use guided approach in 100% of my cases. This is a cases with the problem on the canine. We have a root resorption and endodontic problem also in the lateral incisor. In this case, I don't like immediate implants in this case because there is infection, so extraction, socket preservation with collagen material and xenograft, the same material that the surgeon showed before, with connective tissue on the top, Maryland bridge, and wait the healing, and then plan the guided surgery. I also want to contribute with some tip the surgeon before speech about the double contact in the one guy kit, but the double contact is only for the drills. With this approach, reverse and then forwards, if you look, the motor is in the reverse approach, the implant can sit in the previously prepared site, and then we switch to the forward in order to have a bone contact with the implants. Of course, this is very important for 13, 11.5, 10 millimeter implants. But coming back to the main topic of this surgery, of this lecture, begin the surgery with the final prosthesis in mind. This is the final prosthesis. In the morning, we saw a lot of lecture about the digital solution. This is a T-link abutment, but if you look at the prosthesis, perfectly match with the planning. This is a canine position. This is a screw retainer restoration with link abutment and zirconia ceramic framework. So this is the present of the guided surgery. This is the follow-up, previous and after control, and X-ray, endodontic treatment on the lateral, and implants placement in the canine position. So, from a scientific point of view, I published several manuscripts with a couple of research groups. One from Professor Park, I'm really honored, and one from my research team in Europe. I just want to show you some manuscript. The conclusion from this randomized controlled trial are that with a guided approach, we can expect less postoperative pain and swelling, of course, but most important is less marginal bone loss at the 5-year follow-up. And if we look at the 10-year follow-up, we can expect a very high implant survival rate, but mostly low prevalence of biological complications such as perimplantitis. I will show you, and also the previous surgeon and speakers show several cases with the one-guy kit. One-guy kit is unique because I have surgical template without metallic sleeves, and together with Professor Park and also Dr. Kim, congratulations again for the life surgery, we published several manuscripts, and we concluded that surgical template without metallic sleeves are more accurate than template with metallic sleeves. So this is the reason because we used. All of my patients it's been helpful for me to write this book. The title of the book is Diagnosis, Prosthetic-Driven Treatment Planning, and Guided Implant Placement, the Key of the Success. And this is also the topic of today. But as I told you before, guided surgery is the present. I want to look at the future of the digital dentistry. So I want to level up speaking about the guided bone regeneration. The guided bone regeneration means CAD solution for predictable, prosthetically driven, guided bone regeneration and aesthetics. I don't know the microphone. Maybe okay. I can move there. Change side. Okay, thank you. So the computer-guided bone regeneration, in order to approach with a prosthetically driven surgery, also complex cases that need bone regeneration, in aesthetic or not. In the 2015, with my best friend Silvio Meloni, we published the first manuscript. Why guided bone regeneration, computer-guided bone regeneration? Because in all of this symposium, we heard the same concept. Not only the bone, but the pink aesthetic and the function of the keratinized tissue is most important. So the take-home message is begin the surgery with the final prosthesis in mind. Looking at the common sense, I want to show you some cases. This is the first, maybe it's the easier cases. It's class 4 according to the Kevin-Owell, anterior maxilla. Noemi had a car accident when she was 10 years old. For this case, I plan a customized titanium mesh and guided bone regeneration with autogenous bone and xenograft. Looking at the case, very high smile line. Most important, what Noemi asked to me, to have a bright smile. So I want to maintain the promise. This is the case. You see a bone defect. Fortunately, it's a contaminative defect, but Due to the high smile line, we have some problem to resolve the aesthetics. If you look at the CBCT scan, the bone is, the vertical height is maintained, but we have only 4 millimeters to place an implant. Could be also enough with some technique, but we will need to improve for aesthetic reasons. And as I told you before, I want to plan my bone augmentation procedure according to the prosthesis and according to the patient need. So this is a customized titanium mesh. It's very easy because I asked to my CAD design to copy and mirror, to copy and paste and mirror the shape of the contralateral bone. The same concept what you use to copy and mirror the shape of the contralateral tooth when we need to realize the prosthesis. And we publish with Professor Park this case and this technique with a customized titanium mesh. Look at the video. Unfortunately, we have not so much time. The concept is horizontal GBR. In Europe, we use a technique a little bit different, the technique that you saw before. The flap approach in the first upper left. In the upper right, you can see the implant position. Even if the implant is in the bone, we need bone augmentation. You can see right lower light, because we need to improve for aesthetic reason, to support the soft tissues. So we mixed 50% of autogenous bone and 50% of xenograft and put the membrane like you can see. 4 weeks later, 4 months later, we name this kind of GBR supported GBR because it's just to support the soft tissue. So we can reopen after 4 months because initially we have a good stability of the bone. So after 4 months, we just use PRF because the tissue of the patient was very good, and we reach our results to copy the shape of the contralateral area. Fully digital approach, digital scan abutment from Osstem, and the results from the soft tissues, but I really think that the most important is the implant position. We finished the case with a fully digital approach. And just to give you another tip, we use a zirconia abutment for the veneer and zirconia abutment bonded on a T-link with ceramic on the top for the implants. You can see the prototype model, but also the soft tissues. And we maintain the planning about 4 millimeters in order to give space to the dental technician to make a shape of the soft tissues perfect. And this is on the right of the patient, the implant, on the left, the veneer. And I can also show to you the surgery and a 3-year follow-up. And we reach the promise to the patient to give to her a bright smile. Looking at another case, another car accident, unfortunately, patient's a little bit older. In this case, we have the problem for 2 adjacent implants. But again, the philosophy is to start the surgery with the prosthesis in mind. So the workup is really, really important. After healing, we plan the surgery with the software. In this case, we just use the first drill approach because we need to check the vertical position according to the prosthesis, and we plan horizontal GBR with the same concept that I showed you before. So also for this case, just the first drill, the 2 implants from an occlusal point of view. But I want to stop a little bit here because it could be very easy to place the implant a little bit deeper and avoid big GBR. But the concept is I want to follow the prosthesis. I want to follow the cervical shape of my teeth. So if I want to reach a perfect smile, I need to believe in the workup, so the implant will be a little bit exposed, and classical horizontal GBR, as I showed you before, with xenograft and autogenous bone and collagen membrane was made. And I want to go, unfortunately, a bit quickly to the results. even if we have a good keratinized tissue, we want to improve a little bit the soft tissues in order to have the papilla, because you know that the papilla between two implants is not easy. And we have several techniques. I want to show you this, that is the closed technique, classical, and then I will show you an open technique to improve the quality and not the quantity. With this technique, we improve the quantity of the soft tissue between the two implants and the temporary. We wait for the maturation, the radiographs of the two implants. And here you can see the false papilla between the two implants, also from an occlusal point of view. Of course, it's not perfect like the contralateral, but I want to remember you that we leave the implants a little bit out of the bone. If we place the implant deeper, 1 to 2 millimeter, the papilla go deeper, because Tarnow demonstrated, and then other authors, that we can maximum reach a mean of 4.5 millimeter of the papilla between two implants. Again, the definitive prosthesis in the patient mount, the radiograft, and again, we need to copy the wax-up. This is already our starting point. We have another two cases, a little bit more advanced, because there are vertical defects, class 5 according to the Kaywood oval. One on the posterior mandible and the last in the anterior maxilla. Here the promise is different because the patient doesn't want bright smile, he wants to hit. So this is a complex case. I treated with some friend of mine, prosthodontist and perio. In this case, my colleagues asked me to treat the lower left sextant. So you can see the defect, vertical defect here in the middle area. The treatment plan started with initial periodontal therapy, implant placement and GBR, and perio prosthesis rehabilitation. So here I want to show you just in a few seconds the planning. The planning is complex because we have tilted implants buccally, lingually, close to the nerve, and this is just in the normal position. But I want to focus here. Prosthetically driven approach. In the morning, the authors speak a lot about, also in the discussion section, very interesting, about the screw retainer restoration. With a guided approach, even if we need GBR, we can plan GBR in according to the prosthesis, and we can deliver screw retainer prosthesis. I'm so sorry for this, but in my hands, 100% of my prosthesis is screw retained, and in Europe, maybe 95% of the restoration is screw retained. This is the reasons because we reach to plan in advance because we want to deliver screw retainer restoration. Looking at the video is very quickly, but another tip I think that you know, it's possible to prepare close to the nerve using the one casket also in the lower, because we can go close to the nerve with a non-invasive drill. So in this case, you saw by the planning that is a very tricky case, but the last 2 millimeters of the implant site have been prepared with a one cast drill. Smart build osmirdel membrane, the same 50% of autogenous bone, 50% of xenograft, and this is the post-op radiograft, also for a three-dimensional point of view. And here you can see a comparison between the pre and post results. Horizontal GBR in the last implant and 4.4 millimeter of vertical gain in the middle implants. But again, I want to focalize on the prosthetical approach. For this case, I convert the internal connection with multi-abutments, but I used 2 straight abutments and just one 70-degree tilted, just to save not the buccally position, but because the dental technician want to move mesially the emergence, as planned in the wax-up. If you look here, this is the temporary restoration, and this is the metal framework. Posterior is a long span metal framework, but again a screw retainer. The screw holes are perfectly in the occlusal surface of the implants. This is the metal ceramic restoration, X-ray that show the bone. And here I can show to you before and after, but also the 3 and recently, immediately before I came here, the 4-year follow-up, also from a prosthetic point of view, that show the stability of the regenerated bone. This is my last case, class 6, because he's a very atrophic patient, anterior maxilla, vertical and horizontal defect. Beatrice was a very, very perfect patient, but she has to me that she won the teeth that she had before the accident. And this is a removable prosthesis that is my starting point, because Beatrice told to me, I also like the support of my lip. So the prosthesis is my starting point. Look the thickness of the prosthesis. We need to improve the bone in order to give to her the same support without the prosthesis. So I scan with the intraoral scanner the prosthesis, and we are able to pre-plan the amount of bone graft. If you look here, this is the amount of bone graft that we need, that incompatible with a one-stage approach. So in this case, we need more surgeries, two-staged approach. And Beatrice told to me, I want my teeth when I was young, but I don't remember, I don't know the teeth. So I take inspiration with her mother. I scan the teeth of her mother. This concept was published by Dr. Kochman several years ago. So we can scan with an intraoral scanner the teeth of her mother. We can create personal libraries, and we can move the shape of the teeth of the mother on her daughter in order to have a reference for the shape present in the family. The third step is to calculate the perfect position of the final prosthesis, because the axis of the implant, the position, the dipping of the implants are related to the prosthesis. So I want 4 millimeters, as I showed you before, between the cervical part of my teeth and the implants, and I want to deliver a screw retainer restoration. As you can see, we need to improve the bone before and place the implant later. But in the software, we can see everything. So looking at the surgery, just some spot vertical defect, more than 7-8 millimeters of vertical defect. The same concept, the same flap, the same procedure, but in this case, we use a very thick pericardium membrane, or alternative could be not resorbable membrane, but titanium mesh, for example, need to stay 2 millimeters far away from the adjacent teeth, so we prefer resorbable pericardium thick membrane. And this is the first surgery performed by Beatrice. After 7 months, second surgery, implant placement, and supported GBR. Why? Because even if the bone is good, it's bloating, we place the implant are not exposed, but we promise to Beatrice to support the lip. So after implant placement, we plan supported GBR. Supported GBR could be made with 100% of xenograft in this case, because we don't need to put the bone around the implants. So again, one guy kit, TS3 implants, reverse and forward approach. In case of regenerated bone, the torque was very low, about 10-15 millimeters, because the bone is not yet mature, but we don't plan immediate loading. So the implants are covered by the bone, but we need to improve a little bit more in order to reach the aesthetic results and to maintain our promise. So collagen membrane, in this case normal membrane, only xenograft in order to improve the thickness of the regenerated bone, and a first connective tissue graft on the top. As I told you before, connective tissue graft on the top is to improve the thickness of the tissues. There are some techniques, some speakers already stated about this. In this case, I prefer desepithelialization technique. And to fix Eastern urban name sashimi, maybe because it's white and recall the sushi food. This is connective tissue graft on the top, fixed with internal suture. But you already saw 2 live surgeries, so I can skip a little bit. As I told you before, we don't need only of the quantity of the soft tissue, but we also need of the quality of the soft tissue. So the second technique that I want to show you is to improve the keratinized tissues. This technique, the name is strip technique. Also, there are several literature that stated the importance of the keratinized tissue to avoid bone resorption. And I had the personal consideration. Keratinized tissues is most important. It's most important today with the surfaces of the implants, of the modern implants, but is particularly important in case of regenerated bone that have a quality, a different quality compared with the native bone. So this technique is named open approach, strip technique. The concept is to put some strips of epithelium around the area that was left open so that the healing could be from the top to the crest. From a genetic point of view, we have cells that are called the epithelium because we want to improve the keratinized tissue. Because Beatrice is very young and the implant must to remain in her mouth for a lot of years. So, and also because if you remember, the starting point was very complex. So we needed to improve the bone, and now we want to make the bone accurate. The flap is open, connective tissue is exposed, strip of epithelium on the border, so that inside the garden, Eastern urban names garden technique, can heal for second intention. And we put a membrane on the top just to protect the healing phase. And this is the third surgeries. Bone augmentation, vertical and horizontal, implant placement and supported GBR with the first connective tissue graft, and the third surgery to increase the amount of keratinized tissue. Beatrice, as I told you before, is very nice. With a removable temporary restoration, she graduated 110 cum laude in chemical engineering. Why I told you this one? Because to reach good results is most important, maybe the surgeon, the materials, but also the patient must be really collaborated. And Beatrice was really fantastic. See the healing, we increase the amount of keratinized tissue, and we are ready to reopen the implants. We started from this to this, reopening with customized healing abutment, temporary restoration, healing the false papilla. With the removal, with the fixed temporary restoration, Beatrice also took a silver medal in swimming. As I told you before, is fantastic patients. This is the results, and we reach with all of this plan and surgery to maintain, also to improve a little bit the aesthetic lines. Or aesthetic lines mean support for the lip. On the left with the temporary prosthesis, on the right with the fixed prosthesis on implants. So we move to the final restoration. We copy the shape of the mother here. Maybe the case is not perfect, but we have false papilla, The anatomy of the teeth is quite good. The tissues around the implants is good. But most of all, Beatrice is completely happy. This is some emotional pictures comparing to the before and comparing with her mother. So, just 1 minute to conclude this short and quick presentation. I'm so sorry for this. The conclusion is from two sides. The first is a personal conclusion. I'm really proud to feel part of the Osstem OIC community. And my dream is that become the biggest scientific community in the world. From the lecture point of view, the conclusion is the beginning. Begin the surgery with the final prosthesis in mind. As I told you before, the key of the success of the guided surgery is the prosthetic plan. Place the implants according to the prosthetic plan. So we move for the future of the digital dentistry the same concept on the guided bone regeneration, to pre-plan the amount of bone we need in order to try to reach the perfect aesthetic results, but most of all, the long-term results of our implants. I really want to thank my staff. Fortunately, I work with all female. I'm really happy for this. This is my wife and all of my staff. This is the gala dinner of the Osstem IOSN meeting in Europe that has been held in Rome the end of October. The gala dinner was fantastic, and I again take this chance to thanks again Osstem Europe to always supported me and also to organize this fantastic event. My time is finished, but I have just 15 seconds. Recently, I read an article, and as Professor Park said, the Osstem IOSM meeting in Europe was a tribute for implantologists, and I'm really, really happy for this. I also want to thank Dr. Chong and Dr. Chung, sorry for my pronunciation, maybe Professor Park can, can name well, because take part together with me in a nice roundtable. The take-home message of the roundtable is the same that I want to show you before. Osstem OIC, together as not limits. So thank you so much, and time for Q&A. Perfectly time.
Thank you very much for your excellent lecture. And I'm very happy to see your lecture finally in the end of COVID-19 worldwide pandemic. And anyone who has a question to his lecture from the floor?
Don't be shy.
예, 강의 너무나 감사드리고요. 간단한 건데 전치부에서는 심리가 중요한데 그 엠브레저브의 파필라를 살리기 위해서 특별히 사용하시는 방법이 있으신지 여쭤보고 싶습니다.
Now, Professor Park will translate, maybe.
Yeah, his question is to save and reconstruct the interdental or inter-implant papilla.
Yeah.
You used the connective tissue graft, right?
You
used connective tissue
Yeah.
graft from palate.
Yeah.
So his question is about
No,
your own tip or technical tip about using connective tissue graft to reconstruct the inter-implant papilla.
Thank you for the question, because allow me to explain. In the first case that I show, is a small part of connective tissue was arrested from tuberosity, because the tuberosity is the first choice to reconstruct the papilla, because it grows during time. In the last case, I used connective tissue graft from the mid of the palatal because I needed a big amount of connective tissue graft. It was not possible between the tuberosity. Finally, the patient, Beatrice, was satisfied. But if you need to reconstruct more, for the last case, you should need a first connective tissue graft during implant placement, as I performed. Then improve the keratinized tissues as performed. And if you want more, the third connective tissue graft from the palatal, from the tuberosity. So just to reassume, to reconstruct the papilla, tuberosity is the first choice. And I teach it on my skin that connective tissue grafts are never enough. So it's very common, if you want to reach aesthetic results, to perform 2 or 3 soft tissues augmentation. Usually 1 to improve the thickness, 1 to improve the quality, the keratinized tissues. And as I told you before, the first choice for the papilla should be the tuberosity. In the last case, I didn't use the tuberosity because I needed a big amount. Maybe it could be another procedure. Maybe she did. You can summarize.
원장님, 저기 보통은 맥실러리 튜베로시티에서 띄는데 보다 두껍게 띄는 경우에는 팔레이트에서 띈다고 하셨고요. 두 번째는 이와 같이 임플란트를 심어놓고 파필라를 재건하기 위해서 소프트 티슈 또는 커넥티브 티슈 그래프를 하는 경우도 있지만 더 많이 하고 싶으면 수술, 임플란트를 심기 전에 미리 올려놓는 경우도 많다고 해요. 그리고 세 번째는 케라티나이즈드 진지바를 리컨하기 위해서는 2번 그리고 3번의 소프트 티슈 오그멘테이션 프로시저를 하는 것을 일상적이라고 생각하신다고 말씀하셨어요. 혹시 더 필요하신 거 있으세요?
It's okay. Thank you, Professor.
If you have no question from the floor, I'm going to pick up one question online from live chat in Korean. So 제가 읽어보도록 하겠습니다. 스마일 디자인 과정이 매우 독특하다고 합니다. 라이브러리를 가족에서 가져왔잖아요. 그런 것이 어떻게 되는지 좀 더 자세히 설명해 줬으면 좋겠다는 그러한 질문이 있어서요. 제가 영어로 번역하도록 하겠습니다. Professor Tellerico, you showed in your lecture the smile design from library from the patient's family. But if the patient wants smile design from library of famous actor or celebrated, there will be very complicated requests from the patient. So do you have any protocol to imitate the smile design from the library? This is the question.
I have not any experience with famous people because except you, I didn't know any VIP person. But Dr. Kochman introduced this concept with the name of smile donator. As a researcher, I don't like smile donator because it's most from a marketing point of view. But the protocol is very simple because fortunately I have a perfect staff team in my practice with also some CAD designer. But it's just needed to take a scan with the software to make the outline of the tooth, to segment tooth by tooth and store it in a computer. The software make this procedure very easy. About the VIP person, the celebrity, it's possible, but the celebrity make to donate a scan impression. But it's very easy because the protocol is to segment the tooth one by one and store. Then it's possible to modify the shape starting from the original one.
선생님, 사실 카우치만이라는 의사가 제안한 스마일 도네이터라는 컨셉이라고 합니다. 하지만 문제는 의외로 쉽다고 하는데요. 치아를 각각 세그멘트해서 저장한 다음에 위치와 모양을 모디파이 하는 것은 디지털적으로 그렇게 어려운 일이 아니라고 합니다. 다만 이제 이것은 제 생각인데요. 스마일 도네이터에 따른 스마일 디자인을 하다 보면 정말 대량의 GBR이 필요한 경우가 있잖아요. 그런 경우에는 결국 타이타늄 메쉬 같은 것을 사용할 수밖에 없고요. 수술이 다소 복잡해질 수 있겠다는 생각은 들어서 이걸로 일단 이 온라인 질문에 대한 정리는 하려고 합니다. And this, I want the last person to have question to his lecture from the floor.
비용하는 부담이 얼마나 될까요?
I'm a little bit scared.
Professor Tellerico, yeah, his question is about the medical fee because to imitate the smile design or smile donation, there often requires a lot of or large amount of GVR. So how much usually do the Italian patients pay for implants and GVR and other soft tissue augmentation procedures?
Okay, regarding the smile donator, in this case, it's free of charge because it's the mother. Easy. And I will not perform smile donator for a VIP for money. About the GBR, thanks for the question, because in my tour here in Seoul, I am really happy, and I realize that Osstem is the brand #1 in the world, because maybe first of all is the best ratio between quality and efficacy. And this is the normality. But I also think that, or better, I don't want to speak about the cost, I want to speak about the value. So, just to give a response, there are some situations that it's possible to find a compromise. But there are the other situations that the compromise is a little bit more hard and depends on the request of the patients. For example, the last case maybe is the most expensive. The mother told to me, I will do everything for my daughter. Don't think that this is very, very, very expensive, because always this case is less expensive than you think. But I teach in my skin that to maintain the promise, maybe I need to go a little bit more here, to maintain the initial promise to the patients sometimes is not easy, and depending by the initial point. So I completely agree that GBR is a more expensive technique comparing with thank you. I completely agree. Doesn't work the same. Huh? Is working? Yes. I completely agree that GBR are more expensive comparing with, for example, narrow implants, for example, a dentulous ridge expansion, but there are some particular indications. And regarding the three procedure, implant placement, the same price. GBR is one more cost, but digital technologies are not so expensive as is possible to think, because customized membrane, maybe the cost is quite similar to a conventional membrane. Sometimes connective tissue graft is not a cost in Italy because it's performed together with another cost. Connective tissue is free of charge. So I completely agree that the cost is higher comparing to other procedures. But the indication are for this kind of therapy, and I also want to speak about the value. So, in my practice, I noted in the last year that even if it's more expensive, I improve the number of GBR procedure in my clinic. Because improve the number of complex cases, but in order to reach medium long-term results and to reach aesthetic results, I think is mandatory. So it's most important to select the patients. As I told you before, the patient is most important. Not only because maybe need more surgeries and need to have a big collaboration, also because the procedure is a bit expensive. But believe in me, these procedures are not only for rich people. Beatrice is not a rich people. Are for people that understand the need of some procedure, more than one material, etc. So this is the real concept. Honestly, digital technologies doesn't improve the cost. Most of the cost is the number of procedure and the materials. Digital technologies, maybe, I'm not sure, could a little bit reduced, but I'm not sure. But of course, doesn't improve the cost.
원장님, 구체적인 금액은 언급하지 않으셨지만 요는 환자에게 필요한 수식은 어떻게든 하려고 하고 환자의 경제 상황에 따라 조금씩 조정한다는 그런 원칙을 해주셨고요. 원칙을 말씀해 주셨고 디지털은 특별히 따로 페이를 받지 않는 편이시고 특히 오스템 처음에 말씀하신 것처럼 오스템 하이오센 제품들이 비용에 비해서 굉장히 좋은 효과들이 있기 때문에 잘 사용하고 있다고 말씀하셨습니다. 괜찮으세요?
Yes. Now I'd like to close the first part of the last session. Please, one more round of big applause to Professor Tellerico.
Please give another round of warm applause to Professor Marco Tellerico and the chair, Professor Park Chang-ju. There's only the final lecture left. We're going to announce the winners of Coffee Coupon event, which was held with the start of the final session. Please take a look. Congratulations again. A lot of people have won great prizes. Congratulations. You can check out the results via the notice board on the dental site. Texts will be sent for delivery of the prizes. The highlight event of today, there is a grand event where lucky draw will be held. 3 people will receive Galaxy Buds 2 Pro, and 2 people will receive Galaxy Watch 5. 1 person will receive Galaxy Z Flip 4. Please try your chances at winning these amazing prizes. The winner will be announced after all sessions have been closed. Next, I would like to introduce the next chair, Professor Lee Boo-gyu of Seoul Asan Hospital. Please welcome him with a warm round of applause. He has graduated from College of Dentistry at Seoul National University. He has been the Academic of Affairs at Korean Dental Association, professor at Asan Medical Center, College of Medicine, University of Ulsan. He's president-elect, Association of AAOMS. Greetings. I am Professor Lee Boo-gyu, chair of this session. I would like to thank the audience for being with us despite today being Sunday.
좋은 기회 많은 것을 배워가실 수
I hope you gain a lot from this experience. This is the final lecture. The lecture is going to be provided by Dr. Peter Heine from Czech. The title is Digital Aesthetics from Plan to Articulation. Please welcome the doctor with a warm round of applause.
Hello everybody. My name is Peter and I came from Prague, but I will not show you the Prague because I know that you know it. I saw a lot of Korean couples making wedding photos on our Charles Bridge, so I know it was in some movie in here, but you will see it at the end. Are you tired? Let's wake you up. Let's wake you up. You know what, I'm in a digital dentistry since 2005, when I started to scan, when I started to leave the analog way. And first time I saw the CAD cam when I was 17. I was in Sweden, and I saw the CAD cam in time when we didn't have optical impressions. We didn't have scanners. It was a manual scanner. And in that time, as a dental technician, I was looking at it like, okay, this is the future that maybe I will never see in my lab or my office. But just in a few years, everything has changed. Now we have everything digital. We can digitize each step of dentistry. But all the equipment, you saw I have a lot of equipment, all the equipment that we use needs to be user-friendly. It needs to be easy to use. It needs to be everyday usable. If it's something that is too difficult, usually you see those colleagues that are not that familiar with that and they don't use it. So throughout the digital dentistry, we have some advantages, okay? We have some numberized information so we can objectivize all those information. We can send everything everywhere. We can copy that. We can repeat it. We can do the same restorations even before the patient is coming. You saw a lot of those things. I have to thank to Osstem to be a part of this because I saw so many amazing lectures. You know, every time I'm on some congress, I ask myself, did you see something new? And this time I can say, yeah, a lot of. And I think that I don't need to explain each part of this digital dentistry because you saw a lot of it. But I have to tell you that what changed my way of praxis was that now I do full mouth reconstructions in one day. I do a lot of restorations. My maximum is 158 ceramic restorations a week and 4,500 veneers a year. So I have a lot of, a volume of data, so a lot of studies, and we can really compare, you know, how the materials work and how the technology works. In average, when I calculate the time for one restoration in a year, if I calculate all the restorations, I know that it's 24 minutes. So if I know that the patient is coming for 10 restorations, I know that I will need 5 hours and still I will have a little break for that. So everything got more precise, everything got more automatic. Because I have 6 4-axis milling units, I can mill 6 units every 10 minutes. So it's something that no lab can offer me. And this is what I like, because in the heart, I'm still the dental technician, more than a dentist. So yes, I'm a user of Osstem implants, but I'm sure I'm not the one who can talk about the surgery today, because I saw those gods. And I have to thank again to Marco, you know, to show us, you know, the premium implantology. Impressions have changed, but still, if you compare the preciseness of analog, silicone, and digital impression, you still see some disadvantages or inaccuracies. And we are still testing new scanners. Next Friday, I will be doing a huge test for the new 3Shape 5. And I have to tell you, because there are many questions about the scanners, each of those intraoral scanners has some problem. But the problem is not the hardware. The problem is usually in the software or in our hand. Still, there is a human being behind the scanner, and that's a problem. So the strategy, how we use the scanner, is very important for the preciseness. So we can see a lot of differences with each scanner. We can do good scans or bad scans. But really, I see a good future because I even tested a scanner that is still not on the market in Europe. I don't know if it's in Asia, but it is a scanner that, intraoral scanner that is more precise than the lab scanners. So there is a future of completely precise scan. But we still see some disadvantages. So this is one, let's say, thing we need to think about is nothing from the digital world is completely strictly precise. Then, why we need to have the intraoral scan? Because today is very common. Please raise your hand, who of you has an intraoral scanner? Great. I remember when I started to lecture in that time for Sivona, and then for 3Shape, I was many times on the congresses where only 2, 3 hands were raised up. So then, of course, there is, the community of users didn't work. At the beginning, for example, when I started in 2005, I was the only one in Czech Republic. There was no one in Slovakia. There were 3 in Poland. There was no one in Estonia, no one in Lithuania, and all those countries around us. So there was nobody to talk about it. Today, we have an internet, we have social media, we have a lot of options, a lot of scanners, and we can communicate all together. We use the intraoral scanners for many things. And my dream is to have the intraoral scanner by each dental unit, because each dental hygienist or each assistant should know how to make the scan. Because in the intraoral scan, we can get more information than just the 3D data. So we have a lot of options how to use the intraoral scanners, for what we use the intraoral scanners. Today we do, normally as a general practitioners, we do orthodontic treatment. We discussed it with your chairman. Yeah, this is the future. Everybody will do the orthodontic treatment because of digital dentistry. We can do the scans even with the telephone. This is, thank you. This is a scan with a very old iPhone X. Today, it's much, 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 much better. So in the future, maybe we will not need even intraoral scanners. Who knows? There were the face scans already mentioned in those lectures before. It's still improving. We can do a lot of those 3D scans directly from our cell phones. And yes, sometimes we even use it for some planning. So, each year we have more options how to use our digital equipment. If we have intraoral scan, it doesn't mean we can do only communication with the lab. The way we know, like I do the scan and the lab will do the work. No. We can have a dental designer in the lab, send there the data, but the data can come back to the office. So the final or temporary restorations can be done immediately by the 3D printer or some milling unit in a dental office. And we can communicate with the lab like this way, so even the final restorations should not be all the time done in the lab. It should be done in the clinic by the dental chair. So it depends, what is the most efficient workflow for you, because now we have a lot of options. It's not just one way. Thanks to the digital dentistry, a lot of materials appeared. We have more options of treatments in prosthetic point of view. But when we talk about digital aesthetic, can we even combine those 2 words? You've heard about copying of some shapes of artists, for example. Why not? It's possible. Actually, we don't do that because most of our famous stars we have, like my patients, they don't have a pretty, teeth. But the main thing is that if we want to talk about the aesthetics, we need to know the basic rules of aesthetics. We need to have a lot of knowledge. We need to have a lot of skills. We need to have a lot of experiences. Because if somebody says, I know the morphology of the tooth, it's wrong. It's the lifetime problem. We need to learn from each case, from each patient. In a past time, every dentist using, so which microphone now for it? Okay, thank you. Each dentist using some metal-free material thought that he's doing aesthetic restorations. And this is the result. Yeah, we had not metal crowns, but some crowns covered with something. But the basic thing is to learn how the tooth should look like. Then we can talk about the aesthetics, and then we can say we know how to prep or how to place the implant. That's what Marco was talking about. We need to know the future shape of the tooth and the position of the tooth to be able to plan. And if we are not able to imagine that, we need wax-ups, we need mock-ups, we need to plan. If we know how to do it, if we know the future shape, maybe we can make it in a shorter time without all those helpful things. But it needs a lot of time. When I started, I spent every weekend making wax-ups. I did all the wax-ups for my patients, but I spent all the weekends, at least for 2-3 years. And yes, then after those 3 years, I slowly stopped doing it. We can choose even the color digitally. There are many options, but it should not be expensive. We can do it very cheap. We just need some camera. Now everybody has a very well-known cameras in Samsung phones or anywhere else. It's excellent, so we don't need even those huge cameras. And if we know how to use it, if we know how to use the lights and how to use the filters, we can record the pictures that well that we can read the shade from the picture. I saw in some of those lectures today there was a ELAP, ELAP for the shade analyzing, but we can use even simpler way. Just make a picture with a shade guide and use some graphic software or even PowerPoint or Keynote, and we can just match the piece of a shade guide to match to the teeth. And when you do that, you will realize that not any tooth is same color like the other. And we need to learn that in today's aesthetic prosthetics, we have not even shades. We have a lot of options. We have many translucencies. We have many other effects in new materials. So it's not about a shade all the time. Yes, shade is one information, but we need to know something about the value, about the translucency, about opalescence and other effects. But there is even easier way with some equipment that does it for us. When we talk about the planning, when you say planning today, it means digital smile design. Okay, it's the way we did because it was very modern. But sometimes you don't have a time, and sometimes it's too expensive, regarding the time. So when the patient asks just, okay, I want new teeth, how it will look like, we can just use some simple softwares. Doesn't matter if it will be paid Photoshop or if it will be some cheaper version. We can do it very fast. And that's the point. If the patient during the consultation asks for some visualization, it needs to be immediately done. Not that I will do the picture and then I will spend the time with that instead of being with my family or with my hobbies or whatever. So it should be done in a few minutes. And we have a lot of options. Yes, this is made in Photoshop. Instead of Photoshop, I sometimes use GIMP, which is even on a portable version. But we have also another options, classical digital smile design, when you can send the scans, you can send pictures to the digital smile design center, and it can be done for you, even with the models, with the mock-up, with everything. But it's expensive. It's fine, it's beautiful to have it, but not for each client. Sometimes we need to really to treat the clients that way that we will save them the money and save them the time. So yes, this is one of those options, but we have even faster. Do you know AvoSmile? It's available for the iPad or iPhone. You can set up the teeth, you know, about the shape, shade, size, whatever, and then the patient can look at himself in the selfie camera immediately. So even by the movement, can see the new teeth. And that's it. Immediate motivational mock-up, let's say. And if we compare all those types, and then we talk with the client, usually we finish with completely different shape than it was planned. That's the other thing. We need to understand that what we see in the plan is not the same what the patient sees. You know, they want a huge white smile, that's it. But they don't see those differences in a macrostructure, microstructure of the teeth and other things. So it's more just to communicate and to get the information. What I really like is the mock-up, the printed mock-up. So if the patient has worn teeth like this one and comes for the consultation, we can do just the scan and say, okay, we can set up another appointment, maybe for the final treatment. Until that final treatment, we can prepare several types of shapes. And I like this. It's easy, it's fast, and doesn't matter if I will print 6 or 40 teeth, it will be in the printer at the same time. So we can choose, different kind of libraries or record our own libraries. We can even buy libraries from other colleagues. And it can be prepared for the patient without any other losing of time. So it will take only that time of designing this. And you see how quickly we are switching in between the shapes. And of course, we do even the articulation. So then finally, of course that the patient is surprised, because if the patient will come and you will offer to him several types of smiles immediately, it changes his life immediately, so he trusts you. Yeah, it's a lawyer, very famous lawyer, very stressed lawyer, as you see. But happy, and this is just the mock-up, without any prep. We just try that. And this is that patient where we need to be effective because he asked, okay, I have a time only on a Friday evening. So on a Friday evening, he will come and you will start with the prep. There's no time for another visit. Simple cases. I like those copyings, and this is where I explain even to dental technicians how to choose the proper material for creation of such restorations. Because with the CAD-CAM, we can easily copy the shape. So it's done. It doesn't take too much time. But now, thanks to CAD-CAM, we can measure the thickness of the material, so we can exactly choose the proper translucency of the material, because now we have very dark tooth prepared for the thick crown and very bright tooth prepared for the very thin veneer. And if you will choose completely the same material, you need to choose different cement. And you have to play with that to achieve the final aesthetics. But even this is just monolithic, no layering, it's just shading, glazing. It's enough. Of course it's not perfect, but this, there is no patient who can see that. You can see that, but not the patient. And what is more important, 1 hour, 47 minutes, the whole treatment from coming of the patient with a problem to payment. If you ask how much it costs, it depends which country. I like this movie, do you know it? We lost the sound maybe. Can you check it please? This is the movie where it's a science fiction, but they paid with their own time for everything. And if they didn't earn enough, they died. But truth is that today we are paying with our time. If you will calculate, what money you have to spend for something, I usually see behind that money the time I need to spend in my office. So then I think, isn't it better to rather to go somewhere and enjoy the life? Because we are paying with our time. So the time for me is the most expensive part of the whole calculation of each type of treatment. Time, not the material, not the equipment, but the time. We talked about the orthodontic treatment. Here is a patient who came. Here is a milk canine, permanent canine, second incisor missing. What to do with that? She came because she expected immediately to be treated with veneers. Yes, I can do that, but the preparation will be cruel. We did the scan and we planned the fixed orthodontic system, which is simplified just to the front region, and we treated this lady just in 4 months. After 4 months, she came, we just removed, we put it in a retainer, and did the preparation without extraction of that milk tooth. The root wasn't that long, but it was working. There was no problem. So we explained, okay, we can change the shape of the tooth. We will need to touch the gingiva also. And in time, this tooth will be extracted. We will put the implant, but we will treat just that one tooth. In time, you will have a problem. This is done already 8 years ago, and it works. So why to do that, what we call the over-treatment? It can be done very quickly and easily. And of course, quicker you do that, cheaper it can be. Another case, this one was very cheap, because when we saw this guy, and he was a student in that time, we realized, okay, this is a nice case where we can present all the digital plans and mock-ups and everything. And we offered him a big discount, huge discount, if he will be, available for all those pictures. So we have a lot of pictures by a checkup. And this was the first visit. This was the first time I saw him. He had some braces for 5 years. He didn't know why, but he had it. So we removed this and made a scan, just to have a chance, to plan something, to check everything. We did the scan with already prepared position of the bite. So we designed the new teeth according to the wished shape and size of the teeth. So this was the initial situation at the beginning. This is the scan and the plan in the 3D. And then we printed and milled different kind of mock-ups. And finally, he came and we immediately done everything. We just placed that white mock-up. I made it white. You know why? Because I wanted to push him to normal colors. I wanted to ask him, do you like it? No, it's too white. Okay, thank you. Because otherwise, everybody answers, if I will show B1 shade guide, they say, oh, it's yellow. So most of the teeth we do now is bleach 2, bleach 3. So in that time, I thought, okay, let's do it white. So he will rather step, backward to the normal shades. So during one visit, all the teeth, 12 in the upper and 14 in the lower were done. And again, we had a scan of the mock-up inside of the mouth, then the preparation. We tried, different designs. We milled it with different materials. because we wanted to show, all those options. I don't use zirconia for single crowns. I love zirconia, I use it, but I don't use it for single crowns. And I don't even use zirconia for abutments. I use lithium disilicate. You know why? Because it works, and I have a final aesthetics from the bone level. So I can support the gingiva with colored ceramic, with fluorescency, and with proper dentin color. So this is the final restoration. Everybody asks, and it doesn't fall? No. Adhesive dentistry works if we do it properly. Of course, if I say one day, this means really the whole day. There is no break for lunch. Actually, it's not only a day. You are finishing in the evening or night. So yeah, it's a whole day of treatment. But this is what I like, because you can focus just on one case, on one patient, and you can do it even more comfortable for the patient. And what's nice by this patient that we can see him after years. So we can see the movement of the teeth. We can see how the translucency changed a little, but also how papillas growth. So there were no defected papillas. There was just missing tooth structure, and we changed it with ceramics, and in 5 years it growed this way. So from my point of view, we did it wrong, because there was not enough space in the interdental places. Next time when you see this, you do the morphology of the contacts a little bit different to leave more space for that. Okay, but we have to articulate such cases. And believe me, articulation paper doesn't work. In 80% of articulation with the paper, it's wrong. And 20% is a good luck. So now we are digitizing even those contacts. We can measure those pressures. We can see the movements during the articulation, and we can treat such cases. This is a simple case because I did already the articulation in the software when we were doing the morphology. But usually where is the problem, and that's why I'm telling it here, is a combination of teeth and implants. Because everything in the mouth has some movement. Bone is moving, joint is moving, tooth is moving, not the implant. Actually, even the implant is moving a little. It's about 10 microns. So we can divide, let's say, the pressure separately on normal teeth or on the implants, and we have to see it differently. Today there is an option to import the STL data to that scanner, so we can see even exactly where are those contacts on the teeth, not only in that graph. And I will show you one of my very old cases just to see what happens if we just do the crowns on implants and we believe to the patient that everything is okay. This patient was in my office just because of the veneers after some orthodontic treatment, okay? And then I visited the orthodontist because of another client, and I saw this lady sitting in the waiting room. And I asked her, "Are you okay? Is everything fine?" And she told me, "Yes, everything's fine, but sometimes, especially in the morning when I wake up, I have a problem. I feel like there is something, some pressure in front." And when we checked with the paper, it was there, yeah. And now I can just repolish that contact and she will say, "Yeah, it's better." And I will be happy, she will be happy, but the problem is not solved. Because instead of that, we took the T-scan and we measured this, and this is a problem. 70% of contacts is on the right side, and we have one overloaded tooth. 31% is just on this contact. And where is it? Crown on implant. Because patient doesn't feel that. So we repolish that. Okay, first polishing. Just with the rubber polisher. And the result is better, but it's not solved. Okay, so we repolished even that premolar. And what happened? Okay, it's much better, but we see another problem. So after the third polishing, we found another contact, another crown on implant. Actually, just the composite in between, the crown and the screw. So we repolished that, and look, immediately bite was changed and released, and she didn't feel the front. We didn't touch that front incisor. And thanks to the digital articulation, we can see those things immediately. So we can treat bruxism in 15 minutes. If it's, let's say, easy case. Sometimes it needs more months. But usually, if there is a problem of 1, 2 teeth, it can be immediately treated. So what the digital dentistry brought us? For me, the first thing is efficiency. Time saving for anything you want. Of course, somebody sees, the time saving like, okay, I can do more work. Yes, I tried this at the beginning, and then I realized that I'm slowly dying. No, now I'm trying to save the time to be able to come to Seoul, for example. And of course, it's comfort for patients. They don't need to come several times. They have a lot of things treated immediately. Calls the patient, yeah, my tooth is broken. Okay, come, and it's solved. Bye, see you in 1 year. So another things that brought new methods, new materials, new options. Many years ago, I was asked to be a final speaker on a huge congress where were 1,200 people. And they asked me, you know what? You have to bring those people to the hall. Make something loud. And in that time, I wrote EMAX song because it was the lecture about the EMAX ceramic. I made the EMAX song. If you want to see it, it's on YouTube. Then, before COVID, I did another one. It was on a same congress in Budapest. And when I discussed, what to do for you, for Osstem, because I really like the company, and what I told to Chairman, I don't think Osstem is #1. I think the Osstem is the only one. There is no other company like that. So I thought, okay, you're coming second time to Seoul, make something that nobody will forget. So 2 days ago, I wrote the Osstem song. Actually, I wanted to prepare also the movie, the music clip. Okay, maybe next time. It wasn't enough time for that. I already started, so I can send you the working version. But now, yeah, it is the EMAX song 1. Finalization of the song was on the way from Prague to Seoul. First connecting flight was delayed, so I had a lot of time for that. So finally, I finished it, and please enjoy because I don't feel that strong to sing now, but you will hear me.
This is the first
Please make it loud.
song. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if there's bone, doesn't matter if there's not. Osstem's got some solution, Osstem's got all what you want. Osstem's got all what you want, Osstem's got all what you need. Osstem knows what's the blood clot, Osstem's never let you bleed. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if you're poor, doesn't matter if you're rich, doesn't matter if there's crown, doesn't matter if there's bridge, Doesn't matter if you're nice, doesn't matter if you're bad. Doesn't matter what's the reason for smiles, we screw it down and make you glad. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if in Seoul, doesn't matter if in Prague, doesn't matter if in Rome, doesn't matter if in Hague. Everybody wants to smile, everybody wants to bite. Osstem knows how to save you wild, Osstem knows how to make life bright. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow.
Very short crown. So many doctors ask about that teeth endodontic treated before, or how to attach it.
This is that biggest advantage of adhesive restorations, that the prep is very small and very quick, because we don't need to prep too much. We don't need to do endodontic treatment anytime. It's just about the proper shape and proper cementation, and that's why I don't need, or I don't use the zirconia, because you need to have etchable ceramic. So you need to have feldspathic, low side, or lithium disilicate. Even with all those new hybrids, it doesn't work. It doesn't work itself. So it needs to be bonded to that tooth, but then it really works. It doesn't matter doesn't matter.
Okay.
It doesn't matter what's the size of the tooth.
Okay, the one guy I have another question about vertical height. When you do the full mouth rehabilitation in one visit, he said, I'm not prosthodontist guy, so I don't understand, but he said
how much to increase it?
Yeah, he said, yeah.
This is a very often question. It's a most often question. You know what? I had to go, of course, through all those articulation theories. I have a lot of equipment, all those articulators, face bows and everything. And then I realized it's simpler than we think. If there is the problem only of those worn teeth, not the problem with the joint at the beginning, you need to set up the teeth into the aesthetic position. So you need to see the patient standing with normal look of the soft tissues with the closed mouth. So you have to set up the bite, but then leave the patient to close, because you will recognize if it's too much or if it's not. It's really the aesthetic way. And of course, if you're not sure, just take some composite, the cheapest flow composite you can get, and just build the first molars to the proper shape of the cusp. And you will see how much of enamel disappeared. So this can be roughly done, and the rest, we are humans, so we can adapt to many things. It's not that strict. It's not that strict like sometimes we read in the books.
Okay, thank you. 그러면 현장에서도 질문 하나 받아보겠습니다. Is there any question from the floor?
I got a question. When we can meet next time?
I'm not the owner of Osstem, sorry.
Because I like Osstem, you know, that much that really, it doesn't matter if it will be here or in Rome.
But actually, I'm very close with him.
Okay.
Yeah, I can tell him. Okay.
So thank you.
Yeah, but the last question, I just got the very important question. The song you showed, that song is written, the lyrics and the melody?
Yeah, I do.
Whole by yourself?
Actually, I do everything. That's why I need to save the time, you know, because, yeah, I have a lot of hobbies. This year, I recorded the first LP, because previously it was just the CD, but now it's not modern. So now we're back by the analog. I got a new LP. But soon I will transfer everything to the Spotify and Apple Music and all those, so you will find it. Actually, there is already my old work from 2001, and I wrote even the COVID song during one lockdown. So it's very depressive. It's very how to say that? You will feel like you can't breathe, really, when you will hear that.
I can say it is really addictive. Yeah, I can dream that song today.
Now, just try to find the COVID-19, and or maybe I will later send some QR code.
Okay, yeah, a really good lecture. I think you are the pioneer of the future dental clinic. So I hope, every dental clinic, as you showed, in the near future, every dentist do like you. So, 큰 박수 한번 부탁드리겠습니다.
Please give Dr. Haini a warm round of applause.
Thank you very much.
I'd like to thank Professor Lee Woo-gyu, who served as chair, and I would like to thank the two excellent speakers. And now, survey on satisfaction on lectures. We want to conduct a satisfaction survey on the passionate lectures delivered here at Osstem Meeting 2022. Text message of it will be sent to all on offline participants. If you click on the link in the text message and fill out the simple survey form, 200 people will receive chicken gift coupons and catch the luck by joining the survey.
Now we will begin the poster award ceremony. Up to October, 162 posters were received. We had received a lot of attention. 16 evaluators went through a lot of debate and evaluation to select 6 gold prize, 3 grand prize, and 1 master prize. The prizes will be given by President Choi Kyu-ok. Now let's invite President Choi Kyu-ok to the stage. First, the gold prize of the poster contest at 2022 Osstem Meeting, 500,000 won, an award will be given to the winners. A total of 6 people will be named. Please come up to the stage. I'll call names. Dr. Kang Hyun-mo of Yonsei Dental Clinic, Prosthodontic Department.
Dr. Yoon Si-won of Periodontic Department at Ide Mokdong Dental Hospital, and Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic, Dr. Yu Jae-young of Maxillofacial Department of Jeonnam University Hospital, Dr. Moon Soo-in of Prosthodontic Division at Kyunghee University Hospital, and Dr. Lee Hwa-sun of the Classic Dental Clinic. First, the award will be given to Dr. Kang Hyun-mo of Prosthodontics Division at Yonsei University Dental Hospital. Gold prize for the poster contest. Dr. Kang Hyun-mo of Prosthodontics Department at Yonsei Dental University Hospital. Based on your passion towards dentistry, you have demonstrated a wonderful clinical case. You have been chosen as the gold prize at 2022 Osstem meeting, Seoul, Korea. Osstem Implant President Choi Kyu-oh, please give him or her a warm round of applause. Next is Dr. Yoon Si-won of Periodontal Department at Ihwa Women's Mokdong Hospital. Poster Gold Award of Periodontal Department at Ihwa Women's Mokdong Hospital. It reads the same. Congratulations. Next is Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic. Gold prize of poster contest. Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic. It reads the same. Next, Dr. Yu Jae-young of Maxillofacial Department of Jeonnam University Hospital. Mr. Ryu was not able to visit. Gold prize for poster contest. Dr. Yu Jae-young, it reads the same. Dr. Moon Soo-in of Prosthodontics Division at Kyunghee University Hospital Dental Clinic. Gold prize for the poster contest. Gold prize, it reads the same. Next is Dr. Lee Hwa-sun of the Classic Dental Clinic. Poster Gold prize. Dr. Lee Hwa-sun, it reads the same. All winners have received the gold prize. Dr. Lee Hwa-sun will make a comment on behalf of all winners. Greetings. I am Dr. Lee Hwa-sun of the Classic Dental Clinic. I'm really honored to receive an award following my previous award last year. Osstem has really helped me investigate into matters of which I thought was whether it was possible or not. Osstem has provided a lot of innovative products. I'm really honored to receive this award and I will continue to push forward. We'll have a photo shoot for the winners. Please step forward to the stage. Congratulations once again. First award will be given to the winners. Along with 1 million won award will be given. A total of 3 people will receive this award. We are going to wait for the photo shoot for the gold prize winner.
Now we'll move on to the first prize winner. Please step forward. Dr. Hon Jun-tae of Yonshan Dental Clinic, Dr. Kim Jin-woo of Oral Maxillofacial Surgery at Ihwa Mokdong Women's Hospital, and Dr. Lee Eun-seok of Implant Dental Clinic.
So the chairman is invited to the center of the stage. First, to Dr. Jun Tae-hong from Yonshan Dental Office. First prize of poster, Dr. Jun Tae-hong. The certificate of merit is conferred to you for your excellent clinical case presentation, as it is selected to receive the first prize in 2022 Osstem meeting, Seoul, Korea, November 20th, 2022. Chairman Kyok-chae of Osstem Implant. Please give him a big round of applause. Next, Dr. Jin-woo Kim, Oral Maxillofacial Surgery of Ihwa Women's University Mokdong Hospital. He is absent today, so Dr. Jin-woo Kim, Ihwa Women's University Mokdong Hospital, and on behalf of the doctor, somebody else is receiving the prize. And next, Dr. Eun-seok Lee of Implant Dental Office. Poster first prize, Dr. Eun-seok Lee of Implant Dental Office. It reads the same. So congratulations to all three winners. I would like to invite Dr. Eun-seok Lee to give us what he's feeling after receiving the prize. Thank you very much for giving me the opportunity to make the presentation and for giving me this prize. And I would like to thank the judges who have been working all day from morning. And today, this is a quite rich Osstem meeting with a lot of Osstem products, and we have many foreign guests here. And Osstem is moving beyond the local market, and I hope Osstem Implant would become a worldwide K-implant company. And I would like to thank my mentor, Dr. Park, Dr. Ho, and others who have guided me to this position. So let's have a photo session of the poster grand prize winners. I mean, the first prize winners. First prize winners, congratulations again. Next, the best poster is selected for 2022 Osstem Meeting Poster Grand Prize. 2 million won and certificate of merit is to be conferred. Who is the winner of the grand prize? The winner is Dr. Hyun-min Lee, Periodontal Department of Chosun University Dental School. Please welcome him with a big round of applause.
Dr. Lee Hyun-min of Chosun Dental Hospital. Based on your passion for dentistry, you have demonstrated an outstanding clinical case at 2022 Osstem Meeting Seoul, Korea, and you have been awarded with the grand prize. November 20th, 2022, Chair of Osstem Implant, Choi Gyu-ok. Please give him a warm round of applause. I would like to hear a word from you. Greetings, I am periodontal department at the Joseon University Hospital. I would like to thank my mentor, Professor Lee, as well. I look forward to good products from Osstem. I will continue on providing good treatment to my patients. We will have a photo shoot session. We will have a photo shoot with Mr. Chigyook of Osstem Implant, the chairman. Congratulations once again. We will now conclude the poster award ceremony for 2022. I would like to congratulate all awardees once again, and I would also like to extend my gratitude to Chairman Chigyook for giving out awards. Digital Dental Technician Contest and Osstem Meeting 2022 Seoul have been with us following yesterday's event, and today we are towards the end of our wonderful ceremony. I wish it could last longer. In light of such feeling and sentiment, we have a fabulous event. I'm sure a lot of you have been waiting for this highlight event. Three winners will be given Galaxy Buds 2 Pro, 2 will win Galaxy Watch 5 Pro, and 1 person will win Galaxy Z Flip 4. Lucky draw will be done because a lot of people have 2875 in their phone number. We're going to go through lucky draw in the middle part of the cell phone number. If there are multiple, if there are overlapping numbers, another number will be drawn immediately. Let's start the lucky draw from the third prize. The third prize, Galaxy Buds 2 Pro. 461868. 461868. Next. 282339. 282339. Congratulations. You've been awarded with the third prize, Galaxy Buds 2 Pro. Third but not least, 474849. It's a unique number, 474849. Congratulations. Next is the second prize. You'll be able to win Galaxy Watch 5 Pro. Who will win this fabulous prize? Congratulations. 529049. 529049. Galaxy Watch Pro. The second winner. 529297. It's similar. 529297. You're the winner of Galaxy Watch 5 Pro. Now there's only the final grand prize. Who will win Galaxy Z Flip 4? 222620. Congratulations. You're the winner of Galaxy Z Flip 4. The first Digital Dental Technician Contest and Osstem Meeting 2022 Seoul, which has been continued for 2 days in November 19th and 20th, is now coming to an end. Osstem Meeting 2022 Seoul has continued to lead the development of digital dentistry along with other dental advancements in Korea and in overseas countries as well. I hope you have had meaningful lectures from prominent speakers at home and abroad. I'm sure you have learned about the live surgery. We will now have a award ceremony and offline lucky draw after the ending video. Stay with us till the end and perhaps you'll win. I'd like to thank once again for the chair, speakers, and the audience who are with us today. Now I will close this session. I'm announcer Kim Yoo-soo. Thank you for being with us. Now, award will be given to those who have dedicated hard for Osstem Meeting Seoul. First, we're going to introduce